morning, everyone. Please take your seat and be comfortable. We will be starting the session in next 10 minutes. Good morning, everyone. Please take your seats. We'll start the session in 5 minutes.
Namaste and a very good morning to the distinguished guests, speakers, delegates, my dear colleagues and one and all present here. Myself, Dr. Shabri Priya, Associate Consultant from Department of Histopathology, Apollo Hospitals, BG Road.
And myself, Dr. Anindita Ballav, Senior Registrar from Department of Microbiology, Apollo Hospitals, BG Road, have the honor of hosting this esteemed event. On behalf of the organizing committee, it is my pleasure to welcome you all to the pre-conference workshop of the 12th International Patient Safety Conference. As we come together today, we are embarking on an important journey towards enhancing safety in the laboratory environments.
Our workshop, Safety Sphere, Ensuring Excellence in Laboratory Safety, has been carefully designed to equip you with the knowledge and best practices to ensure safety in every aspect of a laboratory operation. Our workshop today is built around the belief that to get it right, we must make it safe. In this workshop, we will explore strategies, share insights, and discuss best practices aimed at fostering a culture of excellence in laboratory safety. We are thrilled to have you here today and look forward to engaging discussions and collaborative efforts that will help us all achieve safer and more effective laboratory environments. Thank you for being a part of this essential pre-conference workshop, and let's get started on ensuring excellence in laboratory safety.
It is a privilege to have with us today Dr. Manish Mattu, the Regional CEO, Karnataka and Central Region at Apollo Hospitals, BG Road, whose visionary leadership has been instrumental in elevating healthcare standards. Dr. Manish Mattu has been an integral part of the healthcare and patient safety community, known for his dedication, vision, and impactful contributions. We are honored by your presence, sir, and grateful for your unwavering support in making this workshop possible. As we begin with the proceedings, I would like to cordially invite Dr. Manish Mattu, sir, to join us in the lamp lighting ceremony. And I also request Dr. Rahini Sridhar, Chief of Medical Services, Apollo Group, Dr. Preetham Kavinahitlu, Joint Director, Clinical Administration, Apollo Hospitals, BG Road, Bangalore, Dr. Yatish Govindaya, Vice President and Unit Head, Apollo Hospitals, Jayanagar, Mr. Uday Dabda, Vice President and Unit Head, Apollo Hospitals, Sasatipuram, and Dr. Swarna Sibakumar, Lab Director and HOD, Department of Histopathology, Apollo Hospitals, BG Road, to join in the ceremony. Please. So much. On behalf of the organizing committee, I'd like to express my sincere gratitude to our esteemed dignitaries for gracing this occasion and inaugurating the event by lighting the lamp. After the lamp lighting ceremony, now I'd like to request Dr. Manish Mantu sir to kindly deliver the welcome address and officially inaugurate the pre-conference workshop session. Please.
Good morning, distinguished guests, speakers, delegates, and colleagues. It is my great honor and privilege to invite you all to the 12th International Patient Safety Conference pre-workshop on Safety Sphere Ensuring Excellence in Laboratory Safety. This exclusive event is specifically designed for senior leaders and key decision makers like yourself, individuals whose influence and expertise are vital in shaping the future of laboratory practices. Your presence today underscores the importance of lab safety in the broader context of patient care, and I'm excited to see how the insights and discussions today will inspire change in your organizations and also in the broader healthcare landscape of the country. Our agenda today is both comprehensive and thought-provoking, and it will address a wide array of issues today pertaining to lab safety and patient safety. From diagnostic stewardship and smart labs to the ongoing challenges and opportunities around AI lab reporting, we will be deep diving into many important and pertinent issues around lab services today. The workshop will also cover crucial subjects such as safe lab practices, sustainable approaches with go green, go efficient, and the importance of a zero harm approach in lab environments. We will explore emerging trends such as point of care testing and the role of ergonomics in creating safer, more efficient workplaces for lab professionals. A special highlight of today's workshop is a live debate on the potential of AI in lab reporting, a topic that is creating discussions around the globe, and we are excited to hear various perspectives on its benefits and the challenges. Additionally, we'll also engage in a panel discussion around the clinical laboratory as the unsung hero in patient safety, shedding light on an often overlooked role that labs play in safeguarding patient health. I would like to take this opportunity to extend a special note of thanks to our distinguished individuals, to some distinguished individuals who are, contributed to this event's success. Dr. Rohini Sridhar, Chief of Medical Services, Apollo Group of Hospitals. Your leadership and commitment to patient safety have been instrumental in shaping the direction of this workshop. Thank you, Dr. Rohini. I'd like to thank the lab heads of the whole region, particularly Dr. Swarna, Dr. Manjula, Dr. Jayashree, Dr. Geeta, for your contribution towards making this workshop a great success. I'd also like to thank the unit heads, the COOs of various hospitals in the region, the medical heads, and also the quality team, particularly Rekha, the branding, marketing, the entire team that's made this event possible. Thank you again, all of you, for being here. I look forward to a day of enriching conversations, new thoughts, new insights, and a collaborative effort towards ensuring the highest standards of lab safety. Thank you so much.
Sir, please be with us for a moment. Thank you so much, sir, for your inspiring and insightful words. Your words of encouragement and guidance will surely motivate us all to make this event a great success. Thank you once again, sir, for your valuable presence. Now I kindly request Dr. Jayashree Shivadasan, HOD Department of Microbiology, Apollo Hospitals, BG Road, to do the honor of presenting the memento to Dr. Manish Mantu as a token of our appreciation.
Now, as we continue with our program, we are pleased to move on to the first session of the day, titled Diagnostic Stewardship. This session is of paramount importance as it addresses the critical role of diagnostic practices in ensuring both patient safety and the accuracy of care. Diagnostic stewardship focuses on the appropriate and effective use of diagnostic testing with the ultimate goal of improving patient outcomes while minimizing unnecessary tests, reducing costs, and preventing diagnostic errors. And for this session, we are truly fortunate to have with us Dr. Rohini Sridhar, Chief of Medical Services, Apollo Group, as our speaker. She is an esteemed medical professional with specialized expertise in pathology and hematology. She is a trained pathologist at AIIMS New Delhi and completed her fellowship in hematology in Melbourne, Australia. Dr. Rohini Sridhar played a key role in establishing bone marrow transplant services at Apollo Cancer Hospital in Chennai and later led clinical protocols at Apollo Hospitals, Madurai, which became the first in the Apollo Group to achieve NABH accreditation. Her leadership drove Apollo Hospital, Madurai to win prestigious awards such as IMC Bajaj Award and Rajiv Gandhi National Quality Award. As a Senior Vice President of Medical Services at Apollo Hospitals Group, she leads clinical quality and governance initiatives to support the growth and success of the network. Without further ado, I invite Dr. Rohini Sridhar to take stage and share her valuable insights. Please join me in welcoming her.
Good morning, everyone. It's an absolute delight to be here at this session where we're talking about safe practices in the laboratory. It's been a while, actually, since I did anything lab-related. So it's a particular delight and an honor to be here. And I thank the entire Bangalore team, Dr. Manish, Rekha, Preetham, for giving me this opportunity to go back to my roots. And we shall see how well we fare. So what is diagnostic stewardship all about? I think one of the things which was touched upon both in that very kind introduction and in Dr. Manish's opening remarks is that we often forget when we are looking at clinical practice and clinical outcomes, the central role that the lab plays in ensuring that we deliver outcomes of the highest standards. And in many hospitals, we often see that there is this kind of lopsided development where the clinical services race ahead and the lab services are actually in a race to catch up with clinical advances. And there needs to be a balance here if we are to achieve what we all as clinicians and medical professionals, healthcare professionals want to do, which is the best for our patients. And want to place this whole concept of diagnostic stewardship, let's look at it from that perspective. So just to set the context, and 70% of all lab tests are potentially inappropriate. That's a startling number, very high number. So if you did 100, probably 70 of them are inappropriate, and we will discuss in a minute what this means. Also, to give you another point of looking at this, 4 to 12% of all healthcare costs are from lab testing. Now, this of course varies. As usual, most of this data is from the West, and maybe the numbers will vary a little bit in the Indian context, but we all realize as lab professionals and as astute clinicians that sometimes there is a big disconnect between what the patient needs, what we have actually asked for, and what are the results that come back to us, and what do we do with those results. So the whole purpose of diagnostic stewardship is to ensure that your testing is appropriate. So what do we mean when we say appropriate testing? And that takes us to the next slide. So one thing which is important, if you see the quotation from William Osler, is that there is a science of uncertainty and the art of probability. So if you are able to manage this uncertainty, and your testing is anchored in what is likely to be the probable outcome and what you will do with that outcome, then I think you will find that your testing becomes much more appropriate. So this is a definition for appropriate testing, which is actually from the College of American Pathologists. And it says effective for purpose. Effective for purpose means in that particular clinical context, in that particular clinical setting, which is the most appropriate test. And we will discuss a few examples going forward. So if you had a patient who came into the ER in one of your hospitals, and the ECG showed some changes which suggested an ST elevation MI, and then you needed a TROPI result, then I think that the key thing here is that you need a turnaround which happens within minutes. And so the test which you do for TROPI has to be anchored in that clinical need, which is that we need to get the results back quickly. And here the TROPI results will be a part of a plethora of data, not just from the lab, but from other sources as well, which will allow you to come to the diagnosis and move ahead with treatment. And so you can think of many ER situations in which time is of the essence. In some situations, the accuracy is of the essence. You need to be able to nail this down with a considerable degree of accuracy, because a lot of treatment decisions that you take are not really time bound, but are bound on the accuracy of the test that you do. So depending on the clinical context, the test that you select has to be effective for purpose. It needs to be clearly indicated, which means that if you get a result from that test, either positive or negative or low or high, you should be able to clearly articulate what is the action you're going to take. Again, if you go back to the MI example, easy, right? If TROPI is negative and the ECG is borderline, you'd probably repeat it an hour or two later and see what the result is and then go. So there is an action which is tied to the test. And this is very important because we tend to do tests and we really don't know what we're going to do with the results. So there are many new tests which come out which seem to offer us some data, but we are not able to move ahead with what should be the action. So we must have some action that is clearly linked to the test. And it needs to be delivered in the appropriate setting. We discussed this. Is it inpatient, outpatient? Are you doing some testing in the community? If you were, for example, doing cancer screening in the community, and you needed a turnaround of a pap smear, then probably you would have to look at a completely different technology from if you were doing it in the comfort of your outpatient clinic within the hospital. And as I already said, it needs to meet the timeline. So this is appropriate testing. And then this puts a very high bar on what are the tests that are on your menu and what are the tests that the clinicians are actually using. So this is a definition, and there are 2 or 3 important components in this. The first one is guidance. How is this guidance to be delivered? I think as lab professionals, it's important that we serve in an advisory capacity and in terms of guidance. Now, I'll tell you as a medical administrator, I have an opportunity to look across specialties. And even though we did learn some of this back in the days when we were MBBS, I think now we are completely out of touch, right? So when I listen to my colleagues from neurology or cardiology, or sometimes even from microbiology, which you really think, I don't know this, they're populating a different universe. So I just think of this as my clinical colleagues also in the same way. When we did microbiology, all you had was a Gram stain, an AFP stain, and a culture. Now you have BioFire and MALDI-TOF, and as a clinician who's been in practice, I don't know what this means. So are we giving them guidance which will allow them to select the appropriate test? And so that's guidance. What are the interventions that we can use to make sure that these diagnostics are utilized appropriately? And here there is a delicate tightrope to walk, because all of us who've been dealing with clinicians who are directly in contact with the patients, our role is very much one of advising and influencing rather than mandating. So I think what are the interventions that we can use to improve the use of diagnostics? And the key thing here, how do you guide therapeutic decisions, right? So the objectives of diagnostic stewardship are largely these: timely and accurate diagnosis, accurate prognosis and assessment of response, and cost efficiency. So you don't want to have somebody done a BioFire test and spent a lot of money, and then either you get results which are meaningless or results which you can't actually use. And today, where we stand as responsible clinicians, we find that there is a trust deficit. So every time you advise the patient something, even if you write out a prescription for a test, there is this big trust deficit. He's looking at you thinking, is this necessary? Should we do it? Or do they have some other motive which is not directly related to patient outcomes and patient management, which is driving them to advise investigations, right? So we operate in this world where every test that we ask, we should be able to defend that requisition of that test on purely scientific means, and therefore there is a big impact on both cost efficiency and utilization of resources. Are we able to utilize them appropriately? So when we are saying this cuts both ways. If you don't do the right test, you underdiagnose. So you should have done the TROPI. Why did you not do it? If the ECG was borderline, you should have done the TROPI. You didn't do the TROPI, and now you're in a situation where maybe you missed a window of opportunity to intervene. On the other side, you have overdiagnosis. And we know the problem, if it may be not related directly to the lab, but definitely if you take a person who has a mammographically proven lesion, we know that a large percentage, maybe as high as 20% of those lesions will be benign. But the minute you turn to the woman and say that there is a lesion in your breast, then there is a whole cascade that you unleash. She will probably have a biopsy. She'll go through so much of anxiety, worrying about it. So we know that overdiagnosis has problems as well. So it's not just underdiagnosis, it's overdiagnosis as well. So when I say overdiagnosis, we're usually talking about false positives. And so we need to ensure that the test that you use is appropriate in that clinical context, and so the test which needs to be done is done at the right patient at the right time. And this is what diagnostic stewardship is about. So it requires an alignment of these four elements, some of which lies in the purview of the lab professional, and some of it which lies in the purview of the clinician. So this is a fairly close coordination. So again, what does this entail? When we talk about diagnostic stewardship, it's not just this interface between the clinician and the lab. It is also internally what happens within the lab, because all of these components are important to ensure that the result that is given is appropriate and accurate. So I have taken this from the WHO manual on diagnostic stewardship, and this actually refers only to, they've done this in the context of AMR. So I modified this slightly to fit the general situation, but all of these are important. So let me sort of illustrate what I mean. We know very often that a simple thing as a sample not being collected correctly or accurately may result in a wrong diagnosis or a failure to diagnose anything at all. And if that is the situation, then that, again, going back to what comes to the patient, you might have ended up falsely excluding a diagnosis which should have been on the list. So all of these components are important. So it's not just about test selection, it's the rest of it, which includes sample collection, storage, transport, the turnaround times, test reporting, and interpretation. Increasingly, most labs have turned to the practice of putting an interpretive comment at the bottom of the report, which is good. And I think it is one of the interventions which can facilitate this collaboration or interaction with clinicians. But the flip side to that interpretive comment that we put is it's a cut-paste common comment in many situations. So every time you give a result, say of a thyroid function test, there's a standard disclaimer at the bottom. And I think that in putting a standard disclaimer at the bottom, often we don't provide contextual information. That is, for this report and for this patient, what is the comment? So I think the onus is on us when we put in interpretive comments to ensure that we contextualize it as much as possible and make it specifically related to the patient. Now the disclaimers have become longer than the report. So the report is just one number and the disclaimer or the interpretive comment is 1.5 pages. So I don't know, I think we're putting a burden on our clinical colleagues if our disclaimer is longer than the report. So I think we need to find a way to pick the pertinent comment to make. And this responsibility of putting a pertinent comment requires us to also have some understanding of the clinical context. So this is a responsibility that we need to carry. I think, again, I don't know because we did PATH many years ago, and at that time there was a very strong clinical leaning. I remember when we used to report histopathology, my professor used to tell me, first go see the patient and then come back and sit and report, right? So it was a very, very high bar. But we got an understanding of, if you see the patient, you know what the situation is and what is the implication of the diagnosis that you make. Today, when the disconnect between the clinicians and the lab is very large, and the lab is often located in a city which may be 1,000 kilometers from the patient or the clinician, I think we need to figure out a way to get this done. So let distance not defeat the purpose of the interpretive comment, and let us make sure that we have enough clinical context to collaborate with our colleagues. So whenever you look at the best labs in the country, there is a seamless blending between the clinicians and the laboratory professionals. We work as one team, and therefore we are able to add value because we understand what is the clinical question that they are trying to answer. And I think many of the people in the room will agree with me when I say that this is something that is vital to the process of diagnostic stewardship and should not be given up at all. So I just put it here to illustrate two concepts, and this is a very microbiology focused slide. So diagnostic stewardship requires the right test by the right patient at the right time. But antimicrobial stewardship requires the right interpretation, the right microbial, and the right time. So the common thing here is right time. Timing is everything. So if you do the culture after the antibiotic, the whole exercise is defeated. Having said that, most of the times we end up doing cultures after the antibiotic. So a simple thing to do is to, at least where restricted antibiotics are being used, can we at least ensure that the culture is taken or collected before the antibiotic is given. Simple step, but is the fundamental underpinning of an AMR program. And I think these little things are what actually make us capable of providing support to our clinical colleagues. So I have a couple of examples to share with you. I think this is respiratory virus season, right? And all these viruses are in the news. Human metapneumovirus more in the news than before for reasons that we can't understand, because I'm told by my clinical colleagues that it's been around for many years and we've never actually found too many cases. So the common ones are still influenza, parainfluenza, and RSV. But yes, human metapneumovirus has made it to the headlines. As you can see, it peaks around the time where we are, which is December, January, February. So the question is, should we test or should we not test? So let me just stop here and ask what people think. Should we test for metapneumovirus? If so, why should we test? And anybody wants to take a pot shot? So I'll tell you at the outset, because I don't think anybody needs to feel intimidated. I don't think there are any right answers. In most of these situations, we wait for government guidelines which say, please test these patients, don't test these patients. But again, it just goes to the crux of the whole diagnostic stewardship. Why would we want to test? Anybody wants to take a chance at why would we? Yeah, please go ahead. Yeah.
Microbiologist from Bangalore Medical College. So we understand that it's there for quite a number of years. It's not a new virus. And since it is not a new virus, we need to understand if there is a change in strain types, new strains have evolved, and whether the new strains are causing any important clinical disease.
Very good.
children or immunocompromised patients.
Thank you.
And also to rule in or rule out.
Correct.
That also have an implication. Because if we know it is human metapneumovirus, probably we don't have much to treat. But if it is influenza RSV, we have drugs to treat. So
Very
we
good.
need to have
So
a-
I think she summarized. So I think the key thing here is we don't have to test because we are worried about human metapneumovirus because it came in the newspaper and everybody seems to be talking about it for reasons that are not really clear. So there is a cohort, I'm sorry for this typo, but where these, when I say decision on hospitalization, that refers to the group which Dr. Shweta spoke about. So people who are in the high risk category, who are vulnerable and are likely to have severe complications from human metapneumovirus and may need hospitalization, definitely in that group you would like to use it, right? The other thing is that maybe, as she said, you might have drugs to use for the other viruses. So there may be drugs that you can use. So in that specific situation, if you're considering using it. The other thing which I feel a little uncomfortable, but I was forced to put it here, is appropriate antibiotic use. Anybody who has fever for maybe more than 48 hours and probably either takes an antibiotic themselves or goes to somebody who will give them an antibiotic, right? So if you're thinking that it's more likely to be viral than bacterial, then you could probably do away with doing giving them this antibiotic. And then, of course, if there is an outbreak or epidemic, it would be useful. So there are specific reasons why you would use it. I think we've covered some of this. And this will help us. Now, having decided to test, what is the test that you will use? So the reason I'm bringing it here, and so if you took the conventional route, not necessary for this, but I'm using this as an example to illustrate how much time you can save by doing a quick test, which gives you a result in an hour or so. So you can give them the result before they leave the OPD, if we are efficient enough to do it that way. And that may save a lot of anxiety, a lot of waiting, and an ability to analyze these patients properly. So that is the traditional testing methodology, and there are examples where if we use syndromic testing as our strategy, you might actually achieve improved patient management. So this is, again, this I have actually taken from the CDC guidelines on how do we incorporate rapid testing into our diagnostic armamentarium, and this illustrates the situations in which rapid testing would be important. And the reason I want to talk a minute about this is when we grew up, and I think of myself as an old-fashioned, conventional pathologist, rapid testing was generally considered to be not so good, actually considered to be bad. So we have gone through the times when CART tests used to give you a sensitivity and specificity of about 70-odd%. I don't know, Jayashree, you might remember. Now I know we are all sitting at about 98%, but we have lived through that generation where CART testing was done if you were not a very good lab, and you would have to counsel the clinicians that this is not a great test, please wait till I can put it on my system and give you a report. We've come a long way from then, but still I think it's important that there should be a judicious approach to selecting which point of care test you will use and how will you exercise control on which test is used, why it is used, and what are the outcomes that will happen from that. So this is another case study. This is a little bit more clinical and a little bit more at my area. And so again, I would love to have any comments from the audience. So this is a 28-year-old lecturer who presented to ER with numbness and weakness of the left side of the body and slurring of speech of 3 hours duration. She had earlier gone to a nearby nursing home, but she was diagnosed to have stroke, given heparin and antiplatelets, and referred to the hospital for further management. So what lab investigations are appropriate in the clinical context when you did a CT brain and it establishes ischemic stroke? So this is a patient, young patient with stroke. Anybody wants to take a shot on lab investigations appropriate in this context? Again, no right or wrong answers. Platelet resistance, that's a clinician's answer. I will come to platelet resistance in a bit. Anything else? What would you do with a young stroke? Sorry? Thrombophilia profile, excellent. Anything else? What would you get? What are you expecting to get? Yeah, but I mean the history, of course, it's not comprehensive. It's very unusual for a patient with meningitis to present with stroke, if at all it was meningitis, very unusual. This is a fairly short history, right? 3 hours history, presenting essentially as classic stroke. Right, so I want to draw this because the answers which came are what we normally do. My instinct would be, as someone in the audience said, yes, my instinct would be, let's go with thrombophilia, workup, right? This is what we need to do. So let's look at what the literature shows. If you take ischemic stroke, there are broadly 2 categories, but these are the common reasons. I'll leave patent foramen ovale for now. But it's either large vessel atherosclerosis, cardioembolic, dissection, arterial thrombosis, or venous thrombosis. In this etiological mix, which more or less covers stroke in young adults, there are some differences in stroke happening over 50 years of age. In those with over 50 years of age, large vessel atherosclerosis is the big bucket. In case of young adults, that is below 45, you will find that large vessel atherosclerosis probably only about 15-20%. But venous thrombosis, which is where the thrombophilia workup comes in, venous thrombosis contributes only 0.5 to 1%. So if the incidence of venous thrombosis causing stroke is very little and most of the causes are arterial, then what investigation would be appropriate? Correct, I agree, but we kept it to lab. I take it, because cardioembolic stroke, you're absolutely right, remains among the higher causes of stroke in the young adult. But since we said lab investigations, would people want to take a shot? Sorry? Yes, I'm coming to that. I'm coming to that. I will come to that. I put it there to discuss another point. But since we are now thinking this is arterial stroke, vasculitis panel, right? That's a good choice. And then probably we'll come to a thrombophilia, and I'll discuss about this. I specifically want to discuss a little bit about thrombophilia. Now, this is the article that was presented in Stroke. It's an old article, but stands true today. Testing for inherited thrombophilias in arterial stroke. Does it do more harm than good? So 2 things I want to make sure here. That what happens that with thrombophilias, the chances of them getting an arterial occlusion are relatively small. It's only in venous strokes that thrombophilia testing becomes relevant. I'll come to that point which somebody raised. So they have actually given the literature which shows that the versus controls, if you can see, thrombophilia testing in patients with arterial stroke, if you compare those in cases, is 7.9%. I'm sorry, the pointer doesn't seem to work. Whereas in identified controls, it's 8.9%. Let me just take that, which means if you did thrombophilias testing in a patient with arterial stroke, right, your chances of finding a positive result are probably lower than in a control who never had a stroke at all. Point to keep in mind. Right, so what happens now? In a person, in a 28-year-old lady who's presented with an ischemic arterial stroke, you have done testing for thrombophilia, and you have diagnosed thrombophilia when this lady has remained asymptomatic for 23 years. And she probably has something else happening on the arterial side, which could be vasculitis, and there are a bunch of vasculitis and vasculopathies like Moya disease and all the rare ones that we need not talk about. My point here was that look at the history. When you're getting ischemic arterial stroke, you need to be very careful about what is the testing that you're going to do. So among the thrombophilic disorders, the one that is most likely to cause arterial stroke is actually antiphospholipid antibody syndrome or lupus anticoagulant syndrome against the background of SLE. And among the thrombophilic disorders, the one that is most likely to cause an arterial stroke is a protein S deficiency, which we know is very rare and is a weak thrombotic risk factor. So situation 2, now you're seeing cerebral venous thrombosis. And now we get to the question of cerebral venous thrombosis as a cause of stroke. It's venous thrombosis. Now we are feeling a little bit more confidence to do thrombophilia testing. Agreed? Of course, we have the problem that patient took heparin, and we will discuss that. But now we are feeling, yeah, it's cerebral, it's venous thrombosis, right? Let's do thrombophilic disorder. What does the American Society of Hematology say in their guidelines? In patients with cerebral venous thrombosis who have completed primary short-term treatment, the panel suggests testing for thrombophilia only if anticoagulation would be discontinued. This is the recommendation. So if it is an unusual site thrombosis and you are prepared to anticoagulate this patient lifelong, then the purpose or role of thrombophilia testing is questionable, because the chances of recurrent VTE in the two groups is minimal between 18 and 14. So the point that I'm trying to illustrate here is you need a complete understanding of the clinical scenario for us to decide whether this testing is appropriate or not. I'll just do one more scenario and then come back to this. So even in a patient presenting with cerebral venous thrombosis, you are really not likely to gain much by doing thrombophilia testing. The third situation is the most extreme, where you have a patient who's been diagnosed with cerebral venous thrombosis and has a history of DVT 3 years ago. Now 100% testing, right? Now we pick up the problem which Madam referred to. Patient has already got heparin, right? And I have a problem with people who give heparin before collecting the sample. So that's something that we will park for the clinicians in the audience. What do people think now that the patient has got heparin? What should have been done and what have we done? What would be your testing strategy? What would you recommend for testing strategy? So let me highlight these 2 points. The first one is that in most situations, in an acute thrombotic phase, that is within 6 to 12 weeks of a thrombosis, all the factors will be abnormally low. So it's best, if you can, to defer testing for at least 6 to 12 weeks. It's not a good idea to test in the acute thrombotic phase 1. Second, if you're doing heparin, definitely antithrombin 3 cannot be done, but you still have the opportunity to do the DNA-based test. So this is an example of how a complete understanding of the clinical scenario is required for us to be able to contribute, participate, collaborate with our clinicians. So having used these 2 illustrative examples, I will just come to the conclusions and the future directions. So we've talked a bit about the importance of diagnostic stewardship, which are the correct tests for clinical decision making, which is where our focus should be. This is an important opportunity to collaborate, for collaboration among professionals. We should also work with them to address diagnostic challenges. I think I didn't, maybe for shortage of time, could have taken up a case in which there is a diagnostic challenge. The classic diagnostic challenge being patient in hospital with fever for 5 days, no diagnosis, or, with a stroke. And we didn't make that point, we didn't have time. But about 30 to 40% of young strokes, the etiology is never known. So we should work closely with colleagues in trying to address these diagnostic challenges. And by achieving all of these 4 points, I think we will work together to improve patient outcomes. Thank you.
Thank you, ma'am, for such a thought-provoking presentation on diagnostic stewardship. We are truly honored to have your presence here today. As a token of our gratitude and appreciation, I kindly request Dr. Geeta, HOD Transfusion Medicine, Apollo Hospitals, BG Road, to do the honor of presenting memento to Dr. Rohini Sridhar, ma'am. Thank you once again, ma'am. Your comprehensive insights have truly enlightened the importance of optimizing diagnostic processes, reducing unnecessary testing, and improving patient outcomes. The practical strategies and real-world examples you shared will undoubtedly help us rethink our approach to diagnostics and its crucial role in enhancing healthcare quality. And now, moving forward, it's my pleasure to introduce our next speaker, Dr. Sujay Prasad, who will be presenting on the topic, Rise of Smart Labs to Ensure Patient Safety. Dr. Sujay Prasad is a renowned pathologist, currently serving as the Chief Medical Director at Newburgh Onum Diagnostics. He brings with him a diverse skill set that spans across small process automation, laboratory automation, liver pathology, and information technology, among other areas. With extensive experience in laboratory management and clinical services, Dr. Sujay Prasad continues to make significant contributions to the field of diagnostics. He is also a certified lead assessor of NABL accreditation and has conducted assessments overseas. Today, Dr. Sujay Prasad will provide us with an in-depth understanding of how these advancements are reshaping the future of laboratory medicine and patient care. We are honored to have him with us today to share his expertise. Please join me in welcoming Dr. Sujay Prasad, sir, to the stage.
Thank you very much for the kind introduction. It's such a pleasure to be here, not because I'm standing here and talking, more because I have an opportunity to listen to amazing talks like by Dr. Rohini. She gave such clarity in her perspective. I think all of us have take-home message that we have. So thank you, Dr. Swarna, for this opportunity. When you mentioned the topic, the nature of the mind is such that it starts thinking. Whether you like it or not, it starts thinking. And when it starts thinking, it becomes very turbulent. So I had to kind of let go and say, okay, what am I going to talk on smart labs? So many things came to my mind when I thought about smart lab, and particularly relating to patient safety. And over the next for the next 30 minutes, I thought I'll share with you some kind of an introduction to smart lab and what's my perspective of the smart lab. And then how are labs evolving to be smart? And then share some experience and then probably summarize. You can have an acronym for SMART. Scalable systems. Obviously, every lab has to consider scale as an opportunity because the number of samples, the requirement for laboratory testing is increasing. So the lab has to consider scalability as certainly an option. For me, machine learning is huge. How we use it is very important. Automated processes primarily to replace mundane, repetitive work, which takes away the attention of the human and provide the human with a more specific task to be done. Real-time insights is something amazing, I can tell you that. How do you act on something right now if you do not have that insight? And finally, technologically integrated. And that's the evolution of smart lab. So what I did was, I don't know how many of you, I'm sure everyone in this audience will use ChatGPT. Anybody not using ChatGPT? Okay. So I also did the same thing. I asked ChatGPT, can you tell me the lab of the future? And this is what it showed. I said, okay. Anything wrong with this? Only human? No human. Only on the human side, anything else? Very good. No samples. Anything else? No instruments. The only thing that is here is data visualization. But where is the data coming from? It has to come from samples, it has to come from humans, it has to come from instruments, isn't it? So I asked it, ChatGPT, to be practical. And this is what it gave me. So I said, there were no humans, how can it be? So it gave me a picture. So I didn't do any of this. I just asked ChatGPT to give me, and it uses DAL-E to do that. So what's wrong with this? There's a lot of data visualization, agreed. There are humans. So obviously it realized, oh, I'm looking for humans to be in the picture, so it gave humans. There are no samples, and there are no instruments. Correct? So I asked it to be more specific, and this is what it gave. And now there are some samples, but those samples look like plants. So there's data visualization, there is humans, then there is samples, but there are no instruments. So then I asked it to be more specific, and this is what it gave, a lot of samples. One human whose hand is translocated. Because if you look at the picture, how can that person have a hand writing the other way around? So AI is still AI. It's not NI. So then I asked it to be absolutely, tell me what it is. And this is what it gave me. This is lab of the past. You have no data, visualization. You have a lot of samples. You have a lot of humans and a lot of instruments. So it's a play of these four that we have seen through the decades, isn't it? Up to 2000, we had a lot of humans. Then we had reasonable instruments. Then we had to handle lesser samples compared to what we are handling today. And we had very little data. And that data was used primarily for giving a report. And this is, even today we do that. Let's see what happened after 2000 and 2010. The number of humans remained the same relatively, but the instruments went up, the samples went up, and the data also started to go up, primarily because instruments and samples started to go up. But in 2025, the data has gone through the roof. Not that it has happened new, it is always through the roof, but it's just that we are starting to recognize data as another instrument. Instrument for what? In fact, data is all around us, and we have not even recognized it. So the smartness probably lies in how we handle these four activities. And I think more than handling these four activities, my favorite topic is that of how do we handle errors related to these four activities. Because as I'll tell you in a couple of slides, errors are directly related to safety and quality. So now, I think there's a lot of activity that we need to do around data. There's very little we have to do with humans because human behavioral change is a task. And that is a completely, but we can use a lot of data to see how we can change the behavior of humans. And that's what I will share one example with you. So we have a huge opportunity to reduce errors with better data management. And that data relates to all the other three aspects, what we discussed. So, for me, the smartness is to be aware of the existence of errors, because if you're not aware of existence of errors, then we are missing the entire opportunity there. To accept that errors are a daily phenomenon. We can't run away from it. In fact, the classic definition of quality is absence of errors. And when I understood this in 2001, I said, wow, by 2005 we'll be perfect. It's 2025 and we have 45 errors every day. So we can't get, it's part of the journey. Let's accept that. But what do we do about those errors matters. To identify errors when they happen, to record errors when they are identified, to do a good root cause analysis. I can tell you root cause analysis is an art and science in itself. To become aware of tools available for corrective action and preventive action, and finally to ensure we have a proper monitoring mechanism. So there's a very nice article last year which came out, and they're talking about using data to review 600 voluntary incident reports concerning diagnostic errors. And clearly says that diagnostic errors are also internationally considered to be a major patient safety problem, and that even we would be going through that. My question is, are we recording them? Are we identifying them as procedural errors leading to diagnostic errors? So smartness is primarily to reduce process errors and thereby reduce diagnostic errors. So the question is, why smart clinical labs? And for me, it comes back to errors, because errors are directly related to safety and quality. Because if errors go up, quality and safety go down. And what should we focus on? Errors. So if we focus on errors, automatically the errors will start coming down, and it's like magic that quality and safety start to go up. So the smart is in handling the errors and bring it down. And that's where I would like to share some experience in this context on rise of smart labs. And these are the 6 experiences that I would like to share, and I'll keep a watch on my time. I've shared this experience with pregnancy test in most of my talks. And for me, it's a classic, it was a prototype. And this is what happened. We made a blunder reporting pregnancy test. Pregnancy test is a very simple test. Do you agree? And things can go horribly wrong with that. So it was sometime in 2005 that I got a call from a lady. She said, "Doc, you have given a report of my pregnancy test as negative. I have done it at home. It is positive. What do you want me to do?" I said, "Please don't do anything," because I realized even then it was a potential medico-legal challenge. So I said, "Please don't do anything. I'll send my person. We'll do a repeat." And as I keep the phone down, my staff comes running. She says, "Sir, I've done a blunder." I said, "What happened?" She said, "No, I tested it. It is positive, but while entering in the register, I put it as negative." I said, "That's okay. What's the procedure in the lab?" 2 people have to see it. So she has done the test in the first floor, and the supervisor is in the 3rd floor. So she's taken the register to the 3rd floor. And in the 3rd floor, the supervisor has seen this lady. She's a very diligent worker. She's a very good worker. He sees her, he looks at the register, countersigns negative, and when 2 people sign out negative, I sign off the report. Is there anything wrong here? So is this a human problem or a system problem? How many of you think it's a human problem? Please raise your hands. And how many of you think it's a system problem? 50-50%, okay. That's a good, invariably I get this response. So the procedure followed in the lab is this, what I told you. and this is, I had to ask this question at this slide, but anyway, I would think it's a system problem, correct? Because the system allowed the error to happen because verification of the visual indication was not possible in wherever the supervisor was. So what we did was, we kind of this is an Epson camera, document camera. We attached that to the LIS, and I called my staff. I said, we have done a blunder. Please help me avoid these errors in the future. And I was focusing only on the pregnancy test. And the staff said, sir, we can do it for whatever manual assay that they were talking about, blood grouping or cultures or any of those. So that's now, we have a kind of a USB camera that captures the devices. So this is typically how we used to do it, isn't it? We would look at the card, and only the person who's seen the card has it in the mind what it looks like. But now what we are trying to do is, we are trying to capture and provide it in the LIS so that the human anywhere in the world can see that and verify the result and conclude. And I would think this is a lot of informatics. This is generating a lot of data, but more importantly, analyzing the data and using it in practice makes a lot more sense. So my staff started to capture everything, whether it's the card or blood group, tube agglutination, again cards or slide agglutination, culture plates. So we have a large database of annotated images, because when we started in 2005, I never thought at some point in time in the future we would ever be using these images. But that's where we have a huge opportunity to drive efficiency through data. So what we did was we kind of associated with RNSIT, Professor Srinivas and Dr. Sampada. And can we do image analytics on the images that we have annotated? So we took out data, anonymized the images as well as the annotation, because we have the image and we know what we have called it. And then they started doing their work. This is what I like about team effort. Completely engineering, data science, robotics, taking data and trying to answer the questions that we have. And the question we had was, can you look at the image and tell me if it's positive or negative? And if you can tell me if it's positive or negative, I can interface the results into the LIS. I don't need the human to enter whether it's negative or positive, because that risk is always there, that the image is still showing positive, but I'm entering negative in the LIS. So they went through their own amazing science of, I don't know, classification and many things. I don't even have the words, but these are the slides I got. I don't know what they mean, but I just thought I'll show it to you that they have done a whole lot of things to finally validate it and kind of, so this is the output. They have a portal where you just upload the image, it gives a result, and the output of the result can be interfaced. So the verification of the test result is system-based. It's no longer human. Because if the human's attention is not there when he's entering in the register or the LIS, it's going to be an error. The good part is when so the starting point is to take a good image. And the confidence for the technology starts from there, because he has to take the image properly. Ever since 2005, we have not faced an error with pregnancy test. But that doesn't mean you have not faced errors in other areas of activity. I'll move on to the next one. How many of you are not using barcodes to label your samples? Please raise your hands. Great. That's the reason I did not put barcode as a smart solution, because it's a necessity today. But in 2001, when we introduced barcodes, it was fancy. It was fancy because the practice was writing numbers on tubes. And I'm hoping, yeah. So I wanted to show those slides as well, but we used to make blunders in writing numbers. And 6 would look like 8, and 4 would look like 9. All kinds of stuff has happened. So barcode eliminated all those errors. And at that time, we were handling about 150, 200 samples in a day. But today, if you're handling 4,000 samples, the errors started to happen at the phlebotomy area where there were delays and missed tubes. So what we did was we brought a tube labeler and connected to the LIS. What does the tube labeler do? It has input bins for empty tubes. And when it gets a instruction from the laboratory information system, it prints all the tubes necessary and gives it to the phlebotomist. And the phlebotomist is able to take the tube and do it. The good part is we can include, you don't need a tube labeler, but you can include order of draw in the barcode itself. So that's one step easier for the phlebotomist. From then on, I'll go to scorecard for monitoring performance in accessioning. How many of you know that there are many errors happening in accessioning? Please raise your hands. Thank you. So the preamble is accessioning is a key performance area in the clinical lab, and many things can go wrong in this. Though system-driven processes are enforced, human intervention is unavoidable, isn't it? It's unlike the future lab where everything is done through the robots, but we are still right now having human intervention there. While system-based errors can be fixed, human errors can only be identified and minimized through behavioral modifications. Do you agree? You can't. So 70% of the errors in the lab are system-based, 30% are human-based. Of the 30% human-based, most of it is attitude-related, and that's a challenge. So what we did was we attempted to change behavior through scorecard. And twofold. One is to appreciate and motivate staff doing good work. When you have a scorecard, you automatically know that you're doing a good job. But it also provides and identifies for improvement for those who are making repeated errors. And that's where we kind of looked at the accessioning process. There are a whole lot of steps, but I only took one step of registration where you have all of these to be registered, correct? And when we started to look at these, it's not that the human is trying to enter that I made an error in the name, I made an error in the gender. Any update in the LIS, demographic updates are considered to be an error. Whatever we do, we should do it right the first time. If it's modified, then there's a problem. So we took the data from our LIS on how many modifications were done of the number of registrations, and we got an update. And we could categorize that according to the staff who have done those. And we could give them a report on month-wise how their error rates were. What did this do? This kind of makes them sit up and take notice about the kind of errors that they do. And behavioral modification automatically happens. It's like CGM, continuous glucose monitoring. You put a patch, your behavior of your eating changes because you know when you eat something, your spike happens. So you start avoiding that. This is what leads to behavioral modification. And this is real-time kind of insights. With that, I'll go on to critical alert manager. This has always been a struggle for us and continues to be a struggle in spite of this application. It's the lab's responsibility to call out critical alerts. And it's so complicated because who is going to call, what time, how much time do you give as a benchmark, which tests are included for critical alert. All of those are data management. If you allow a human to do it, one person will do it great, the other person, you can't blame the person because the other person has so many other things that he would miss something out. So the current system includes manual and automated processes, and the challenges include identifying the test for critical call-out, defining criteria for call-out, and information management around call-out, who, when, what, where, why. This is going to be a challenge because when we started to look at this, we realized that it has to get so granular. Just taking the example of creatinine, nephrologists would never want to be called for 4.5, isn't it? But a general physician wants to be called even at 3. So how do you set critical calls for specific to the requirement? So if I log in with my registration, I would start to know what the critical ranges we are going to set, and then we have a place where we have all the information. What is the minimum value set? What's the maximum value set? What's the critical alert? Who's going to call? What is the probable outcome? All of those we start to capture. Because when we capture this, we can have something like this, a dashboard which comes out of Power BI. I don't know how many of you use Power BI. Power BI is a data visualization tool, not as fancy as the one that we saw in the lab of the future, but good enough to get insights from a dashboard like this. This dashboard is only telling you what is happening, but it is not telling you why it is happening. That's diagnostic analytics. That will come in the future. Even now, many organizations are doing diagnostic analytics, but descriptive analytics is what this is. It's just showing what is in terms of data. With that, I'll go on to QC analysis. We'll do a lot of QCs. My question is, do you have a snapshot of understanding how many QCs runs have you done in the organization as a whole? And in that, how many are outliers? Because the purpose of QC is to identify the outliers, not to tell that 99% is QC is fine. I want to know what is the failure rate. QC fails of 289 out of 57,301 runs in a period of 27 days. So I want to understand what this is. And that's where data helps. And asking the right question. I want to know which test is the most common top 3 tests. Because if I address the top 3 tests, it gives me an opportunity to handle those 3 tests. Here I get to know it's gamma GT, total protein, alkaline phosphatase. 173 out of the 289 is already covered. All I have to do is pay attention to those 3 tests. But I also want to know what equipment, top 3 equipments are affected. I have that information. 242 out of the 289 I already have. Probably one instrument in Davangere is troubling us more than the others. I also want to know which location is getting affected. So if you start to capture data, your ability to use the data to answer many questions starts to come. And this is what I say, insights providing you the understanding to take corrective action. So information converted to knowledge, converted to wisdom. There's no point having knowledge of the errors if you can't do anything about it. Taking action on the errors is wisdom. Finally, I'll take you through a tool that we have in our LIS to look for beta thalassemia or iron deficiency. It's a common problem, but we have used machine learning in this case. And I'm eagerly looking forward to the debate. I think Dr. Renu and Dr. Anita are going to debate on AI, whether it's going to be a boon or a bane. So what we asked ourselves is there a unique pattern in CBC, particularly RBC parameters, that indicates an abnormality? And this abnormality could be anything, could be a thalassemia, low 8, hemoglobin E disease, HD, whatever. We just asked this crazy question. Then we started to realize that there are many limitations, and we use this annotation to begin with. And then we started to we have a data science team in-house of 4 people. Ms. Suma has left right now for her own reasons, but she was the one who drove this entire project. We came out with this class to be looked at as an outcome, and they did a whole lot of work. This is a 2-year or 2.5 years effort. And this is what I wanted to share with you. So in the screen that our doctors are looking at, they get the prediction probability score of possible iron deficiency or thalassemia. So they use that information. So it's an assist to the pathologist to decide whether they agree with it or not. So if they agree with it, they have to put in their remarks here, and then it learns from that again. So we have the prediction as an assist to the pathologist. So then we went through the concordance and discordance of this tool providing that kind of information. And the aha moment came when this gentleman has been coming to us regularly for health checks. And there's been a drop in hemoglobin of 1 gram from the last reading. Now, when this happens, I'm a bit concerned in an elderly because is there an occult bleed? Is there a need to do a bone marrow? A whole lot of things, endoscopies and all of those come into picture. But my pathologist told me it had just been introduced, the machine learning, and he said, sir, this algorithm is telling there's a probability of beta thal. So we did electrophoresis, which is not part of the health check. We did a hemoglobin electrophoresis, and A2 was 4.2. So this person was beta thal trait, which we had not picked up over the last 6 years. So again, there's information. I can tell you, everyone in this room is sitting on a sea of information. We probably know a little bit of it, and we try to understand a little bit of it. But try to see as much of data as possible and ask the questions that data alone will not give you the insight. You have to have the question. And it's our prerogative, I think it's our duty to ask the right question. And then we will have data to give us the answers. So this is just a tip of the iceberg because there's data so much below the surface that we are not even used it. So we are looking at LFT patterns, non-conformance recording, sigma metric, sample archiving, sample sorting, and document control. All of them, we are trying to see how we use data and try to do smart things. So just to conclude, labs will need to become smart to survive or thrive. And I don't like the word survival. Labs will need to be smart to thrive, not to survive. Right now we are surviving. So let's start using data to thrive. Smartness is not only for looks, but serving customers without errors, because that's the definition of good quality and safety. Errors in process will lead to innovation and automation. Now I say this because there's a lot of things happening in between, because if you don't handle errors the way it needs to be, then very unlikely that innovation and automation will come. We have to accept errors and analyze errors. That's when it gives us ideas. Safety and quality is inversely related to errors and risk, and I've shown you this. Identifying errors in lab process is often the starting point. For me, it was the starting point. If somebody told me you have to increase your quality, I said, I'm doing my best, what do you want me to do? But if somebody had asked me how many errors are there in the month of November or December, now here is an opportunity. Because when you start analyzing those errors, out of the 100 errors, top 3 errors gives you an idea where to put our finger. A good root cause analysis will provide necessary insights to reduce errors. With that, I will thank you and for a patient hearing and look forward to questions. If we have time.
Thank you so much, sir. Your session on the rise of smart labs has truly illuminated the pivotal role of technology in transforming laboratory medicine to enhance efficiency, accuracy, and most importantly, patient safety. As a token of our gratitude and appreciation, we kindly request Dr. Manjula, HOD Hematology, Apollo Hospitals, BG Road, to do the honor of presenting memento to Dr. Sujay Prasad.
Thank you very much. Thank you. I'll just take. Thank you.
Thank you so much again, sir. We deeply appreciate your time and expertise in shedding light on this vital aspect of healthcare innovation. We will now take a 15 minutes tea break. Tea and refreshments are available outside this hall. Please return to your seats by 11:15 a.m. so that we can continue our next session on time. Thank you.
Testing check. Check. Hello. Check. Check. Hello. Check.
ಚೆಕ್. ಹಲೋ ಚೆಕ್. ಹಲೋ ಇರಪ್ಪ ನೀನು ಕಾಲರ್ ಮೇಕಲ್ ಚೆಕ್ ಮಾಡಪ್ಪ.
Hello. Check. ನೋಡಪ್ಪ. ಹಾ. Check. Check. Hello. Check. 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 Hello. Check. Check. One. Check. 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 Hello. Check. 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 ಹಾ. ಕರೆಕ್ಟ್ ಆಯ್ತಾ? ಹಲೋ. Check. Check. Hello, check, check, check. Check, check. Hello. Hello, hello. ಆ ಕಡೆ ಕಡಿಮೆ ಆಯ್ತಲ್ಲ ಅರೇಮ. ಹಲೋ ಹಲೋ ಹಲೋ. ಚೆಕ್ ಚೆಕ್ 1 2. ಚೆಕ್. ಹಲೋ ಚೆಕ್ ಚೆಕ್. ಆ ಮೇನ್ ವಾಶಿಂದ ಕೊಡೋದು ಕಣಪ್ಪ ನಿನಗೆ ವಾಲ್ಯೂಮ. ಲೆಫ್ಟ್ ರೈಟ್ ಅಲ್ಲ, ಕಿತ್ಕೊಂಡು ಹೋದ ತವೇಗ. Check, check. Hello, 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 hello.
We kindly request everyone to sit down. Welcome back, everyone. Please take your seats. We now move on to an exciting session, a debate on AI in lab reporting, boon or bane. There is a little change in the program. Instead of Dr. Anita Mahadevan, we will be having Dr. Nandis with us today. So, artificial intelligence is transforming many aspects of healthcare, and laboratory diagnostics is no exception. From improving efficiency and accuracy to potentially replacing traditional workflows, AI is both a promise and a challenge. Is AI a game-changing tool that enhances precision and saves time, or could it pose risks such as over-reliance and errors? This debate will explore both sides of the discussion and offer valuable insights into the future of AI in lab reporting. Arguing in favor of AI in lab reporting, we have Dr. Renu Ethirajan. Dr. Ethirajan is currently serving as the Chief Medical Evangelist at SIGTUPL, where she is actively involved in the development of healthcare solutions on an artificial intelligence platform. She plays a key role in strategizing roadmaps for AI-based healthcare solutions, focusing on how AI can transform the healthcare landscape and improve patient outcomes. On the opposing side, we have Dr. Nandis, Additional Professor of Neuropathology at NIMHANS, Bangalore. Dr. Nandis is an expert neuropathologist with vast experience in neuromuscular diseases, neuroinfections, and ultrastructural pathology. And I would like to call upon Dr. Jyoti Ranganathan, consultant pathologist and head of the department at Manipal Hospital, Sarjapur Road, to kindly chair these sessions. Without further delay, let's start the session. Please, sir. Over to you, ma'am.
Lovely talks before this, and I know all of you must be really looking forward to this day in laboratory report. I must commend and compliment Dr. Swarna and her team for choosing such lovely topics. I think we don't have the audience sleeping at any moment. So although this being a pre-lunch session, I'm sure it's going to captivate your interest. Without wasting much time, I thought I'll just show you 2 slides on AI. Actually, when she invited me to moderate this session, I myself, out of curiosity, started reading a lot on AI. And it's interesting to really realize what the definition of AI is. Can I have the first slide? Yes, next one. So I think I'll stand and talk. The next one? Just the definition, yeah. So this just refers to the ability of a machine and system to acquire and apply knowledge so as to perform a variety of cognitive tasks, basically mimicking human behavior. So you are expecting and hoping that a computer actually performs tasks that originally only humans could do. And of course, computers, I believe, have started reasoning, making decisions, and they do help in problem solving. Historically, I was quite surprised that way back in 1950, the next slide, switch to the next. Yeah, it was Alan Turing, 1950, and we are now in 2025. He conceived the idea of using computers to mimic intelligent behavior and critical thinking. And it was the father of artificial intelligence, John McCarthy. He coined this word way back in 1956, and there were a couple of milestones which just caught my attention. Whole slide scanners developed in 1990, and I think we are several decades behind. But well, at the end of this debate, I think we'll throw across questions to the audience as well. So without wasting much time, I would call upon the first speaker, Dr. Renuka.
I'm right here, ma'am.
Oh, okay. So she'll be discussing laboratory reporting as a boon.
That's right. Can I have the slides, please?
Can we sit down?
Very good morning to everyone present out here today. I'm extremely excited. First of all, I'd like to thank the organizers for giving me this wonderful opportunity to be here on this wonderful winter morning here in Bangalore. The amazing weather that is there in the city here today. It's definitely uplifted my spirits for the morning to address this occasion. I'm going to be talking about AI in lab practice. Just to give a little introduction, I'm myself a hematopathologist, and I've dabbled in the field of pathology for many years, and I'm a person who started, all the way from manual reporting, manually doing the tests in the lab, and then slowly, looking at automation coming through in my practice, and then taking up further onto AI. And today, the revolution that we are looking at is AI in our day-to-day activities in the lab. And I just want to give you a couple of live examples, perspectives. More than a debate, I'm actually here to inspire, to give some amount of inspiration, maybe raise some curiosity, get some thinking cap on to see how could you look at the same picture but in a little different way. And finally, it's your decision and your call and how you would want to adopt this in your practice. I've put the first slide as responsibility, and I've put this because I'm going to come back to this right at the end. I've just got 15 minutes, so I've kept the slides very crisp and very, very less, but there's a lot that I really want to say. And why have I started with responsibility? Whether we are doctors in healthcare, whether we are pathologists in the lab, whether we're lab professionals, from the technologists to whoever we are in lab practice, I think the most important virtue that we all have is responsibility towards our patients. The safety of our patients, giving the right report at the right time, the right diagnosis. The gun's always been on our heads, and even before the sample comes into the lab, we've been called to give out that report. And how can you give that in the best way to your patient? Can you always be present in the lab 24/7, ensuring there are no errors? And I think I'm very grateful to Dr. Sujay because he actually set the tone to this particular talk. And we all do look at the lab practice in that way, from quality to the errors that happen out in the lab, and to the right decisions that we can make in the lab, the right kind of diagnosis that you can give, because it all starts from there. It starts from the bedside, it comes to the lab, it goes back to the bedside again. So the tremendous amount of responsibility that is entrusted into our hands, the economic pressures, staffing issues, decision fatigue, all of this plays in a day. And how much can you contribute? You may have the intent, you may have the time, but how much can you actually contribute in a day? Now, AI as a tool, can it actually improve decision making? What are we doing in the lab? Every step that we take in the lab, it's about decisions. Whether it's reporting, whether it's tackling a technologist who's doing a test in a certain way, you're looking at a quality indicator, is it right or wrong? The first thing in the day starts with looking at quality indicators, right? So it's all decision, decision, decision. Now, can there be another tool which can actually aid us, which can actually help us use that decision in a right way, and maybe make it a little better, simplify our lives a little better, make it a little more productive for us, making us ourselves a little more efficient? And if there is such a tool, there's definitely an ethical obligation to use such a tool in practice, and I'll tell you why. The burning question is, there's an overwhelming information about AI today, and it's out there in Google. You'll get wonderful speakers speaking about it. The burning question is, should I adopt it in my practice? We're all scared, right? How will it change my life? Will it take away my job? Will it, hamper me from, giving the right report? Maybe the AI is going to give something wrong. And I'm going to keep this talk very simple. I'll show you some things for imagination as well. But the bottom line is there is an emotion when I speak about this. Because when you create solutions for AI and you unravel that mysterious, that entity called AI and the environment called AI, and the things that actually gives you goosebumps, when you're talking about things like deep learning, machine learning, the neural network. Now let's start with the human mind itself, right? Now our human mind is very complex. This is a very complicated neural network right there. But our mind is powerful. And I'm tired, right? And maybe when I come back the next morning, I'm so fresh, I get that in the diet. So we all undergo fatigue. What about biasness? What about ambiguity? What about distractions? Are you in the same tone, in the same mood the entire day when you're working? Your intent might be there, your experience might be there, but we're all human at the end of the day. So what if we could get a tool which could actually help us and aid us? And where can it aid us? And that's the first question. What is the most common, like a blanket test that you do in the lab, day in, day out, day in, day out? What kind of a name would you give for tests like that? Screening tests. The 80% are screening tests. And then the rest of it are those complicated advanced tests, which gives you that kick, I want to go do a flow cytometry, I want to go do something in molecular, I want to go do something in cytogenetics, that kick that gives you at the end of the day. But the fact is that most of the time when you're sitting in the lab, you're actually having this mundane activity, as Dr. Sujay Prasad rightly said. You're spending 80% of your time just doing that. As a hematopathologist, I've done PC, DC my entire life. And the thing is, I've lost out so much time when I could have actually given that time to more challenging cases, to more interesting cases, to cases which have really enlightened me or given me that excitement and that adventure for that day, right? So what if AI could actually take away that 80% and do that? And that too, with the right amount of standardization, reproducibility, and probably with a little more accuracy as well. Because AI doesn't come with an emotion, right, at the end of the day. It is just doing what it has been programmed to do. That's what AI is actually doing. So there's another very strong thing that I'll get back at the end of it. It all starts from change. The universe is changing, the world is changing, technology is changing. We're adapting technology in our lives today, iPhones, whatnot, everything. Why is it that when it comes to lab practice, we are not very open to change and to innovation, to technology? It is there and it is meant to be there. And it is how we adapt it, where we feel that it can actually help us. And for that, you should first know where the problem is. If you know where the problem is, if you know where the pain is, and then you know that, yes, I need a solution that can help me to actually address that pain point, to actually address that particular problem. So now you'll find this on the net also. There's nothing great about it. But I want to tell you a few things out over here. Why do we need AI? Do we really need it to give us a diagnosis? No, we are qualified lab professionals, we're qualified pathologists. We know our subject, we know the diagnosis. It can aid us when it can screen and throw those cells out to you, highlight those cells out to you. Like, hey, see, this is where the problem is. And it gives that outright so that you don't have to spend time screening and looking and to see where the problem actually is. So it highlights the problem to you, saves time. Assists in flagging the abnormalities, and it gives you visual evidence. So it is data backed with data, backed with research, backed with visual evidence, and that gives you the confidence that, yes, I can rely on something like this. If it is showcasing an abnormal cell, yes, I know this is an abnormal cell. It is saving my time. The enhanced accuracy and efficiency, I'll come to that a little later. The main thing is it is consistent, it is reproducible, it will give you consistent results. So it's not going to, go haywire during the day that, sometimes it's going to be calling the same thing as something else. So it's dependable. You can believe and trust on it to give you the aid that you're seeking out from something like AI or even like just basic digital reporting with the visual-based evidence out over here. The most important things in the lab are TAT, the turnaround time, because everybody wants that report on that dot. The second thing is, after turnaround time, is the quality of the report, whether it is accurate or not. And the third thing is, in every lab today, is scalability. I might be an experienced pathologist, you give me 5 slides, that's fine, you give me 6 slides, that's fine, you give me 20, you give me 30, you give me 50, but I will reach a pause, you know, when you give me like 100 slides, 500 slides, 1,000 slides, I don't think I'll be able to do that. But scalability is the need of the hour. The business in the lab needs to grow. You are going to be given so many cases. What do you do? At least 50%, 60%, 80%, the AI can take over, and you can give your time to the critical cases. You can give time to those cases which need your ASAP attention. And that's where the differentiation is, having a tool like this. It just simplifies your life, right? In the real world impact, what are the things that it can actually do? It can resolve challenging cases faster. Now, we all have that one case that gives you a nightmare. No matter whatever you are, how many years of experience, you'll get that one case. You'll go back home and think 10 times on that, right? And why do I say this? Because you have accessibility. These things are all on a cloud-based platform. Now, if I want to get another second opinion, what do you generally do? You transport that slide. So there's this logistic challenge of actually transporting the slide somewhere. Again, that's going to be reviewed. There's going to be time spent on that. The report is going to come back. Until then, your clinician is again asking you for that report. Your patient is asking you for the report. What if things are on a cloud-based platform? The AI has done some amount of job, and a cloud-based platform where you could actually get a peer review, you could actually get a second opinion real time. At that moment, because you need that diagnosis now. You don't need it 10 days later. And you need it right now. So collaborative working. You know, you collaborate, work with the experts in the field. You learn as well. Your errors are much lesser. I also made a lot of errors. I got my first CSF after I passed out, and I made an error. And I learned after, and I never did that mistake again. But what if you could avoid a lot of errors? If you can get expert opinions in real time, you'd learn as well, and you'd avoid the error as well. Isn't that a better thing? Well, these kind of solutions help you to do that. So ultimately, you're going to be providing your clinicians with detailed insights that improve patient outcomes. So again and again, we come back to the patient safety, better patient outcomes, and that's our intent. So if there is going to be a tool which is going to help you to get that intent solved, why not use it? Why not try using it and then make that choice? So I already told you about this, the 3 most important things, according to me at least. So most of the things that I've written here are just my thoughts. That, quality, scalability. I think these are the 3 important parameters that we're looking out in the lab. Accessibility, and I think this is the most important one. I'll tell you a little story out over here. So I was reporting for a group of Adivasis in Gudlur. It's like a bunch of 50 hamlets out over there. And the patients there don't have a pathologist. There are clinicians out there. And until they aligned with some pathologists in the city, I was just trying to help them out with some diagnosis, reporting, just helping them out. It's not that I was on the roll or something. And I was moving in the car, and suddenly I got this call, and we have 2 babies, and they're both having fever. We don't know what to do. The CBC is fine, and all of that. So I said, okay, let me look at the CBC report. It wasn't very enlightening. And then finally, I said, okay, what about urine examination? Now, urine is something that's always been in the back burner. Nobody wants to look at urine. Nobody. Everybody wants to look at the fancy things in the lab. Nobody wants to look at urine. So I said, okay, let's run the urine. And thankfully, we ran it on the scanner. I got to see the images. I didn't put it up, because I just wanted to tell you what's from the heart right here, right? So we put it up, and guess what? One of the infants had RBCs in urine. The other infant had pus cells in urine. It was as simple as that. It's just no one thought about running a urine test. And there was no pathologist there, obviously, who could have run that test and seen it under a microscope. But after I said that, obviously, the right kind of evaluation was done, and further, the clinician took over. I can't tell you the sense of gratification. It's not that I diagnose something, an adult T-cell lymphoma or one of those rare diseases or something. It's just a urine test. But I cannot tell you that gratification I felt that day. Somewhere far away into the hills of, in Gudlur district, I don't even know these 2 infants. And the fact that I could actually do this with remote access, visual-based evidence, it was so simple. It was so simple. It was priceless. That moment was actually priceless. It was, in a way, the first tele-reporting I ever did in my entire life, and I remember that till today. After that, I've done quite a bit more, but I have endless examples to give, but I have just 15 minutes. But I wanted to tell you the importance of it, how you could use it, where you could use it, within the lab, accessibility, where you can do with remote access today. There are people reporting in the Indo-Tibet border where there are no doctors, where there are no pathologists out over there. The patients out over there, the people in the village out over there are actually getting solid, good reports today, thanks to AI and thanks to digital pathology. So that's something to actually just give a thought to, right? Okay, now let's move on to something a little more fancier. So there's a lot of research also happening. So when we are looking at lab professionals, ourselves as lab professionals, it's not just about coming for the day, diagnosing a test, some slides are kept on your table, you want to finish your test for the day, you want to finish diagnosing for the day, go back home. There's so much beyond all of that you can do, and with the help of AI, you could do so much more. Diagnostics is one, research is another, education is something major what you could do. You could educate through AI. And last but not least, even your quality testing, like your EQUAS programs, your ILCP programs, all of this can actually be taken on an AI-based platform today. And trust me, it's so much more exciting than what we're actually manually doing and with paperwork, what we're doing today. So King's College in London and with the NHS Foundation Trust, they're collaborating with NVIDIA's. And what they're trying to do is that they're trying to create the supercomputer. And with the supercomputer, they're trying to prioritize and triage patients, particularly because of a lot of backlog which has happened during COVID. Now, what did COVID do? It gave us a shot in the arm. It declined our TAT. It made us so miserable, we couldn't even go to work. But as pathologists, what did we have to do? Our lab professionals, what did we have to do? We had to go to work, right? Even the clinicians, we had to go to work. But what if we had this? And what if you were at home and you could have still looked at a lot of reports from home? Even if you could have avoided going to work, you could have had the accessibility to look at a lot of reports from home, right? So now because of this, a lot of thought is being put into this, and AI, they're looking at even things like creating synthetic images, like synthetic brain images, synthetic images for breast carcinoma, for colonic cancers, etc., so that they can do more research on that and address issues, the medical issues which don't have answers today. They want to do more deeper research into that to get the answers out. And this is the kind of the amount of meticulous work which is being put in with the help of AI. And Professor Sebastian, who's actually the head of the division for the AI out over there, and that's exactly what he has said. Through this partnership, for the first time, such a scale of computational power will be available to healthcare research, and it will truly be transformational for patient health and treatment. Because ultimately, again, like I said, it comes back for patient benefit. So such incredible work on research is also happening, and that's also a thought that we need to give to, not just diagnosis, but extensive research that you can do with AI-based tools. Birmingham Children's Hospital, what are they doing? Now, they have an ER which attends to about 45,000 emergencies. There's so much of paperwork. They have no space to keep that paperwork. And that's the situation today. So what are they trying to do? They're trying to collaborate with another company called as Iron Mountain. And Iron Mountain is collaborating with them. And they are going to manage all of the scanning, the data, the profiling of the patients, retrieval of the data so that you can get faster, accessible, vital information pertaining to cases. You don't have to wait to go manually and fetch those important information when you are considering to treat these patients in the ER. Increase speed, quality of patient welfare, decision making. So again, I'm saying decisions. Our day in the lab is all about decision. The faster you do it and the more accurate you do it, I think that will help us in the long run. And just try to intelligently use these tools. I'm not saying AI is the end of it all. Finally, you still need that knowledge in you. You need to know where to use it. You need to know how to harness it, how to exploit it. How can you make it simple for yourself, right? You want to simplify your day. Don't we do that at home? We try to do chores at home. Don't we try to use technology at home to simplify our chores? Are we still manually scrubbing the floor? We are not. So something like that. It's just how intelligently you can apply and implement that in your life. And finally, they're even looking at staff productivity. When you're doing at competitive evaluation, when you're looking at competency evaluation in the lab, when you're looking at educating your juniors in the lab, your technologists in the lab, imagine you had a screen like this and where you could actually give the information on the screen and educate hundreds of people. Otherwise, you would have like the 2-headed microscope, 4-headed microscope, 6-headed microscope, and you're having the pointer in that microscope. You know, this is a megaloblast, this is an erythroblast. Trust me, many pathologists come on and they still have confusion. I had confusion in a lot of cells, even after I passed out. And then I learned and looked at atlases and I learned, and that's how I learned. What if you had a tool, an AI-based teaching that could actually teach hundreds of people? Just think about how efficient that would be, the kind of people who would be actually coming out from there. And then you have these amazing tools like this, where you have histopathology biopsies, you know, where you can actually, the AI cuts it into different planes, gives you different areas of focus. It even gives you on the quality of the focus, which area was focused, which area was not. It gives you an automated focus scoring as well. And then there are all these RUO algorithms which are being used today for grading prostatic carcinomas, for looking at breast cancers, and Edge AI. Now I'm telling you, Edge AI is such a thing. As the tissue is being scanned, you're getting the features of detection, quantification, classification, all inline computation. So while scanning this, in seconds, you're getting the results from the AI. Now, how fast is that? I'm not got this from the net, and I'm not talking about this from the net. I have actually witnessed it. I've seen this in various expos that I have visited, both here in India and also outside India, and that's why I'm talking about it, because you see how excited I am? Now look at this. This is called SmartPath. Now this solution, you can actually keep it on a tabletop like this, and you can actually scan a live biopsy. You don't even need a formalin fixed specimen. You can actually scan a live biopsy, and it works on just ultraviolet laser-induced light, which goes into the biopsy. It goes into the DNA and the RNA. From there, the thermoelastic expansion of the tissue happens. And from there are photodetectors, which, you know, the transducers, which pick up those signals and transform that into an image and gives you a clean image, like in a histopathology H&E image that you're seeing right here. And so you get smarter things like TWAD, what Digit is doing with TWAD systems. You can actually set up a point-of-care biopsy in your home office. Tomorrow, see, histopathologists are all going vertical today. You have histopathologists doing only FGT, they're gastrointestinal, and then there are people like me who do only hemat. Now you could have your own little cubicle, and you get the samples across, and live tissue again, no fixation, nothing required. So these are the different innovations which are actually coming up. And we are still thinking, should we adopt AI? These innovations are already happening, and people are already doing it. So frozen sections will be
Sorry to
floppy all
interrupt,
over the
Dr.
day.
Renu, you just have 2 minutes to go.
Sure, this is my last slide. And to actually put the whole thing into place, and why you can be confident about it, there are good practice statements coming out from different governing bodies across the world, including NABL. So NABL has recently, I don't know if you're aware of it, they've got these clauses for digital pathology, 7.5.4, and then you have scope of digital pathology. There's also a clause in tele-reporting. So if NABL is allowing that, obviously it's seeing some sense to implement things on AI, things on digital pathology in our workforce right now, in the current and in the nearing future, and that's the way it's going. But I think more than all of this, like I said, the first thing starts with change. Embrace the change. Unless you are first willing to open your mind, you have to open your mind, unlearn a few things, embrace the change, adapt, and then finally comes adoption. So with that, I end this, and I hope I've been able to inspire and create a bit of curiosity into your minds. Thank you.
Thank you, Dr. Renu, for convincing the audience that AI is a boon. We'll take on questions at the end of the second speaker's talk. I request Dr. Nandish to take over. AI is a bane. AI in lab reporting.
Very good morning, and I'm thankful to Dr. Swarna for giving me this opportunity for 2 reasons. One, of course, sharing this platform for this particular event. Second is to meet my favorites and my role models, Danan sir, Dr. Vijay Shankar and Sujay sir. It's nice to meet all of you again. And third thing is, I am remembering my Viva days back in MBBS, where a topper will come out with bright colors impressing the examiner. That's what Dr. Renu did. And I am a mediocre who goes with tens, and that camouflage effect will confuse them. Okay, very excellent presentation. Now we'll straight away go with the, I won't go with the strengths. Madam has already highlighted it. There is no doubt that AI is running the globe. Even my son uses ChatGPT for his portfolio project. So if I start speaking against that, there is a risk of being thrown tomatoes and eggs. So I hope that nobody is carrying that. But I just want to have some disclaimers that all this information, whatever I will be giving, is not my thoughts. So if you want to blame, you can blame. So many articles. I was worried that everyone is going for AI. Will I get any information articles? There is actually competitive degree of information against AI. Okay? So obviously, whenever there is majority, you will have a good amount of opposition. Okay? That's how it runs the life as well. Day, you will have night. You realize the effect, value of day only with night. Darkness with lamp. Interaction. So many things, information came from interacting. Many people, especially the attenders, technicians, technologists. Of course, we will be in a different stream. We will all be, in the sense, looking at a different level of thing. But we need to go to the grassroots level also. And there are some situations which I will share what AI has done. And of course, my intention is, as Madam expected, inspiration. My talk should not be opposite of it. It should not create fears of adopting AI. Okay? So that is my disclaimer. So BANE will not be a right terminology to use because there are a lot of good things. So we'll have to see in a different perspective. So take it as a drawback, take it as limitations of AI, challenges, obstacles, and risks. So this will not induce stress in us. If you use something as stress, it will be a problem. Take it as a challenge, then the life will be more charming. But another disclaimer is that all this, what I am telling, is at a contemporary level. At this level, what the situation is. Because AI will improve much more, no doubt about it. Only thing is, AI will improve, but we should also improve with AI. We should not cause the opposite, where we become we should not retrogress. And some of the challenges are at the implementation level, so it will be a transit, temporary. Some are at the maintenance, sustenance level. Some are only potential. They may not have occurred or they may not occur also, but you should be ready for it. And most important is, some may be applicable at every step of our workflow, or some may be only at a specific level. So, but I cannot take individual example and give, so I will be using generalized statements for that. And of course, yeah, it may not be visible yet. Stephen Hawking said that success in creating AI would be the most significant event in human history. And of course, we have attained that, no doubt about it. But that may become the last if you are not prepared for the risk involved. Okay? So it may have a very devastating effect. And whatever information I will be giving is only food for thought, a concern which you should think about it and be prepared for it. Next is, and not to forget our background. We are from low and middle income countries, not to forget our great country, and which is known for its diversity at every level, whether it is social, economical, or any platform you take, it is extremely diverse. Within a small area, you take Bangalore, different corners. Sometimes you feel one area of Bangalore will look like some foreign country, another area will look like original Mera Bharat Mahan, anything can happen. So just a small area you take. Next, the objective is only to be proactive, be aware, and be proactive to mitigate the risks which may come with the utility of AI, because it is already in place, no doubt about it. It's going with us. We are using simple techniques, which is also AI. So a glimpse of the concerns now. The first concern would be data collection centers. As sir very nicely explained, now we are all loaded with data. Data is everywhere around. How we utilize the data will be useful, but problem is now it is coming with its own new challenges. The first important thing would be how to handle this data set. So we are actually obviously depend on something else, and how good it is. Is it equally good or more good? Naturally, whenever you go for help, they should be higher than us. So water will always flow from a higher level. If you go to a lower level, it will create more problems. It will go in the opposite direction. So that analyzing tool should be much, much stronger, much, much good, and it should be equally expendable. Of course, taking into consideration the entire spectrum of variables, at all factors are fraternity. And accuracy, this data whatever is it is happening, it should not be in the dark room where you don't know the explanation. The transparency should be very clear, how it has analyzed, what is formula is used, it is matching with what you are seeing. Only then you will be acceptable. Otherwise, if you cannot reason out, then you may get doubt. And the model developed for analyzing this data, that also should be clear, because it is not developed by us, it is developed by somebody else, an IT person. If they have used some other standard to compare, some other method to compare, the errors, I mean, there may be a bias there, so there will be a lot of challenges at the developmental level itself. So the algorithm whatever is drawn, it will be compared to a gold standard or golden truth. If that golden standard is something which is also not very accurate, then there will be problems with that. So it's all getting refined, retrained, everything. Of course, that doesn't mean that it is not good. It is improvising, it will improve at a very, very great level. So regular refinement and retraining is important. And absolutely, as I mentioned about the gold standard comparison and all those things, those are some of the challenges which are still going on, and it will be continuing because there is no perfect bar or there is no end point here. It's just a journey, and that's the root of the journey. Second thing is at the implementation level. Most important is high investment cost. India seems to be rich, but at the same time within that it's a lot of poverty is there. And our simple example, anybody if you get 5-6 types of products, the first thing as an Indian mentality, including me, first thing what we will see is the cheapest, which has got the best discount, all those things. Same thing holds good for this also. So I invest in cost. Is it just at the implementation level? No, it is at the maintenance level. We were so happy to procure the digitizer. Now we are struggling with the space, physical space, cloud space. So now leave away Mars, we are now aiming at the sky. So sky is so vast, how much we will acquire, we don't know. Next is training required, whether we are, and the training should be retrained, effectivity of the training is important, people will leave and go, you bring others, permanent people are, government is not asking for permanent contract people, and these contract people will gain experience and not accountable also. Now next, how do you evaluate all this, what after implementing it, what are the evaluation tools? If you know the physicality, all those things you know, but these are all technology related, you depend on a technology person, because we have not studied that, we are just acquiring now the information. Of course, standardization, so many things go with standardization. And lastly, what are the legal and regulatory guidelines which are there governing these issues? There are other things which is still, of course, all these things are getting formulated, which we will come across soon. And not to forget the ethical and privacy challenges, because earlier, confidentiality. Earlier we were worried about so many other information which is getting leaked out. Now we are scared about losing their mobile phone, because that carries so much data. So because of the same thing, confidentiality, data security sharing, because so many people will be using. Earlier only your own lab people were using, now your new people are entering your lab. That is the AI related technicians, technologists and engineers. So you don't know, and once it goes out into the, how many of the emails, I don't know, it's hacked and all those things, the data security, everything. If you run our own email, it will always have that risk. Just imagine the loads of data, loads of patients' information that may be available for them. Data leakage again, and accountability. Now, anything goes wrong in the lab with the physicality, you can easily catch hold of him. Of course, as sir very nicely indicated, never target at an individual. It's all at the system level you can target. Now, if the system is within your purview, okay, you can do something. If it is outside in the cloud, where will you search in the cloud? We may have to catch hold of some flying bird, all those things that will happen. So that means to say, whatever difficulties which are facing at AI level, you don't know whom to pinpoint it. Okay, you will catch hold of the engineer who has developed it, but he will tell that it is, I have developed this, is very clear, somebody who has entered the problem, no, who has entered, they will not be accountable. That is the problem, and most important is that guidelines are still getting standardized and formulated, that is important. Now technical challenges, not to forget the technicality of it. Anything will fail, okay, say component failure, malfunction, next is integration. If you take up our simple example of our LIS, LIS has a wide spectrum. You have a very simple one and a very high sophisticated one. Our LIS is so rigid that nobody can speak to it. Even we our own find it difficult to speak to our own. Now it has become part of our family. It's so rigid that we find it difficult to approach our own LIS. So imagine if you bring another LIS, another information system, both will be turned the opposite direction. So it will be very difficult. So integration is important, and some of the AI things are so closed. For example, we got one digitizer which was again available because of the low tender, cost was low. So low L1. So we got that. That is so strict. So we purchased with so much hope because that won the tender because it's low cost. Next came, you have to add additional software, licensing for the person. Third thing, leave away that. If somebody has to see outside your institute, they have to be there. You have to convert it into a different format of it. Another cost, additional cost. So it went on. So that means to say it was not at all open. It was a closed system. So now to open it, we have to use all kind of tools. And of course, not to forget the risk and all those things. The earlier people were worried about pickpocket and all those things because they were carrying money and all those things. No, even if somebody steals or tears my pocket, no problem. But I'm worried about online thefts. People can do burglaries in online. Okay, so one phone is enough to remove your whole savings, right? I'm just joking. Okay, so whatever it is, AI should align to your goal, laboratory goal. Next comes social concerns. Human is a social animal. Ours is a society. So, as made very clearly, everyone will have this fear. Will I lose a job? Of course, everyone says, no, it will never, you will not lose a job because it will only complement you. But that is applicable to people who have already reached that stage. Okay? But you need people to be at the data entry level, all those things, they are the fear. So one great person told, of course, the greatest service of any of those things which you establish, the startups. So many people are telling startups and all those things. The startups they are encouraging because it is creating employment.
Dr. Nandish, you have 3 minutes.
Yes, sure. Almost done. Okay. Employment. So where did I lose? I lost my thought employment. Sorry. No. Because the flow. That flow of thought got interrupted, yeah. Not to forget because so many potholes are there in Bangalore, so this also like a pothole, okay, fine. Yeah, yes, data entry level. Where did I, so unemployment, if it creates employment, because these unemployment, all those AI will, unemployment is not a problem in developed countries. In our country, there is need for employment. Even a 5,000 if you pay an employer, it's always good. It will form a family for that. So keep about that. So only problem is whoever is there, they have to acquire new knowledge. So there will be resistance, as Madam very clear. And AI, that name itself is so much, that intelligence comes now, whether it is artificial or original, the intelligence name is there, people will come with lot of expectations. So that is one. And not to forget, it will compromise all these things of a human. Analysis, problem solving, thinking. Nowadays, to go to the second road, I use GPS. Okay? Where is my thinking? Okay? So, this risk is there, human interaction, and not to forget, ours is too diverse. There is an institute which is struggling with basic minorities, there is another institute which is hi-fi. So that gap should not be there. In our country, the global, let's not compare with Europe, they are all ahead. At least within India, they should be uniform. Okay? So if you want to, instead of doing all these things, we'll do in such a way that everyone gets the same thing. See, AI is becoming super AI very soon because you are improvising. But we should also become superhuman. But on the fear is that they are becoming more and more ordinary. So that's it, I think I done. Yeah. About job loss, they have done actual investigation. After adopting AI, who else has lost? There are various sectors who have lost jobs. That is in China. Let's not worry about it. Lastly, these are all. Last, all these things, these are all self-explanatory. We become very complacent, lazy, all those things. Reinforcement, because some are old model, policies will change, but AI policy may also adopt. Surveillance. And not to forget, there are so many aspects in our, like phlebotomy, no AI can do. Counseling, no AI can do. And what about the next, something I forgot? Something I thought. Okay, about counseling over and whatever. Okay, this is in India. India, so diverse. You see, this is very nice. This is what I'm telling you. What is this slum right next to the posh apartment? That is our country. And see, all this you agree, at least in our setup, I am still struggling with internet connectivity issues, the strength of the internet, and unstable power supply, all these things are there. And issues like data analysis, all those things. You agree, pathology in laboratory, I don't know about that, at least I have been facing and even now I am facing, pathology in laboratory medicine always kept as tier 2. First is the clinical thing. Money comes, first goes there, and all those things, you think they will are here. And this is a summary in a diagrammatic view of all those things. lastly, this is all, everyone, we all of us have to go for AI, no doubt about it. You have to use it because it enables it more. But we should not become artificially intelligent. We have to adopt artificial intelligence so that we become more intelligent, really intelligent, originally intelligent, super intelligent, but not artificially intelligent. Thank you so much.
Thank you, Dr. Nandish. I think you've not told the audience that AI is a bane, and you've kind of convinced them that it should be used as a tool, right? So I think we'll open the forum to the audience. So tell us, is AI a boon? I think you should raise your hands. We'd go for a poll. Boon? Only 2 people are convinced, Dr. Renu. Okay, that still is just barely 10 to 15% of the audience. So I think Nandish, Dr. Nandish, you have a bigger follower group. But I'm for it. You're for it, okay. All right. So do we have questions from the audience for the speakers?
Dr. Renu, thank you for that. So if AI is a boon, what's the role of the human?
The role of the human is to intelligently exploit the advantage of AI in their practice where they feel there is a problem and how well AI can help them in addressing that problem and that situation, making it more efficient. Yes.
So what's the role of the human?
So it's not going to address the entire problem. It would obviously address at least 80% of the problem or 50% of the problem and leave you to make that critical decision, which obviously the human mind is needed to make the final decision on things because we are intelligent and we have a brain for that to analyze it. But the routine work that involves in arriving to that decision, there the AI can complement you. And you don't want to be just counting numbers in a day. You don't want to be doing stats in a day. You don't want to be looking at the intensity of a stain, grading something. That's mundane. That's just math. That's just math. So, yeah.
I get the point that AI is a tool, nothing more, nothing less. How we use the tool can be a discussion on whether it's a boon or a tool. You used all the content to show that when you use the tool the right way, it's a boon. Nandish showed if you use the tool, if you don't know what of the tool to use, it's certainly a pain. The biggest challenge is AI can only use information and gain knowledge. And the knowledge is to the extent of thinking. Beyond thinking, the AI can't participate in consciousness. What AI is missing, which humans have, is consciousness. And that is wisdom. So you can have information, you can have knowledge, but to convert it into wisdom is still our until a humanoid comes and takes that away. But as of now, I think we are very relevant, and our relevance only will increase with AI, not decrease. Thank you. No, actually I go with Renu. AI is definitely a boon. Star conditions apply. Conditions apply is what Dr. Nandish said. Sam Altman recently said, the super intelligence is just 1,000 years away. Once that comes, I think the humanoid will be there for sure, and that's where I think the whole civilization might be having a new era altogether. As of now, yes, both of them make sense. As it is said, it is a boon condition supply with Dr. Nandish. Beauty is Dr. Vijay Shankar and myself can tell anything and get away with it because by the time humanoid comes, we'll not be there.
I have a question, Dr. Nandish. Since both of us are pathologists, histopathologists. So what is the role of AI in interpretation, in diagnosing a slide, Okay, histopathology slide. What is its role and how can it help us to reduce our stress level? You know, one slide will take away your entire day and you cannot sleep peacefully, right? And you forget about your family when one slide is giving you trouble, right? So I want to understand from your end, like, you know, AI will definitely help us, or it is going to be like all your
Yeah, I will make it simple that there is no life of an histopathologist with A, without A is the same. Okay. Only thing is with A, that is, it will make a few kind of refinements. Like you may report it at home, at least all those things, and some kind of preliminary screening it may do and all those things. So few enablements may be there, which is optional. But it depends on the individual, particular person. Whether he wants a refinement of those things. Okay, it is like this one. You have a nice car, but then you get additional accessories. It's an accessory right now, because whatever tools they have mentioned about artificial enabling this thing, counting of ERP and all those things, those are definitely good ones which you can adopt and enable it. But still you can do the same, right? It's not making any difference. At least from my perspective, where I come from a government background. However, because none of them has not entered the area of urology, because in breast and other things, they are making a difference. This is contemporary at this stage. However, one person came from Roche. They told you can at least adopt MID1 positivity, because ERP may not apply for brain here. Okay, then you do some studies and all those things. It was a trouble. Then Carl Zeiss company came, they told intraoperatively people struggle, everywhere they will not have a pathologist to give intraoperative consultation. We came with a probe where it can penetrate 2 millimeter and show the morphology, where the surgeon can decide, so that you can see, pathologists can see the malignancy and those things. At least they want the margin. Once they close, it will be difficult. Now when we asked for the tool, it was not a validated tool. It was all on small numbers and highly testing control was very, very different. So in that way, and even all of you have seen, even Roche or those things, it's still learning. So many issues are there. Of course, this is my understanding. Of course, it's like this. If you are walking as an instructor, AI right now may make you go in a cycle, a little faster than us. That's the only difference. But very soon, era may come as the Vijay Shankar, where you will be able to go like to airport, flight drone, something like that. Drone situation may come where it may enable the pathologist to go in a drone like that. Air taxi. Yeah. Thank you.
Yeah, so thank you. Dr. Renu, I have 2 questions for you. So you said NABL has accepted digital pathology. Would you tell us how we are planning to validate this methodology?
Definitely.
And do you have any EQUAS? Dr. Sujay is right here. Do you have any EQUAS for it?
So, answer number 1, there are guidelines for validation. CAP has guidelines for validation. Like I said, the good practice statements which are there in different, according to different governing bodies, you could go through that as well. You could go through the NABL as well. The clauses do mention the validation steps, predominant steps that you could follow. But in my opinion, first of all, you should decide what kind of a laboratory space you're coming from. What are the pain points that you want to address, and try to emulate the validation as closely possible to the real life situations that you see in your lab. So that kind of is subjective. It varies from lab to lab. But then obviously there has to be a comparison with the ground truth, with the gold standard. So whatever the AI results are, there has to be definitely a comparison with the ground truth. A certain amount of concordance is expected. There are guidelines for that as well, for different parameters, the total allowable errors or the concordance requirements that have to be, the benchmarks that have to be met. See to it that is aligned, but most importantly, take care of your pre-analyticals as well. It's not that the AI is always to be blamed. It's just like manual practice as well. We look at the pre-analyticals in the lab. So there's pre-analytical, the analytical, and the post-analytical. You need to look at all these 3 spaces. Ensure that it is close to ideal. It will never be an ideal textbook situation. And then obviously do a very unbiased study And like I said, put those sample data, whatever you're looking at, which is relevant for you in your lab, where you feel that is required to be looked into, adopt it in, do the validations in areas like that, and document that result. And that's what the enabler is also expecting. And also to talk about one more point which Dr. Nandish said, and that's also part of the validation, the privacy protection, the security of the cloud. So all of this is privacy protected on the cloud. There are passwords which are used. So the whole audit trail, so the maintenance of the audit of the custody, the chain of custody, who has scanned it, who has entered the details of the patient, who has reported it, was there a second opinion on that, was there an amended report? So that whole audit trail also has to be validated. The TAT validation, when I did it by manual methodology, what was my turnaround time versus using an AI, what is my turnaround time now? What is the quality of reporting? Has my decision-making capacity, has it got better with the AI assisting me? In what areas has it made me productive? So those kind of qualitative parameters are also there, which need to be validated in addition to the proper conventional parameters that you're looking at, the quantitative results given by the AI. And document the image quality, the digitizer, the speed of scanning, the speed of the internet, and the dialogue between the LIS integration. Like you said, the APIs could vary, and the different the IT support that is coming out over there. Is it really can you actually integrate all of that in your lab? Because finally it has to be a working solution. So validation is one aspect of it, and how practically can you make it a success for your lab, the truly understanding that potential and addressing the problem statements. So I would suggest that's how you'd want to look at a validation.
One thing that in Apollo, Swarna may be able to add something. For last 1 year, I'm Dr. Anjali from Apollo Mysore. We are at Apollo, we are doing the digital pathology EQUAS for last about 1 year. I can say that it is working about 80% of the times. Twice I could not open at all, some password gadbad happened. So the slides are on the internet, and they take our diagnosis. We can give a consensus. We have to give a consensus currently. Means a pathologist A, pathologist B, pathologist C in a lab cannot give 3 diagnoses. Those are the current problems what we have. It may get sorted out because we are using our existing software, patient reporting software for that, because across the country we are doing. So to an extent, it is working, but we need to this thing, like this time what has come, it has been opened yesterday. My password had become invalid, but now it has become valid. So I'll go and see tomorrow.
Yeah, we are EQUAS with TMH. I think majority of them on the digital platform. I think absolutely no problem with opening the windows and seeing the slides. You can annotate it. You can see at different, resolutions. I think we are very happy with having the digital histopathology images. They give the case history with the images uploaded, and we are really doing it well. And we have not faced any problems with the EQUAS with the TMH. Second, I think the commercial one, RML EQUAS, I think they upload even the histopathology as well as cytology also on the digital platform, and we have enrolled with them, and then it is doing good. Okay.
Yes.
So there are 2 things here. One is using digital path as a tool to perform EQUAS. That is okay. That's a tool, just like a microscope. You're using the digital image. I thought you were referring to an interpretation of the slide by AI. Do you have an EQUAS for that? So I don't see that coming up soon. It will come, but as of now, I would like to call AI as an assist intellect. Because intellect is thought-based. Intelligence is awareness-based. And I don't think AI is aware right now. The way we are aware of this situation, AI can never be aware. AI can only work on thought process. If the thought is biased, it will be biased. What you input into the AI
will be what the output will come. If the input is biased, the output is biased. Right now, we are giving all our inputs based on our thinking, and that's where the challenge is. How we use it is up to us.
Thank you, sir.
I think we'll conclude the session and not take on any more questions. So I think all of you agree that yes, in today's world, AI makes a big difference, and it only has to be used as a tool, and that too used very intelligently. Absolutely. Because as pathologists, it's going to come in front of you, you're going to be asked to validate, and believe me, I don't know, it's quite scary to validate these processes, but because at the end of it, you're going to be signing out a report, and there has to be a legal identity for every report that you sign out. So please be careful, these tools seem very, very fancy, and of course in today's world, like when we're talking of whole slide imaging or scanning, well, if AI interprets one odd atypical gland, you've got to go back to your slide and look at it, right? You're not going to believe that algorithm or whatever which says that yes, this is benign, this is malignant. And AI actually has a lot of role in oncology, where they've integrated proteomics, genomics, and all biomarkers, and that helps give you a comprehensive result at the end of it. So these algorithms have been used by oncologists, and they're still being used. But in pathology per se, I think its application, say in automatic reporting, say in biochemistry, has been used. Microbiology, infectious diseases, I'm told that, you know, they are AI empowered. But we have microbiologists in the audience who will tell us whether this is a boon or, I mean, there are fallacies in it too. So my take-home message to the youngsters would be, continue your creative thinking. Don't give it up. Read, because at the end of it, you're the one who's going to be diagnosing it. Of course, these algorithms sound very convenient, because once you look at an algorithm, you know a machine is interpreting it, you're very happy, you don't have to get back to that algorithm and even reason out why, what is the result. But it helps, you have to read yourself, you have to interpret things yourself. AI makes your day easier, but at the end of it, please remember that your neck is on the block and you're signing out the report. So just be careful, validate all of your equipment, whether they are AI driven or not, and only once you're satisfied, go ahead with it. Thank you.
Thank you so much to both Dr. Nandis and Dr. Renu Ethirajan for their thought-provoking insights to this very relevant and evolving topic, and to Dr. Jyoti Ranganathan for expertly chairing this session. And thank you so much to the audience for an active participation and in such a nice discussion. Now I'd like to request Dr. Shwarna Sivakumar, Lab Director and Head of the Department of Pathology, Apollo Hospital, BG Road, to kindly present a memento to our esteemed moderator and panelists. This debate has shed light on the remarkable potential of AI while also highlighting the challenges. Let us carry forward these valuable insights as we continue to adapt to the rapidly evolving landscape of medicine and technology. As we move forward, we shift our focus to another equally important aspect of laboratory operations, safe lab practices. While technical advancements are reshaping the way we work, the foundation of any effective laboratory lies in the adherence to safe practices. These practices are crucial not only for ensuring the accuracy of results, but also for protecting laboratory personnel and maintaining compliance with essential regulations. To guide us through this critical topic, we have Dr. Dayanand, Senior Pathologist and Professor from Bangalore Medical College. Please join me in welcoming Dr. Dayanand to the stage.
Hello. So after hearing the SMART and the AI laboratories, I'll be taking you to basics of laboratory. So when ma'am called me and said, will you be speaking on the safe laboratory techniques, I was worried. I got taken aback. Why is she asking me to speak about this? And then I understood. So I come from a government setup where I do work in a very minimal infrastructure. Probably I might have been practically exposed to so many adverse events which would have happened in the laboratory. She might have thought I'm a better person to speak. Thank you for giving me the door for the people. Okay, let me go on to the topic, please. Yeah. As she rightly said, when I joined the government medical college in 2001, I joined government medical college in 2000, and in 2001, there was one second year DMLT student. She was about to mount the Westergreens for ESR. And one of her colleagues was pulling her leg and she happened to drink that, enter into her thing. So I was in charge of the hematology section then, and they had to, as a protocol, we did do the HIV testing, HPSAG and the hepatitis C, and luckily it was negative. But she had to undergo the basics of the basic HIV testing. It came negative. Then I said, no, it is not the end of it. You need to undergo one more test at the 6th week and the other test at the 12th week. You may not believe. Literally, I could see her deteriorating right in front of me. She was going through such an immense stress. So she almost lost 7 kgs. 7 kgs within 3 months. She is now very happy. Okay, so everything went on well. Why I like to tell you all this is because the adverse event which happened, the first report on the adverse event associated with the laboratory did come in 1907, and out of 23 cases that was reported, 17 of them were resulted because of mouth pipetting. It's not that resulted in the associated infection, but adverse events did happen. But the first report in 1919 which came, and it did mention about avoiding the mouth pipetting. But what happened in my laboratory, it happened in 2001, almost a century later. So after hearing the smart laboratories, imagining the laboratory in my government sector, I'm waiting for the government guarantees to happen. Okay. So the other one which interested me more was in 2013, the two pathologists in California, they developed tuberculosis. They went back to think they had performed the frozen section in a cryo, the thing, so they must have contaminated that. When the nodule was sent as a cancerous nodule, later it turned out to be tuberculosis. I'm afraid quite frequently we do the frozen sectioning, which might turn later as a tuberculosis. And luckily I'm Indian, so the chances of me getting that may be very rare because I'm living in market from last 25 years. Every breath I might be taking might be having mycobacterium tuberculosis also. But the question is, when you're taking the sections and the lid is being closed, suddenly after taking the section you open and bend down to take the sections. So there is a sudden increase in the volume of aerosol, so the droplets. There is every scope for one to develop the infection. So Coming to the hazards associated with the laboratory, there are several hazards: the biological hazards, equipment hazard, chemical hazard, electrical hazard, radiation hazard, and mainly what you need to concentrate is the lack of knowledge about the lab safety. The human error is the the common reason to be associated with this. Okay, so the biological hazard. So what we mean by the biosafety, the term usually used to describe describe the containment principle, technology, that practices we implement to prevent unintentional exposure to pathogens. So we are trying to put some technology to prevent the unintentional exposure to these pathogens. What's the biosecurity? Biosecurity is, how does the biosecurity differ from the biosafety? Biosecurity is intentional exposure, misusing, theft of the pathogens, which you have other reasons in your mind. So my topic will be concentrating only on the biosafety today. So to adapt the better biosafety measures, you need to gather a complete information. What is the design of your laboratory? What is the infrastructure you do have? What is the competency of the technologies what you're doing? What are the potential pathogens you are going to work with? What are you dealing with those pathogens? How much is it just the diagnostic, or you're growing the pathogens? All that you need to have an information. Not just that, about the detailed information of the pathogen, how it is going to spread, how it is going to cause the harm to the individual. You need to know about it. Then next step is to evaluate the risk. Evaluate the risk is, so to what extent, what is the possibility of exposure to that pathogen, and even if it gets exposed to that pathogen, what is the consequences? Is it causing a mild disease, or is it causing a lethal disease? It is causing only the disease is it causing harm to the community also, is also very important. Luckily, if you look at the most of the laboratories where we work, the exposure will be unlikely and negligible. If you look at this, okay, so if you look at this corner, when there is a likelihood of exposure is unlikely and there is no negligible clause and the very low, that is what the biosafety level 1, where we are using at a practical hall, a teaching purpose, where there is no scope for the exposure at all and no chances of they developing the disease at all. The most of the diagnostic center, the research laboratories and the biotechnology workup they do, it falls under the second heading, where there is a moderate risk and there is a possible chances of exposure, and it is in the medium. So it's all fall under this range. So this most of our research laboratory is under the heading of biosafety level 2, where you need to have a few of the primary barriers, like the biosafety cabinets, the class 1 biosafety cabinets you need to have, that the PPE you need to have. Even though the chance of exposure is through the self-inoculation, the mucocutaneous exposure, or by ingestion. The most of the laboratories, what we do, the exposure is through the mucocutaneous exposure, or the self-inoculation, or the ingestion. Unlikely so much chances of the aerosol spread or the community spread is there. So we are very lucky to have the green, the area which is in green is the core, is in the biosafety level 2, and most of our laboratories do work in this environment. But what we need to attain the biosafety here is to follow the core requirements. There are the one which is in the yellow area is the heightened control measure, where there is an increased chance that exposure can cause the lethal disease to the individual and can have the low to moderate risk of the community spread. That is when you need to have a heightened the primary barriers, like the biosafety level 2 and the thing you need to have. And the maximum containment measure is the one where the risk is very lethal and you don't know how to do it. And there is no vaccination, and if the person develops the disease also, you don't know how to treat that also, and it has high potential to cause the risk to the community, then you need to do in the maximum containment measure, where almost you need to have what's that positive pressure suits, biosafety level, biosafety level, what's that biosafety cabinet level 3 you need to have. And entry access, hair locking, and directed ventilation. All that is necessary when you are going for that. So luckily, we are safe, and most of the laboratories can work under the heading of Biosafety Lab Level 2. Okay. So what are the core requirements for the biosafety? The core requirements for the Biosafety Lab 2. One is the facility designing, the good microbiological practice and the procedure, and personal protective equipment, laboratory equipments, specimen receipt and the storage, and the personal competence and the training, and decontamination, the waste management, and emergency and the incident response, and the occupational health. So coming to the the microbiological practice and the procedure, the main aim of this good microbiological practices is to protect the personnel, community, and the environment. How do you do it? You are doing it by just applying the SOPs for performing the biological activities rightly. How does it help? It prevents, it avoids the human error, it avoids the suboptimal technology, laboratory techniques, and the equipment misuse. So the first thing is the laboratory design. Remember, when you're designing the laboratory, the access should be restricted access. Only those technologies who are trained, already trained, can make an entry, or they should not be entry to the children. You may laugh at it, who will enter the children? Why do you think talking about the children entering into the lab? Come back to our laboratory, many a times if the children have the vacation, summer vacation, husband and wife are both are working, they'll bring their child also along to the laboratory. It is a big time for us to prevent them entering into the laboratory. See that there is a biohazard, the thing is pasted on that, and the fire rated glass door, which is always, it has to be closed always. Only whenever necessary it needs to be open. It should have an adequate space, where there is a space all around the equipment, where there is a scope for you to clean it, to keep clean and tidy. So it should provide an ample space for the work cleaning, restricted access, and smooth, easy to clean walls and the floor, the furnitures, and impervious, the durable bench tops, and the fit for purpose laboratory furnitures. Okay. So next is, so it's very difficult to keep this lab so clean. It just says there is probably very less of sample, or the no functioning is happening. So it is important probably to keep whatever, at least keep as minimum reagents on the table, so that the spillage and the other consequences should be avoided. So general behavior and the best practices. You remember, I did say the biosafety level 2, the most of the spread do occur through the self-inoculation, ingestion, and the mucocutaneous exposure. So then what we need to concentrate more on is not to eat anything in the laboratory, or don't keep any eatables, don't store any eatables in the laboratory. Never allow your technician to be on the earphone, or you yourself use the earphone or other thing into the laboratory, because obviously you get diverted, and even if there is an emergency beep which is coming out, you won't be hearing that. So you'll be when you are on the earphone. So never apply the lipstick in your laboratory, because the ingestion and the thing is a more the thing. You never use the cosmetic inside the laboratory. And wash is very, very important. You might believe I'm wearing the gloves. Before wearing the gloves, you wash neatly, enter into the laboratory. While coming out of the laboratory, after taking off the gloves, please do wash neatly. The washing, importance to the wash should be given, and I don't have to explain all the steps which is involved in the hand wash process. And make sure if there is a cut on your body, or so anywhere in the cuts, make sure to cover with the waterproof bandages before entering. And always keep the flammable reagents away from the electrical or the heat sources. There is always a chance for exposure. I'll come to this later in my thing. So when you're using the personal protective equipments, the lab coats should be always the full sleeve. It should always be buttoned, and think of cleaning it, washing it at least very frequently, and don't put it on the hangers over the other aprons, because obviously the main concept of using the apron will get lost because the interior portion of the apron might get, the lab coat might get contaminated. And the gloves, yeah. So it is important to use the gloves and the right gloves, and you need to know when to change it. Even the slight evidence of the contamination, kindly change it, not till it gets the tone and the thing. So safety goggles is necessary. Face shield, not just the safety goggles, and the face shield. Probably if you have used the face shield while grossing and particularly taking the sections, it is important. Many a cyst which is filled with the fluid, we try to cut open, it jets on our face. Even if you are using the specs, inside the specs, it splashes on the lips also. 3 days you don't sleep later. So after that, do have. So the respirators, instead of the respirators, the most of the things, respirators, probably in the biosafety level 3 and 4, you might need the respirator, where the chances of aerosol do occur. So, but otherwise, the simple triple layer mask, N95 mask, should help you in protecting. So the technical procedure, so even though in our biosafety level 2, the exposure through the aerosol is very minimal, whatever you are trying to manipulate with the pathogens need to happen in the biosafety cabinet. It's a class 1 biosafety cabinet needs to be used, even though there is a minimal scope for the exposure of the aerosol. Don't do it on the open bench. And the pipettes, the mouth pipetting, I don't think it is happening at all. I think nowhere it is being practiced, but still, when you're using the mechanical pipette, don't push the air into the blood or the serum. So it can, there is always a scope for the creation of the aerosols. And even if you're pouring, if you're pipetting, you gently you need to pipette to avoid the aerosol that can get created. And centrifuge is very quite dangerous. You remember many of the adverse events which did happen with the centrifuge when they were working with the Bacillus anthrax, when you are homogenizing it, and they opened it up and the sudden exposure and the technologies did, we lost those technologies when the research do happen. It may not happen so frequently in us, but still it is important not to use the glass tubes, the glass test tubes, because there is always a chance of that breaking and contaminating the centrifuge. And it is always should be capped, closed, because if it is open and if you are opening the centrifuge after centrifuging the high speed the rotation, there is always a chance of high volume of aerosol that should have been created. And it is may not happen, but it is always important for you to keep that in your mind. Safety needle prick injury. This is the quite the thing. How much ever, whatever you wear, and if you are not attentive, there is always a scope for needle stick injury. So major thing what we need to remember is never try to recap the needle, or never try to remove the needle from the syringes. But after doing the FNACs, we are in a hurry. We want to push all the material fast and make the smear. In that hurry, it is always a chance for getting pricked. You may not believe, when I was in second year postgraduate, I was doing the FNAC. As such, doing the procedures, it is big tension for me. And that case happened to be a case of supratrochlear lymph node in a VDRL positive patient. So it's a small, tiny node. I was thinking why this man wants to do an FNAC for such a node, small node. And I was trying to enter, and it entered through the node into my finger. I didn't sleep for 2 days. Luckily, nothing happened. Otherwise, my wife never would have believed me. This event would have really happened or not. Okay. So there are certain definitive procedures. So when you're picking up the, when you're place the needle, when you would like to recap the single-handed methodology to recap. So place the cap on the bench top and try to scoop it to use the needle and use the only single hand, so that it will help you preventing the needle prick injury. Particularly when you are grossing also. So with the knife, when you are using, how much ever you would have contaminated previous day and washed it and kept, the next day when you are cutting after 2 specimens, it is already been contaminated. There is always a scope for getting the hand cut. So your mind should be attentive and try to prevent, because once it is cut, you can just open the glove and try to decontaminate and wash. Then again wear the glove and start grossing. That's the only thing that must be left with us. So there are certain That's a Pronto holder. You do have the Pronto holders now, so you don't have to remove personally. So you just have to press the press and it will fall off. So you can use the Pronto holder to avoid to an extent the needle stick injury that can happen. So the specimen receipt, and when you are having a large number of the specimen, this picture is taken just straight from the NCDC manual what we have. That's why the quality is bad, so I couldn't make it better. After seeing so many better PPTs, I was thinking and worrying, oh, that this PPT will come, what the rest of the people will think, but leave me for that. And whenever we have an accession room, this is a usual scene. The keeping all the specimen over the request form. And you remember, this is the glass bottle and a rubber cap. Even many a times, when it is being misplaced, when it's being carried to the laboratory, it might fall. And the small endoscopic biopsies or the screw-cut biopsies, it is very difficult to search back and get it. You should avoid using even many a times, the surgeon will push the small biopsies, the fat-rich the specimen into that, and after fixation it gets bloated up. How much ever you are trying to take out, it won't come. Invariably, we try to break the bottle and hurt ourselves. There is a scope, the potential scope to hurt yourself, and it is very important for us to not use the glass containers. Instead, the plastic containers wide opening with a screwed cap is much better. The thing, and never keep the sample on the request form, because once it gets contaminated, if it happens to be in histopathology, my postgraduates will be carrying that contaminated request form for 2 or 3 days, towing to one deeper with special stains. They'll be manipulating many times with the same request form. So it is important not to you keep the specimen. Instead, you can keep it in the plastic the thing. So cover it. Check the packaging integrity upon receipt. Place the breech packages in sealable container and decontaminate the container before further using it into the biosafety cabinets. And when you're storing it also, use it in a robust container, and preferably plastic, so that it won't break. And many a times we have the tendency to lift the container using the cap. So when you're using the cap, there is always a scope. If it is not closed properly, it can fall and the contamination to occur. It might be quite simple. Instead, we can hold the rest of the surface to the carry. That is a simple thing which we need to consider before this. The personal competence training is necessary when you are introducing any technologies. Show him the entire laboratory, a design of your laboratory, where the fire exit door is available, and what are the things he needs to take care for the safety. And when you're putting him in a job-specific training, he needs to undergo the specific training, and the competency needs to be evaluated quite frequently. And the safety and the security training is a part of the training which is necessary to be done. Decontamination of the waste management. So uncontaminated, it will go for the municipal waste, and the contaminated material, when reusing, the chemical decontamination needs to be done. And the contaminated material for the disposal, you need to, before disposing, before sending it to the third party disposal, try to decontaminate at the source itself before sending it to the third party disposal. Okay. And lastly, the liquid waste is quite frequently what we use. Should become the liquid waste what we generate. When we are generating the liquid waste, try to dilute it before putting it into the sewage drainage. And we do have all the drainage pipes is pointed towards one container, and where it has been fixed to the dosimeter, and where we will be treating it with the sodium hypochlorite solution at least for 6 to 8 hours or the overnight. Or dilute it before putting into the drain, and the drain should be connected to a proper dosimeter and should remain in the contact with the chemical disinfectant at least overnight before putting it to the drains. Many a times the chemicals what we use for the formalin and the xylene, many a times put into the drainage. This time when the NABL accreditor he came, he was very particular. How are you discarding your formalin? We said we are discarding the formalin, we are putting it in a container, diluting it, check for the pH. It is not less than the 6, it is not more than the 11, and then we are doing. We do it quite sometimes, not regularly, but still I did tell that NABL, he didn't agree. So we have to go to some Gomit company, so one who collects all the chemical thing from the industries, and we had to go to him. And there is no specified guidelines from the regulatory bodies to discard the individual thing. But what we need to do is at least to dilute before putting it into the drainage. Chemical disinfection is the common thing what we use for the surfaces. And remember, they themselves is very harmful. They should be stored and handled, used and disposed with a care, because they themselves are inflammable and toxic. So the sodium hypochlorite solution is the most common, the chemical what we use, but it is corrosive to the metals. And we do have got the bleaching powder, which we usually do to the toilets and the bathroom, where the spillage has occurred for the last time, where there also can be the liquid bleaching fluid can be used. Alcohol, 70% alcohol, isopropyl alcohol, or the ethyl alcohol and the methylated spirit can be used, where you cannot use the sodium hypochlorite solution, like the metal surfaces or the tabletops you can use the thing. And you remember, the alcohol is highly flammable and it can be misused otherwise. And the chlorhexidine is the solution disinfectant which you usually use for the hands, with the alcohol being the medium. Even when you're storing the chlorhexidine, you should be careful, and it can be inflammable. Emergencies, so it is not just this, it can be a fire accident, it can be electrical breakdown, and the personal health issues. The person working with that can develop the sudden MI and can collapse. At least your laboratory personnel should have an idea how to respond to the emergency condition that would arise in that scenario. Personnel must be trained in the emergency response and have the periodic refresher training in order to maintain the competency. So whenever there is a spill, what we need to do is immediately vacate the affected area. Do not enter the room at least for half an hour to 1 hour, depending upon the volume that has been spilled out. That is the time when you are allowing the aerosol and the droplets to settle. Then delay the long entry. If there is no central air exhaust is there, then you need to cover with the absorbable material. Then you add the chemical disinfectant and dispose it off later. So that is, and remember to post the signs indicating the entry is forbidden right in front of the spilled area. Occupational health is very, very important. To vaccinate all the technician, do the health checkup regularly. The possible exposure he might get on, at least try to do those tests and make sure he has not been developed or that particular disease. I don't go much detail about the chemical hazard. The chemical hazard come with the history of come with the potential for being toxic and flammable, and it is known to react with the other chemicals very aggressively, and it will be corrosive also. And when you are storing the chemicals, make sure in what the thing it is compatible with. You should not be storing the hypochlorite solution with the other acid, because the formation of the chlorine fumes will be very high. So it will, biosafety records do show that this chemical is compatible, can be stored with these particular other chemicals also. We need to keep a watch on that. We should never be keeping the acids and the acids above the shoulder level. The lower level should be the acid, because when you're manipulating, when you're lifting it, there is always a chance of that falling and causing the accidents with that. So always keep the laboratory safety guidelines for specific chemicals which you are using frequently in your laboratories. What are the, the formaldehyde 37 reacts violently with the strong oxides and the hydrogen peroxide. Should avoid keeping the formalin also and the sodium peroxide or the hydrogen peroxide similarly together in the same container. Avoid doing that. So there's one more about the chloroform. He also defines what are the antidote that can be used and what all you can store the chloroform also. So this is about the chemical disposal, safe.
Sorry, sir, for interrupting. We just have 5 minutes remaining for the session.
Thank you very much. I'll be finishing in 2 minutes. Yeah. Okay. So the safety showers and the safety shower and the IVA station needs to be very close to the laboratory. Okay. Electrical hazard, it's a big shock. So actually what I wanted to tell you is one of my teacher in good medical college found dead with her Mangal Sutra tangled to microscope. A simple microscope can be electrically, you should take care of the electrical hazard that can come along with even the simple microscope. It can not just give the shock, it can be cause the fire and the explosion. Remember, you should never keep the inflammables in the refrigerator. When you open the refrigerator, automatically the light will on, the thermostat. There is always a scope for the short circuit or the sparks to happen. And inflammable, when it is placed in the refrigerator, if you open, the sudden fumes can get ignited, and there can be a scope for the explosion. So never keep any flammable reagents near the electrical equipments. Test regularly for the earthing and the grounding system. Do not overload the electrical circuits, because the electrical device can generate spark, and do not use them near the flammable and volatile liquid. Never place the inflammable liquids in household refrigerator. The fire safety is the same thing. You need to know where the fire exit is there. Fire extinguisher, at least check the expiry date, and it is, at least you should know how to work. Sometimes when suddenly I think of that, or how to lift that and how to open, you will be always keeping in that mind. In between, some training should happen, how truly you are going to use that. And you should have a methodology to relax, be calm, and think of getting out of that place. When there is a chance of fire accident, try to switch off all the electrical appliances you do have, and whatever the biological material which you feel it is important, try to place it in autoclave, refrigerator somewhere, so that to prevent the further thing. Okay. So this is lastly about the waste management. So will be, I don't waste my time with the waste management, because if I get into it, it takes a longer time to finish. Thank you very much for giving me this opportunity.
Thank you so much, sir, for a comprehensive session on safe lab practices. We now have time for just one or two quick questions before we move on to next session.
You said you don't have time? Yes.
Okay, so no questions. So, as a token of our gratitude and appreciation, we kindly request Dr. Safia, HOD Department of Biochemistry, Apollo Hospitals, BG Road, to do the honor of presenting the memento to Dr. Dayanand.
Thank you. Thank you. Thank you.
डॉक्टर निवेदिता कहाँ है? डॉक्टर निवेदिता कहाँ है? So before we go for the next session, we just have a quick chat. कनेक्ट कर दिया सर ने, कनेक्ट किया? Okay. So before we go to the next session, our group quality and quality operations and service excellence head, Mr. Gaurav Loria, would want to address the gathering just for 2 minutes time, and then we'll continue with Dr. Nivedita. Just 2 minutes time.
Check. Check, check.
Gaurav, sir, over to you. Is connected? Gaurav, sir, over to you. Gaurav, sir, over to you.
Hello.
Hello, sir. You can start, sir.
Hello, can you hear me?
Yes, sir. We can hear you. You can start, sir.
Okay, so thank you.
Put up the camera.
A very
Put up
good afternoon to all of you. Thank you for having me here for this session today. First of all, I would seriously like to thank Dr. Manish, Rekha, Complete Lab team and Karnataka region team for organizing this conference on such an important and critical topic. Also would like to thank all of you as delegates who have taken out their time from their busy schedules to deep dive and understand the new advances in this space and understand how can we actually make it safer for our team members first of all, and how can we make it safer for patients also at the end of the day. So thank you for doing this. I'll not take much time, just wanted to request all of you to join for the 12th International Patient Safety Conference, which is happening in 21st and 22nd Feb in Delhi. I'm sure Rekha and team would have communicated to all of you, and so please make sure that you register and you do not miss this conference. For one single fact that, that there are really very interesting topics that lead us to the new era of patient safety that we are talking about. Also, we have separate specific tracks on lab safety where again very key important topics will be shared along with many other interesting topics. So our speakers list, our agenda, most of these things are already updated on the website and we are continuously updating that. So please feel free to reach out. Please do register before you go by the end of the day. And we really look forward to seeing all of you there at the conference. Thank you once again for having me here on the call and for all of you for attending this. Thank you. Thanks, Rekha. Good day. And good luck for the rest of the day. Yuvraj, I'm disconnecting.
Ma'am.
छोड़ दो अभी हो गया.
Next, we have an important and timely session on Go Green and Go Efficient, Sustainable Lab Practices. As healthcare professionals, we are not only responsible for patient outcomes, but also for minimizing the environmental impact of our work. Laboratories, being resource intensive, present a unique opportunity to embrace sustainability while maintaining high standards of efficiency and accuracy. To lead this session, we have Dr. Nivedita Jairam, Founder Director and CEO of Biotrexa Global Healthcare Private Limited, Bangalore. Previously, she was Lab Director and HOD of Biochemistry, as well as National Head of Operations at Triaster Sciences and Strand Life Sciences. She will guide us through innovative strategies and practical steps we can take to align our practices with sustainability goals, all while enhancing operational efficiency. Please join me in giving a warm welcome to Dr. Nivedita Jairam as we look forward to learning from her invaluable experience.
Good afternoon, everyone. It's such a pleasure to be among you all today, and I thank Dr. Swarna and the entire Apollo team for giving me this opportunity to be here today. I don't think the time is right, just before lunch when everyone is hypoglycemic. Such good speakers before me. And, I don't know if my topic is, that interesting as the previous topic. Anyway, the topic for today is go green, go efficient, and be sustainable. Now, this is the goal that globally all clinical laboratories are going. I don't know in India, it is taken shape right now, but I don't think we are going towards this goal with fast strides. All of us have to make this effort so that we make that impact on the environment. We lessen the impact on the environment, which is not only for healthcare, but it is for all the spheres of, employment. So the agenda for today, the overview, why sustainability in healthcare and laboratories, current challenges to highlight the environmental impact of laboratory practices. Objective is to discuss sustainable laboratory practices and their benefit. In the modern era, clinical laboratory plays a crucial role in the healthcare system. I think all of us as laboratory professionals should be aware of this, and we should take pride in the profession that we are. Whether people give us credit for it or not, we are important in the healthcare system to begin with. So laboratory often consumes a lot of environmental resources like energy, water, chemicals, plastics, etc. So it is pretty important for us to go green. As sustainability becomes the global priority, clinical laboratories are moving towards go green, go efficient approaches to minimize the environmental impact while maintaining their operational excellence. So it has to be twofold. What does go green mean? For a laboratory, what does go green mean? It refers to implementing environmental sustainable practices in our laboratory operations. So what does this involve? Reducing the waste generation, conserving water and energy, using eco-friendly products, as well as responsibly treating the hazardous material. So these are the cornerstones for going green. Now what does go efficient means? It focuses on optimizing our workflows in the laboratory and reducing waste to improve our productivity as well as to reduce the waste that we generate. What does this involve? Streamlining the processes. So we have to often look at the processes that are there in the lab and streamline it so that it reduces the environmental impact. Leveraging energy efficient equipments. How many of us have had a say in the equipment that needs to come into the lab, and how many of us have looked at energy efficiency? What is it? First thing that we look at? Cost. Okay, so that shouldn't be our call. As laboratorians, that shouldn't be our call. So as we go, I will tell you the various things. So first comes is leveraging so that we take in energy efficient equipments into our lab. Minimizing reagents and resources usage without compromising on the quality. So if we, when we are again deciding which equipments that we have to purchase, do we look at the amount of reagents that the equipment use? Do we do that? There are certain equipments along with the reagents will have several diluents, it will have several buffers and so many other things. But when you look at another equipment, these reagents or resources are lesser, which are more environmental friendly. So we have to look at energy efficiency, we have to look at, minimal use of chemicals in our laboratory. Now going green and efficient, what is the importance? So environmental impact is reduced, that is what the main agenda. Cost saving too. Everyone thinks going green and being efficient is expensive. No, over a period of time, there will be cost saving that happens. Regulatory compliance. From 2018, government has been very, very strict about the carbon footprint. Okay? And so they are bringing in lot of regulations. So if we go green, we can be regulatory compliant. Enhance reputation. Take pride in corporate social responsibility. Okay? So your reputation among the healthcare also will improve. Innovation. Getting eco-friendly technologies. There are so many technologies. Yes, finance, economy is important, but getting in eco-friendly technologies also should be kept in mind. Now, as we go on, I will tell you, when we use the newer technologies, it needn't be expensive. Okay? So what are the core principles of going green and going efficient? Reduce, reuse, recycle, energy efficiency, water conservation, safe chemical management, digital transformation. So try to get all your data and everything digitally done. So you save paper. Okay. What does sustainable development mean for healthcare provider? Okay. For each industry it is different. So what does it mean for a healthcare provider? Meets the needs of the present without compromising the ability of future generations to meet their own needs. Okay? You save the planet so that the future also meet their needs without any difficulties. What is the current status of sustainable healthcare in India? What do you think? Incorporating sustainable practices seem like a long-term goal now, as of now, okay, or even optional. Some people may go green, some people may say, that is not feasible by us, with no immediate urgency. So that is where we are now. Government is bringing in regulations, government is pushing us to do better, but that is where India is now. What's new in JCI for sustainable healthcare? JCI was the first accreditation body. The new Global Health Impact Chapter, JCI 8th edition, introduces environmental sustainability standards. These standards aim to help healthcare facilities worldwide reduce carbon emission and promote sustainable healthcare practice. NABH also has now come out with its own. Okay, so the SEBI introduced business responsibility and sustainability reporting in 2021. This is one of the regulatory bodies. The National Accreditation Board for Hospitals, that is NABH, is updating its accreditation standards in 2024 edition to include sustainability goals. So everyone is becoming aware and everybody is trying to make things more green, efficient, sustainable. So go green, go efficient align with creating a sustainable and safe environment. Basically, it should be sustainable and it should be safe. So what does go green means? Go green means supporting the conservation of Earth's resources and supporting the preservation of personal resources. So ways to go green. The first and more important is energy efficiency, reducing water usage, reducing waste and recycling, using environmentally friendly materials and investing in green tech solutions. So today I will focus on two things. We will talk about one tool and one green tech solution whom we have interacted, we will discuss about that. The rest of the things are, known to all of us, okay? So, energy efficiency. Survey in 623 hospitals, 357 public and 266 private between the year 2021 and 2023 revealed that Indian hospitals, both government and private, occupies about 6% of commercial building and consumes approximately 14% of India's commercial electricity consumption, which the government is aiming to bring down at least to 10%. So what are the steps to reduce energy consumption? All of us know, this is nothing new, all of us know. So turn off the equipment when not in use to save energy. Other than the 24/7 labs, the equipments that are used routinely can be kept on, everything else needs to be eating, and the technician should be aware of this. Use energy efficient lighting systems such as LED. I think most of us have moved on to LED lights. Invest in energy saving equipments and appliances. Okay, so we take extra effort to understand the energy efficiency of any equipment, whether small or big, before we purchase it. Choose equipment with high energy efficiency ratings to minimize power usage. Regularly maintain equipment to ensure optimal performance and energy efficiency. So we train and retrain our technicians and tell them how important maintenance of everything, not only our big equipments, maintenance of every small or big equipment is important to save energy and to perform better. So optimize heating, ventilation and air conditioning HVAC system for energy conservation. We have our ACs, heating systems. How often are they maintained? How often does somebody come and does maintenance? If we do this, we can save a lot of energy. Encourage staff to adopt energy conscious practice in daily operations. I think among all these points, we have to focus on training our staff. Okay, because of accreditation, we train them on safety, we train them on codes, we train them on spill, we train them on all these things. But I think this should be the topic that we should train all the technicians and tell them how efficiently we can save energy. Okay. Enerva is a startup NGO based company that we have worked with earlier. They work closely with the Energy Conservation Ministry of Karnataka, and these people have a very, this is not the only startup, there are several startups. I will talk about them because I have interacted, I have seen their installations, and I've understood them well. So most of the electricity that we get through the grid, 70% is from coal, another 30% is hydroelectric and other sources. So how can we reduce this? The carbon footprint is here only. So how can we reduce this? Renewable sources of energy, there are several of them, and we should look at this. Now the cost, when we think of it, we will not take the Bescom energy, let's go to a renewable source. What do we think? Oh my God, it's going to be expensive, right? No, it is not so. The commercial per unit is 8 to 9 rupees per unit. But if you use a renewable one, it will be 5 rupees or less. But there is an initial investment that we need to do. But that is only one time. And you can reap the benefits of this for a lifetime. Okay? So what does this company do? They have, the similar solar system. Okay, not most of us have solar systems at home also. So that works only when there is sun shining, right? So here the solar system powers the hospital when it is day. It also powers the hospital when it is night. Okay. So what it does is it stores the energy in the batteries and then it can be used in the night. Okay. When there are power cuts less than 2 hours, it has backup for that also. How many UPSs are there in our lab? For every machine there will be a UPS. We will have, stored so many UPSs. It will create so much heat. We need a room for it. This source also has, company also has this. There are several companies like this. These companies have also a UPS battery separately, which is again solar powered. So when there is a breakdown in, breakdown can happen anywhere. So when there is breakdown of main power, this can take over. Within milliseconds, the changeover will happen and this can happen. So what is the difference now? UPS use lead acid batteries. These have more environmental friendly batteries. UPS batteries have to be changed every 2 to 3 years. This can be changed once in 15 years. And this is absolutely silent, noiseless. It doesn't need a separate room. We have a UPS room, right? It can be kept anywhere. You can go and keep it, outside in the hospital. It comes in a DG, in a container. You can keep it next to the DG also. And then these big hospitals, okay, more than 100 beds, use something like 3 megawatts per hour. If you have to make this investment, it will be about 5 crores, which you will get back. Okay, return of investment will be in 3 crores, in 3 years. And after that, you have this whole system. You just have to pay maintenance for the system. The second advantage for this is you don't have to keep it in your hospital or in your healthcare center. You can keep it anywhere in Karnataka and through the grid it will be supplied, extra transmission charges. So by doing this, you are completely eliminating getting electricity through the normal grid. So what do? You save coal, you save the environment from the, from mining coal. So this is one of the innovations. They have, so EV batteries, BMS, remote monitoring, BESS, solar system integration. They also have a digital platform which will tell you if anything is wrong, whether anything has to be corrected, where there is a short circuit somewhere, whether it has to be attended to immediately, it gives alarm, and all the things are in a mobile application. Okay. So they have done several small lab projects, medium projects, hospitals, and rooftop solar for most of the industries. This is one of the innovations where we can completely get rid of the normal grid current that we get from DISCOM. Okay, there is an initial investment, but within 3 to 4 years, all this you'll get the return and then it will be free henceforth. The second most important resource that we have to conserve is water. So water is most important resource on earth, and now not globally, there is a drive to save and reduce water usage. So hospital laboratory water need. The laboratory, the laboratory requires, medical grade water. Yes, the CSST requires that, OT requires that. So for a medical grade water, usually 4 liters of raw water is required to make 1 liter of medical grade water. So if you look at this diagram, almost 42% is used in sanitary. HVAC uses about 23%. Medical procedures are only 14%. Laundry 5%, and the catering and food services use about 9%, and the rest miscellaneous is 9%. So where can we save this water, where, in which aspect? Now I will go to it. So water usage is estimated 10 to 20 liters per day in a very small lab and 100 to 200 liters per day for a larger lab. Water intensive equipment like autoclaves, glassware washers, water baths require higher amount of water, and quality control, regular water quality testing has to be done. Now it is done in most of the accredited labs because it is one of the requirements. Now if you, we have just taken a few equipments and see how much water they have used. So water volumes to be sourced, which must be sourced, purified and safely disposed after use. So when you look at it, you know, you will have to look at all this before choosing your equipment. So non-vitreous, I mean, we'll say dry chemistry and wet chemistry. So dry chemistry, wet chemistry almost, I mean, approximately uses of 30 liters of water per hour, whereas dry chemistry doesn't. And over a year, about 97 lakhs liters of water can be saved annually. And this is quite good. Okay. Now I am coming to a tool. This is used by most of the hospitals. This is used by most of the hospitals now. Okay. Aquagen, which is a FluxGen company. So here, continuous monitoring of quality. Okay. So there are sensors that are, we have mechanical sensors at home, isn't it? With our tanks on top. So when it raises up, you know the pump stops and things like that. Those are mechanical ones. Now these are sensors which are in various places. It will be placed in 15-20 major spots in the hospital, and it will give continuous data from all these points. Okay, quantity, quality, level and automation. So it is completely automated. There is no manual intervention. The maintenance people get, you know, get all the required measurements where they can act on. Then intelligence and alerts, leaks, overuse, levels, quality, everything is available in their mobile. So compliance reporting. Now there are several organizations that are regulatory bodies now, which help us to comply to the regulations that is set by the government. Water saving, energy saving, carbon credits. What does this mean? If you conserve water, you also conserve energy. How is that? We have a raw water treatment plant which uses energy. You use energy to filter. You use energy to heat the water. Right? In all these places, energy is used. So when you reduce the consumption of water, automatically you reduce the energy use also, which reduces the carbon footprint. Now 100% human intervention free. Okay, no one can go and do anything in this mobile app. Conserve water up to 30%. I will show you 2 examples. Save on water related energy cost up to 18 to 20%. Now we'll just see a few examples. So this is one of the hospital in Coimbatore. Okay, so what it does is it gives us end-to-end water management system in 15 water points. Analytics and alerts are always given. You know, where there is water leakage, water wastage or anything, it will sort of notify them. So this is yearly water consumption before Aquagen was introduced. 2,73,750 kiloliters. After it was introduced, they saved up to 2,45,280 kiloliters. So 10% save.
Ma'am, sorry for interrupting. We have 5 more minutes remaining.
I'll finish. And here, you know, all the hospitals usually buy water. So they were spending 43 lakhs, and here it is come down to 23 lakhs. So similar thing was done in St. John's Medical College, where they had the approximate 9,700 cubic meter of water being saved. Now reducing waste and recycling, minimize single-use items, proper segregation of waste, recycle laboratory plastics and glassware, limit chemical waste, digital documentation so you save paper, efficient resources use. So sustainable chemistry, green chemistry and non-toxic list, again we go back to the same thing where we use chemicals which are not toxic. So all of us know this: prevention, reduction, recycling, recovery and disposal. Safe and sustainable chemicals, minimize and control, eliminate and remediate. So regulatory bodies, so from 2016 biomedical waste the rules are there. So you are improving the patient management in the hospital. You have to use environmentally friendly materials, choose eco-friendly reagents, use sustainable packing which are biodegradable, use non-toxic cleaning supplies, invest in eco-friendly lab equipments, and paper alternatives. Kindly replace papers, reduce plastic use. So this is the way we invest in green tech solutions. You adopt energy efficient equipments, then you utilize renewable energy sources, implement smart energy management systems, invest low emission laboratory equipments, optimize water use with sustainable solutions, and support green innovation. Now what are the benefits of sustainable practice? Preparing smart hospitals for climate risk challenges, economic benefit of sustainable operation, regulatory compliance ready, staff safety and engagement, and contribution to environmental mitigation. So going green, going efficient is not fancy. It is the need of the hour as of now. We have to save energy, conserve energy, water. We have to choose equipments that are energy efficient, which uses less chemicals, less reagents and resources, and we should be very conscious of the environment and prevent environmental impact as much as possible and become responsible. In conclusion, the adoption of Go Green, Go Efficient system in the clinical laboratories is a vital step towards the sustainable future. We can only sustain if we go this path. By embracing environmental responsible practices and operation efficiency, laboratories can achieve a balance between high quality diagnostic services and minimizing the environmental impact. So the hallmark is reduce the environmental impact and introduce environmental sustainable practices in your lab operations so that you minimize the environmental impact, you go green, you make your lab more efficient, and you serve the patient better. Thank you.
We now have some time for just one or two quick questions. Okay, now moving forward, as a token of our gratitude and appreciation, we kindly request Dr. Anjali Arun, Consultant Pathologist and Lab Head, Apollo Hospitals, Mysore, to do the honor of presenting memento to Dr. Nivedita Jairam. Thank you so much again, ma'am. Your valuable insights were not only enlightening, but a reminder of critical role we play in building a healthier planet while maintaining efficiency in our work. We will now break for lunch. We will reconvene at 2 p.m. Thank you and enjoy your lunch.
Request all to please take your seats. We'll start the session in 5 minutes time. Thank you.
Good afternoon, delegates. Please take your seats. We will start the session in 5 minutes. And it's a gentle reminder for the delegates to get the KMC credit points. Please give your KMC registration number to our organizer outside the hall. It is a request to delegates, please take your seat. We will start the session shortly.
Namaste everyone, please come to the hall. We are starting the session in 2 minutes.
Kind attention please. I request everyone to please gather inside the hall immediately. The session will start in another 5 minutes. I repeat, I request everyone to come inside the hall in another 5 minutes. Session is going to start.
It's a gentle reminder to get the KMC credit point. Please give your KMC registration number to our organizer outside the hall. Welcome back, everyone. We hope you had a refreshing lunch and are feeling energized for the session ahead. To start the afternoon session, we have an important topic that addresses the well-being of lab professionals. Wake up call for lab professionals, ergonomics. Ergonomics is often overlooked in our day-to-day work, but it plays a critical role in preventing workplace injuries, enhancing productivity, and ensuring long-term physical health. In the fast-paced environment of laboratories, small changes in posture, workstation setup, and movement can make a significant difference. Today, she will share practical insight and tips on how lab professionals can create a healthier, more comfortable, and more efficient working environment. Please join me in welcoming Ms. Elizabeth to the stage.
Good afternoon, everyone. We are here to discuss about patient safety. Are we really thinking about our safety and health? Yes, we have to be. Okay, let us talk about ergonomics. What is ergonomics? Ergonomics is a science of designing workspace, tool and tasks to fit the user. So, in this session, we will explore how proper ergonomic practices can help to minimize physical strain, improve posture, prevent long-term injuries. By the end of the session, you will be having a better understanding of how simple adjustment can make a significant impact on your well-being. Let us start. What are the ergonomic risk factors in the lab workspace? As you all know, most of the lab tasks involve sustained posture and repeated movements that, along with awkward posture, can cause discomfort in the muscular body system and cause musculoskeletal disorders. What are the common musculoskeletal disorders you can experience in the lab setup? Mostly people complain of neck and back strain. It can be also shoulder pain, may cause rotator cuff tendinitis, tennis elbow or lateral epicondylitis, carpal tunnel syndrome and trigger finger. And don't forget, like you can also get lower back pain associated with the constant sitting without back support. So when we think about lab work setup, most of the time people are adopting a sitting posture. How can you modify that? So if you are using a microscope, make sure that you are adjusting the workspace before you start the work. Always position the microscope so that your neck is in a good posture without bending, and make sure that your shoulder is in a neutral position, not in elevated posture. Take a proper back support to sit, and don't forget to use a foot rest. It can reduce the strain on your back. And remember that whatever good posture you adopt, it is necessary to change your posture. You cannot engage your muscles for a long time in same condition. So we'll talk about that later, about micro break exercise. Just observe how do you work in your workstation. Can you modify your work? This is the arm rest, whether you can adopt to give a proper arm support to reduce the contact pressure. Every simple adjustment what you make in your workspace is going to help you out. And one more thing, it's not the ergonomic thing, not only to take it in the workspace, whatever activities you do, most of us will be using mobile. So how to keep your mobile and how to keep your laptop, you have to be you have to take care about it. I just took a workstation. I know that there are many workstations in different labs, but how to sit properly, how can you adjust your sitting posture? Just observe in two scenarios where she can modify it. So there is a lot of difference in the back strain, or you can say that the pressure what you feel in the intradiscal area with the back support and without back support. And make sure that the knee and thigh is at 90 degree with a proper foot support. And most of the work in the lab involve like the arms are not supported, where the arms are hanging. So when you are using a pipetting activity also, you cannot rest your arm. So make sure that arm is not elevated, but it is at the side of your body. It's in neutral position. Okay. So where the task involves long time standing, make sure that you are keeping the foot on a footrest. So it will give a relaxation at the back. So if you are standing for a long time, just elevate your foot on a footrest. You can reduce the pressure at the lower back. Biosafety cabinet. What are the proper ergonomics you have to take care? So here also the seating you have to be taken care, back support you have to be taken care, and footrest, and extended access opening and sloped viewing window can reduce the strain at the neck and also strain at the eye. Most of the even a biosafety cabinet also, you have to be in a sitting posture for a long time, and repeated movements are there. Make sure that you are breaking your work in between. Okay, microtomy ergonomics. Here you may be experiencing more strain at the neck and the shoulder, and also the repeated rotation of the wrist and finger can cause more strain at the wrist and also finger. How can you reduce the strain? By keeping the neck in a correct posture, taking a proper back support, and also break the work in between. Here the shoulder is not supported, you cannot help it, but make sure that you are doing a micro break exercises to relieve the strain on the shoulder and the neck. Okay, so the eye strain, it's common with people who are using microscope and computer. So how to reduce the strain on the eye? You can follow 20-20-20 rule, where take a break every 20 minutes by looking at an object of 20 feet away for 20 seconds. And always keep the monitor at one arm distance. Take care of the glare and defy dry eye. Make sure that you are blinking very often. Usually we blink 14 times per minute, but when you're straining or when you're focusing an object, so our blink rate will reduce. So make sure that you are blinking the eyes or closing the eyes in between, and proper lighting. Okay, so good posture, good health always starts with good posture. Okay, whether you are standing or sitting, okay, make sure that you are adopting a good posture. Okay, so whether you are hunching your back, keeping the neck forward. Okay, so whenever you adopt a bad posture, it causes excess strain on the musculoskeletal system. Okay, so now we are going to talk about micro break exercises. What is that? Muscle may fatigue when sitting or standing for extended period of time, and injuries may slowly develop. That means if you are sitting at a proper posture also, it can cause muscle fatigue. Pay attention to sign of fatigue. We really do that when we are engaging in a work. Even if we feel tired, we keep doing the work. So recent research suggests that micro break exercises, that means 2 to 3 minutes of light intensity activities for every 30 to 40 minutes can reduce the risk of injury. So what are the micro break exercises? I just included a few of the upper limb stretching exercises and the neck exercises. So I think you are able to understand. If you want a demo also, I can ask somebody to come and do a demo if you really require. Otherwise, I think you are able to understand. So this is to break your posture, your side stretch, your tricep stretch, and especially it's you know that you have to stretch your neck, your back of the neck, paraspinal muscles and trapezius muscles. The last one is for your hamstring stretch. The minimal stretching activities you have to do in between your work. So don't neglect about your lower back and the spine. So if suppose if you are sitting for long hours, whether you are driving or you are working for long hours, whenever after you getting up, if you give a back stretch, you will relieve lot of strain at the back. Okay, the first exercises. The other one is the forward flexion. The third posture for the quadricep stretch, the side stretch, and the rotation movements. This is, see, we are not only focusing about stretches, we are also have to think about our strengthening. This is a static neck exercises for the neck muscle strengthening. And the upper back, the scapular muscle stretches. Okay, so one point to understand is that chin tuck, it's a small thing, but it's going to benefit you a lot. Okay, so from the neutral point, you have to just take it back and come to the neutral. Okay, not forward. Okay, neutral to take it back and come to neutral. This will, whenever you take a long posture in focusing on something, you can just take it. Okay, during the work also you can do it. And also just stretch your shoulder back. Let the retractors work. Okay, most of the time we use our shoulder in a protracted posture, the forward posture. Okay, the shoulder should be aligned with our ear, but are we really? So it's always in the front, right? So it has to be retracted and just squeeze it. Okay, so you can feel the difference. So that and the chin tuck exercises. Okay. So don't forget to strengthen your core muscles. The core muscle is the one which is going to give a trunk stability. Okay. So the first two are the cat and camel exercises for the spinal mobility. The bird dog exercises and that's a modified curl up, and the side plank and the back extension exercises. So this need to be done at least 3 to 4 times in a day, in a week. Okay, each exercise can be done for 10 repetitions. The last, what is our physical activity? Okay, the physical activity for the adult, the WHO demands at least 150 minutes of moderate intensity exercises, that means endurance exercises, or 75 minutes of vigorous intensity exercises per week. As you all know, the endurance exercises is going to give cardiopulmonary capacity, improve the cardiopulmonary capacity, okay, and also improve our VO2 max. The research says that after 4th decade, there is always a 10% decline in VO2 max. And after 50 years, it is 15% of reduction in VO2 max. So we can decide how much activity level you can be in at the later age. So your physical activity at present can decide how much active you are in future. Okay, so you have to really work on your endurance capacity. So we should not only see, most of the time when we think about exercises, we think, okay, let us go for a walk, brisk walk. So that will come only in the endurance exercises. What about strength building? 2 to 3 sessions of strength training is required in a week. per week. What is the strength training does? So it is going to reduce sarcopenia. What do you mean by sarcopenia? There is an age-related loss of muscle mass, quality and strength. Okay, it starts at the 4th decade of life. Okay, and also our osteoporosis. So osteoporosis you know that osteoporosis cannot be prevented, but we can reduce the impact of developing osteoporosis by doing impact exercises or resisted exercises. So both of the things are really required along with your micro break exercise. So one point to understand is that minimize sedentary time and work on, like along with our work, you have to take a personal time to work out. Okay. Okay. I hope you got an insight about micro break exercises and how to go about your work and exercise balance. Okay. Be active and be healthy. Thanks.
Thank you, ma'am, for such an enlightening and practical session on ergonomics. Your insights have highlighted the importance of prioritizing health and well-being in our demanding work environment. On behalf of everyone, we truly appreciate the time and effort you have taken to share your expertise and valuable recommendations. Thank you once again for a truly impactful session. As a token of our gratitude and appreciation, we kindly request Dr. Shrishmita, Consultant Pathologist, Apollo Specialty Hospital, Jayanagar, to do the honor of presenting the memento to Ms. Elizabeth.
Now, we will move on to our next session, which focuses on point-of-care testing. As healthcare evolves, POCT has become an essential tool in providing timely and accurate diagnostic results, directly impacting patient care. The ability to perform tests at or near the site of patient care, whether in clinics, emergency settings, or even at home, offers significant benefits in terms of quick decision-making and improved patient outcomes. This session will focus on the latest trends, innovations, and best practices in point-of-care testing, particularly in how these developments can contribute to enhancing patient safety. We are delighted to have Ms. Rupa Sharma, Service Operation Manager from Siemens Healthcare Private Limited, as a speaker for this session. Please join me in welcoming Ms. Rupa Sharma to lead this exciting and insightful session.
Good afternoon, everyone. As the introduction is already have happened, I'm going to talk about the point of care testing, and I think most of the healthcare professionals are aware what the point of care and how the point of care testing have evolved the healthcare professional to give the faster and the quick result where it will help the patient safety, and it is going to immediately the patient intervention with a very small or the minimum time duration. So with this we aware that it is going to give you immediate and the immediate action where the intervention from the laboratory is got minimized, and we can do these testing at the bedside of the patient or even in the emergency department. This is not only going to give the benefit for the patient who's having the immediate results or the immediately treatable results, but also help the economic condition, right? So the pricing has reduced, the time duration has reduced, and this is helping the patient to get the quicker and the faster decision by the clinician, having the result within a 1 minute of time in their hand. So what could, if I want to emphasize what is the better or what is the better decision making have given by the point of care. So we know that it is the point of care testing which has minimized the timeline. It has reduced the, so dependency on the laboratory. So it has come up as a decentralization of the laboratory. Right now there is no only the centralization required where the sample need to be sent to the laboratory. We have to wait for the sample preparation for a certain period of time. And later on the results, when the results come, it is already a time taken by the clinician to treat the patient, right? And this is not only helping the patient, but it is with the global, all the global, the world. Now they have coming up with the mobile treatment, ambulance treatment, in-house patient safety. So these have evolved with the different technology, what it is right now available with the point of care testing, and the different company have come up with all sort of different technology which is going to help the healthcare professional to treat the patient with a minimum time duration. As I've already talked about, it is not only the India or it's the global. Global has changed the complete point of testing portfolio in a very synchronized manner. If we look into the emergency department, if we look into the patient safety or patient testing at the home care testing, the ambulance part where you can able to treat the patient or at least stabilize the patient, having few of the testing. Now, if you look into this particular slide, which is talk about the assured, right? So now to give these brief understanding, generally, this assured principle where come as the ideal characteristics of the point of care testing, it has come from the WHO. So when the WHO have thought about on the sexually transmitted disease, especially on the HIV, so it has briefed what they are looking when I'm looking for a point of care testing, what is my prime requirement to treat the patient? Is it only the quick response or is it only the the low charging or the low cost value? No, it is have multiple characteristic and the multiple feature required. If I'm going for a point of care testing, my only motto is not having the quick testing with the qualitative release, with the result, because anyhow, with 1 minute of result, the 1 minute is so crucial where the decision can be taken for the patient. So it has come with the assure principle which talk about the affordability where I'm looking for the affordable test. I'm looking for the sensitivity where I am going to reduce my false positive, my false negative. I'm looking for a specificity, so my test should be more specific. I'm looking for the user friendly. So if you look for the point of care testing, it is not only the laboratory professional who is the laboratory in charge, who is working at the laboratory, they are not the user. It could be the user by the nursing staff, it could be the user by our DMLT, MLT student, it could be the user of all the MBBS and the MD doctors as well. So it should have user-friendly approach where the testing can be done in a very appropriate manner where it can be done by any healthcare professional with the minimum time duration. I'm going to talk about R that stand for the rapid. It means that the rapid testing. So where I'm going to do the rapid test, which will help again giving the result in a in the probable manner. Now the refrigerator, robot means I don't need multiple inventory management, I don't need multiple storage capacity. The requirement should be from the point of care testing. It's like that I have an instrument, I have a reagent cartridge, I have a test, I will insert it and the test can be done in a quick timeline. Equipment, so which says that not needed. What it does mean when I say equipment not needed? It means that when I'm sending a sample to the laboratory, it required a sample preparation, right? If there's a serum sample, I need to wait for a certain period of time, the clotting can be done, then I'll go for a centrifugation. Once the centrifugation will done, then I'll separate my serum, or the vacutainer is available with the, serum separator, vacutainer is available. But there is no requirement of any additional equipment. I can have my instrument in hand as a handy. I can put 1 drop or a 2 drop for a patient sample and the test can be done. But to meet the criteria, I have to be done as a delivered faster way, right? So it complete the assured platform where the WHO has categorically come up with the idea when I'm using a point of care testing devices, it should fulfill these ideal characteristics for a standard way of doing the test on the point of care devices. So as my first introduction slide only, I have discussed the decentralization of the laboratory, right? So now with all the point of care devices, whether it is a glucometer, whether it is a ABG instrument, urine sample, or a cardiac triage instrument has come up in such a way, in a broader way, where the dependency on the central laboratory has minimized. Now if I am, if the dependency has decreased, it's not only the cost getting impacted, the cost get reduced, the dependency on the sample, the dependency on the laboratory professional has reduced. We have to wait a longer time. So the turnaround time for the test also got improved. So that's what it is talking about, how the POC instrument has decentralized on the dependency of the sample. So there are a lot of portfolio has come up where we can revive the CLIA guideline where there is no requirement of certain, so they have come up in the devices which creates and which comes with all the features which could able to cater your healthcare professional to deliver a results in a very appropriate manner without having the dependency on the laboratory or the central laboratory, right? Now what all the technology has come up? So we know there is a urine strip is going for a very longer time, then it has come as a meter like glucometer and the strips, that dependency has coming up for a very longer time, then it introduced the urine strips, then it comes as a microfluid, then immunoassay device, a nanotechnology which has coming up, and then the DNA. Now with the COVID, so you have seen that with the COVID, the test dependency on the PCR testing, and to understand the quick or the rapid card testing of these virus detection it has increased drastically on these kind of outbreaks or the what we have seen in the last 2 years, the biosensor. So these are few technology has come up where the point of care testing can evolve better way, and it has increased its credibility. It's not going to depending on the laboratory, but I can do these testing at the bedside of the patient. And when I say bedside of the patient, I am not only going to minimize my timeline, my affordability, my cost reduction also has impact. And now we always talk about what is the advantage, right? But at the same time, we are also saying that if I am doing a testing with the POC instrument, will that be so quality results which I am going to get from the instrument? Because there is no proper channel or the proper way of measure the what is kind of a specificity and sensitivity. But with the new generation kits, with the new generation technology, it has evolved drastically, and now we are going to look on what is the advantage on the POC testing. So the first thing is that you can get the result in a very quicker way, right? You no need to have the dependency, okay, we have to wait for a 2 or 3 hour of a timeline. I have a result in my hand with a 1 minute of duration. It's not going to. I think there is some problem with this, but I'll talk about what we are trying to say here. So the rapid testing, rapid results where the duration is minimized, cost effective, limited result, limited timing, affordability have increased, easy test. Now there is no healthcare professional required certain criteria to meet to run this test. Now the home kit is also available where the home testing for the elderly patient, for critical care patient, if they are doing the test in the critical scenario at the home testing manner, they can able to do with these point of care system and the point of care devices which is available with us. Now what is the initiative or the government has taken to improve these, adoption, especially on the India level? So there are a lot of government initiative has happened. So in that, one of the initiative government has trying to, prevail, the prevalence, and they are trying to have the more advantage where the ruler criteria could able to cater with these devices, where the accessibility of these healthcare is not very drastic and it is very minimum. So they are approaching the, government has come up with different criteria or the different scheme where these preventive healthcare can be manageable with these devices. Affordability, so affordability will also a concern when I look for the Indian market or the Indian scenario, because the kind of the population what India is having has the drastic difference with the poor, middle class, upper high class and the high class, right? So everybody is not accessible for the kind of testing required which certain people can able to take from the particular hospital or the healthcare professional, but the rural people will have that limitation. So with that criteria, government has come up with this scheme where these tests, these point of care testing devices can able to cater more and more patient and able to help them to treat their treatment, and they can able to, at least they could able to understand what is the problem and what is the clinical condition going on with them, and they are able to going for a further treatment if it is required, right? So as I have already talked now, because on the other part of that, if you know that we always say India is a diabetic capital, it is not only the India is diabetic capital, but if you look for a different chronic disorder like, you know, hypertension, all these, even the cardiac condition has drastically increased in a certain period of time. Last 5 to 10 years, it has drastically increased. So to improvement on all this, these kind of a prevalence is required, and we are focusing on this adoption of the POCT instrument where you can able to access or able to do the test in a very quicker and the faster manner. So COVID, we have, again, I have touched upon on the COVID part. So we have seen that during the COVID, there is a dependency. Now, if you look into, even if you look for the healthcare professional as their adaptability, before going to the hospital, there is a vital treatment, you know, vital, they will say that, okay, you check on your vital. So in that vital, we always used to take care of the height, weight, BP, and the temperature. Now, after the COVID, after this COVID era has changed, and now the saturation is also one of the vital has added in that saturation. And then now, if you look for all the people, if you go and maybe the people who's sitting here in their house itself may be having the oximetry, right? So if there is a breathlessness, people are aware like there is a breathlessness, and if there is some condition where the respiratory is not, so they will quickly putting on their, in their finger, they're putting the oximeter and they're checking whether saturation is minimized or is the saturation is the up to the mark or not. So these also have given the platform where the point of care can not only require some expertise to understand whether the treatment required or not, even the minor with the small devices to understand what is my clinical condition is going on, whether I need to seek any healthcare professional guidance or I could able to monitor my condition with this. So before, for a longer time, the diabetic patient, they used to do the testing on the urine strips, right? So they used to monitor their diabetic or the sugar level with either the glucometer or even in the urine if they are if they have developed the microalbumin ACR condition as well. So this has come up something. So this also I need to highlight here where the impact of the COVID also have changed the adoption of the POCT instrument in a larger way. Again, for the HIV patient, if you see here, the treatment required, that has significantly dropped down from 14 days where the person need to take the treatment of an antiretroviral treatment, right? So in that way, the point of care testing and the immunoassay testing has reduced with the 144 days of the timeline to 14 days. And even the treatment what people are going to get, it is in the double in number. Same with the diabetic patient, as we have also mentioned now, the diabetes, as we always hear that India is a diabetic capital. So in that, if you can see here, not only the glucose, like your fasting, your PPS, not only going to give the idea, but the HbA1c has now come up. Now with all the HbA1c in the POCT platform, the HbA1c treatment or HbA1c test detection has required more and more importance where to know whether it is a pre-diabetic or it is required the longer duration of the treatment. So that has gone up to 95% requirement of the HbA1c testing, and it is happening in the with the requirement of the patient condition. So with the POCT, it is not always we say that it is required only bedside, but the impact of your hospitalization has reduced because of the adaptation and because of the treatment. So when you see that the dependency, as I mentioned in the previous talk, it is mentioned that the 27% of the dependency on the central laboratory had reduced, because now you have every department, whether it is an emergency, whether it is a CCU, ICU, neonatal, you go any department, you have a certain setup of an instrument available, and these instrument is going to help you or help patient in a faster way of treatment, right? Now, what is the current trend? So generally, as I mentioned earlier, the question always have with the POCT whether it is going to deliver you the quality results or not. There is always a question, if I am going to get a result from a POCT instrument, is it comparable with my laboratory instrument or not? Is it possible for me to depend on the POCT instrument result and start treating the patient? That dependency is still there, but now the trend has changed. Now there is a more development. It is not only the portability what we are looking for, but now if you look for the different technology has come up. Now there is a cartridge based system, there is a single use system. Now the instrument is coming with the inbuilt QC management system, so they can manage your QC. You can able to see the LJ graph in the point of care instrument. It is not the earlier you are using the strip is having some kind of a problem and you are getting the wrong result. But with the different evolvement and the different technology development, you are coming up with the modernized instrument which is comparable with the laboratory instrument. Also, I would like to highlight here the data management system. So earlier we always say that okay, my hospital or my laboratory is a LIS connectivity. Whether my POCT instrument can capable to do that? No, previously that was a limitation, but now with the development you can able to have the data management system. So there is a one hospital having multiple instrument in the multiple department, but I can have the connectivity as a data management, and I could able to retrieve my all patient data. I can have the history of that patient, and I could able to monitor what all the data management system could able to give me. This is not restricted only the patient management, but also giving you the it also gives the idea of managing the inventory, whatever the inventory required for the instrument, whether my instrument performance is good or not, whether what is the QC is happening on today's date, whether the calibration has failed or whether I have to look for any kind of a calibration data. So all this can be compactly impacted on the data management system, and you can sit in one room and you can manage all your 4, 5, n number of POCT instrument, and you can monitor the performance of that one. So these kind of development have created value added on the point of care testing. So as I mentioned, the single use of the devices, right? Now there is a single cartridge system has come up. There is a single QC cartridge system has come up where you can able to install it and the cartridge can be expiry. There is a shelf life of it, and it is going to help you more and more on that the quality management part too. But there is a challenge. It always says that there is a challenge. What is the challenge? The main challenge here I would like to highlight on the regulatory part. So the way the regulatory is supposed to handle on the point of care system, it was not very much synchronized. The regulatory or the government has to come up with the proper channel on the how these instrument can be regulated and what could be the criteria met. So if you look for a NABL or NABH criteria as well, so there are so many things was not taken into consideration when the point of care devices will come up, right? Cost and the affordability. So some tests, like not all the point of care tests, I would say that it is very cost effective, but yes, that has decreased drastically. But it also need to have a out of pocket, requirement, because India is not running as an insurance based policy on the healthcare. So there is a requirement, you have to pay out of pocket for that. So that also have a burden on these rural patient or a tier 2 or a tier 3 kind of a city patient. So what is the future care on the India, right? So what we are looking for when we are talking about what is the point of care is the future in India, whether these tests would able to have more impact, how the laboratory, the central laboratory or how the automated analyzer have created a different in the testing portfolio altogether. So we are looking for enhancing the patient care. So enhancing the patient care is quality result with the minimum timeline, with the minimum interference, and also it gives the quality result. So that's what we are going to look for, the enhancing the patient healthcare portfolio wise. It is beyond the traditional setting. So it means that we are not only going to go talk about the emergency department or a healthcare department, right? But now there is so much clinic has come up, small bedded hospital has come up, ambulance care, critical care has come up. Even you can talk about, in the people, there is some article they are talking about having some small equipment at the gym level, because there is a lot of incident is happening on the gym side as well, right? So this is also going to enhancing the patient treatment. Other point is the talking about on the data driven point. So which I have talked about, data driven is mainly on the data management system. So it is not only empowering the healthcare, giving the data management system, but it is going to help the complete healthcare professional of particular hospital, where you are having all the system controlled by the data management system, and you have visibility on what data have come up with my instrument, and these data have what is the authenticity of these data point. So it means that you are monitoring a real-time data. And lastly, it will be the cost effective. Yes, they are coming up with a very small instrument. So you have seen, like maybe some of your hospital would be using, so you have a mobile devices kind of a system where the point of care testing is happening, where is a handheld devices where you can move around with the hospital and do the testing for the patient. And lastly, it will, as I mentioned, it will be with your the different single use of cartridge, right? The different cartridge based system could give you the more and more visibility on the instrument performance and the quality performance. So this is how it is going to go ahead with the point of care testing in the future, and I think hope you are adapting in your hospital as well. So the quality part, the cost effective part, and the immediate treatment to the patient is what the POCT is all about. So thank you everyone. So these are my references from where I have taken the data point. So once again, thank you so much.
Thank you so much, ma'am, for such an insightful session on point of care testing. May I kindly request Dr. Jayashree, HOD Department of Microbiology, Apollo Hospitals, BG Road, to do the honor of presenting memento to Ms. Rupa Sharma.
Adversary, I now consider it as an ally because it reduces the pressure on TAT. Acknowledging the presence of Dr. Thuppil Venkatesh, I want to ask your opinion on laboratory oversight on point of care testing equipment. And I'm sure you are aware that in 2022 modification of NABL, whatever the next edition, point of care testing should come under the lab is what NABL has said. I mean, it's optional. We laboratorians have always looked at point of care testing. Let it be there. We don't want, God knows which nurse is using. God knows whether she will be there in the next shift, even if I train her. Whether she will be there tomorrow, that is another question. Whereas in laboratory, we have a certain continuity. We consider our people trainable. And we can have some follow-up on quality control, etc. When we ask just the glucometers to be brought to the laboratory for quality control, there is significant deviation in the time when they want to come and get it done. So, what is your opinion about laboratory oversight and NABL accreditation of point of care testing? And sir, afterwards your comments. Thank you.
actually have covered a lot of things, as I clearly mentioned, so NABL, regulatory guidelines really required for the point of care testing. What I can see.
So the problem what I can see here, the NABL have not taken into consideration a point of care testing in a very systematic way, if I can say that, right? So there are some instrument can come under the NABL, and there are some instrument like strip-based method which you see. So those things required the complete intervention from the NABL point of time. So when I am saying NABL, so NABL have to understand there is a point of care testing has from strip-based method to there is a benchtop system available where you can able to control, you can see the control result, you can see the LG chart, you can see the calibration report. But when I go back to the strip-based method, so it is a single strips, so there is a chances of error is high because the manual intervention is high. So according to me and according my suggestion, I would always say that the NABL have to understand from 1 to 10. So they have to incorporate a systematic way where all the POCT device could come under the one way of in the platform of the accreditation. It's not like that if I am having the strip-based method, I cannot compare my strip-based method with one instrument which has the benchtop system, which has all the feature available, and it can give the laboratory in a such a way that laboratory, whatever the laboratory is doing for the automated analyzer, it covers that. So that is the part from the NABL. I think NABL have to come up with some systematic way of keeping the POCT instrument in that particular accreditation body. That's first part. Now second, as you mentioned, yes, there is a challenge with the nursing staff or the different healthcare, because when I look for the central laboratory or the laboratory system, they are ongoing, their training is very much given importance, not only from the personal point of view, but if you look the HOD of the department or the biochemist or the microbiologist or even the pathologist, they keep on calling all the company professionals to conduct the training in a regular basis. But in the POCT device, when I'm keeping different laboratory, they try to escape for the training because they say that yes, for them there is a dependency on the patient care is more because they have allocated certain patients to be taken care in a time duration. So for them having a training, that's become a challenge. So once they keep on not having the training, they miss something. That's why you may get the results sometimes, pre-analytical challenge will become more and more often. And also there is another part I would like to highlight here, because see, when as a recommendation, so when as a laboratory, if as a company, as a manufacturer gives some recommendation that you have to do this testing as a certain way, or you have to collect a sample in a certain way, or you have to take sample in a 2 ml of volume, the laboratory personnel try to do that. At least 90% of them, they try to do that, what the specification and the recommendation has given by the manufacturer. But in case of POCT devices, when you keep on giving these specification, somewhere they are missing that gap. And that creates this kind of an issue where the results not correlating with the laboratory. And I think I would, as you have clearly asked that, this is my personal clear, I would say that laboratory always to have as a POCT equipment for an audit purpose. You have to, as a monthly, as a 6 monthly, as quarterly, the laboratory, if the central laboratory can hold that auditing thing to the POCT devices in the multiple location, so then that gives the understanding to the nursing staff or a nursing superintendent or whoever is the person, they could able to give that importance, yes, this instrument need to be taken care in a certain way. So this is what I could say that, ma'am. Thank you.
Sure. Thank you so much, ma'am. Please stay.
I thought I will come and deliver my talk and go. Now you have put me to shield, excellent speaker. You don't require any shield. You have done a very good job. I tell you one thing about point of care testing, it's not new. About 700-800 years ago, in Indian system, there was a point of care testing to detect jaundice. Grandmother used to ask the grandchild to piss on the rice. If the rice turned yellow, she used to decide, bring medicine. It's not new. Point of care monitoring is new. We have not touched upon that. After the modern medicine, modern laboratory practices, point of care testing was considered as an independent division. There was a separate standard, 28270, ISO 28270, or 22870 was the standard. That standard had only 8 pages. And the standard mentioned any laboratory wants to use this 22870 must be 15189 followers. That is the main laboratory standard. Medical laboratories requirements for 2 things, quality and competence. Remember, quality and competence. When we talk about quality, we have quality control, quality assurance. Of course, point of care testing is a bedside testing. For immediate treatment to be provided, immediate decision to be made for point of care monitoring was a waived test. It's a clear, it is a FDA waived test. That means point of care testing for a long period of time did not require the EQUAR proficiency testing. But the moment in 2022, they merged this point of care testing standard with the main standard, 22870 died, they buried. Now we have only one standard. All the examinations, we don't call it as testing now. Testing is the word used for clinician. He will test patient. Laboratory will examine the patient sample. The laboratories, whether in India somewhere, whether it's NABL or IAS, whatever accreditation body, they will only look at 2 things. Whether the laboratory has quality resources for even point of care testing, whether competent people are handling that. Whether it is the laboratory staff, whether it is a nursing staff, whether it is a OT staff, please remember there is no concession. They should be competent. Competent means they should have some qualification in handling POCT. They should have some training in POCT. They should have sufficient experience. There is no question of doubting them. Of course, what you said, regular auditing is required for everything, for point of care testing also. Now, point of care testing is no longer waived test. We have to participate in external quality assessment scheme. That's where there's some improvements going on. But I will tell you one good news. Very soon, in another 4 or 5 years, point of care testing will die. I'll tell you what happened. They'll put a chip inside your body. The chip will come in contact with circulating fluid. That will send with your body electricity, a signal through RFID to your external device like cell phone. It will get the data of circulating drug, circulating whatever it is. And that message goes to the clinician. And that clinician will immediately write the order and it goes to the pharmacy. In the pharmacy, a drone will carry the medicine and deliver it to the person. Oh, everything will happen. I was in Kyoto meeting. I tell you, fantastic. They've already come out with this. With AI, it will become much more. Anyway, till we continue to use your glucometer or whatever it is, let us follow what you said. Very good presentation. I compliment you, congratulate you. Thank you.
Now, as a token of honor and appreciation, I request Dr. Jayashree to kindly give memento to Ms. Rupa Sharma.
As we continue our program, we are now shifting our focus to a critical and thought-provoking session on role of lab in patient safety, moving towards zero harm. In healthcare, patient safety is paramount, and the role of diagnostic laboratories in ensuring safety cannot be overstated. Laboratories are central to the accurate diagnosis and treatment of patients. And as we continue to push towards a vision of zero harm, it is crucial to examine how labs can contribute to reducing errors, improving outcomes, and safeguarding patient. Now it's my privilege to introduce our next speaker, the legendary Dr. Venkatesh Thupil sir, Professor Emeritus, Department of Biochemistry at St. John's Medical College, Bangalore, who will be speaking at this session. Please join me in welcoming Dr. Venkatesh Thupil sir.
Is this working? This is working? If they get up, they may go out. Okay. After lunch, two things are difficult. One is to give a talk, another is to listen. There are two difficulties here. I don't know how. We are going to encounter. See, all of us are from diagnostics division. Any clinicians here? Oh, I am very happy. Only two of you. Okay. I am extremely happy to have you here, sir. The World Health Organization in 2024, you know what they declared? On 17, they said, my health is my right. You remember? Your health is your right. Even clinicians' health is their right. Patient's health is the patient's right. I differed. I am on the guideline development committee of WHO. I said, I do not completely agree with you. I said, of course, my health is my right, I agree. Why my health is getting deteriorated? There are three I can identify. One is, my environment is getting deteriorated. See what happened in Delhi, causing respiratory problems, with smog, smoke and fog together attacking us. You know what happened in your industry? Industrial pollution causing disturbed health. I said, my right is also my environmental health. My right is also my animal health. People eat chicken and mutton. If they are sick, will they not become sick? My health or our health is also our agricultural health. Indiscriminate use of pesticides, insecticides, fungicides, are they not causing problem to us? Clinicians will know. But is it possible to detect it? Do we have a laboratory? Are we estimating pesticide, insecticide in the food we are consuming? My health is one health. My right is one health. Have you ever thought about that? I wish we had some veterinary university experts and somewhere I saw one line, veterinary. Our agricultural department, expert should have been here. Where is that safety? What is safety? We have hundreds of definitions for safety. Now I had prepared this for World Health Organization, this talk, but I am using it for some of them I am using it today. I will not take much time because 5 minutes ago I should have finished my talk as per your schedule. 3 o'clock I should have finished. 2:15 to 3 was the time given. I don't want to bore you. Friends, one thing I tell you. Global health is one health. It is not just allopathic health, Ayurvedic health. Because today, patient has taken Unani medicine, tomorrow he comes to you. He takes allopathic medicine. Sample comes. You don't know what are all the medicines the person has taken. Do we have a system to measure drug-drug interaction? Okay. Who is the patient? Who is the patient? Are you the patient? Yes or no? I tell you, is there anybody here who never took single medicine in the past? Raise your hand. No hand will go up. Is there anybody here who will not take any medicine in future till they die? Nobody will raise an hand. That means, my dear patients, we are all patients. We are concerned about ourselves. For that, we have to have evidence. That evidence-based medicine is what we are going to talk about. Now, accreditation. Accreditation is a very simple thing. It is not going to give you assurance. It will only give some guidelines to be good. But good is the enemy of the great. Which laboratory in this country has 100% methodologies they are adopting is accredited? Is Lalpath Lab, Apollo or Metropolis? I have been assessing laboratories for last 25 years. 16 accreditation bodies. I have established 4 accreditation bodies. But I tell you, there is not even a single laboratory which is 100% accredited for everything. Accreditation is not given to the laboratory, accreditation is given to the methodology, what they adopt. Laboratory got accredited for GOD, POD method for glucose. After 1 month, the cost went up, the hexokinase cost came down, they changed their method, but they continue to say, we are accredited for glucose. Is it not fooling the people? I've seen big boards in Hyderabad and other places. Our laboratory is accredited. Accreditation is a voluntary process to assure safety to users. It is not mandatory. Nowhere in the world accreditation is mandatory. As a result, providing safety to the patient has not become mandatory. Accreditation to some extent provides assurance of safety. Second thing, what drives accreditation? Whether hospital accreditation, laboratory accreditation, what drives? Only 3 drivers are there. Our clinicians know. One driver is third party payment organization, insurance agency. Then they will get money reimbursed. Provided they come to Apollo, which is accredited hospital by NABH, 5th edition or 6th edition, our NABH assessor is sitting here. You did the course along with me. You remember in Bangalore that day there was a big problem. Then there's another driver. My mother at the age of 95, last year she passed away at the age of 100, at the age of 95, I wanted to take her to a laboratory to get blood glucose done, knowing very well she was not diabetic. She was eating all the laddus from anywhere. She loved it. She was not diabetic. I told her, I want to take you to a laboratory. Oh, because laboratory people, they would do it free of cost to me. You want me to get pricked? And I said, no, you are already 95. You want to get it checked. I took her to a laboratory. In the laboratory, technologists came, phlebotomists came to draw the blood. My mother asked, what are you doing? I am going to draw blood, Amma. Why? You want to estimate blood glucose. Why? Your son told us to estimate blood glucose. I said, is your blood glucose method accredited? 95-year-old lady is asking. That technician went inside and came, no, we have applied, we are not accredited. Then in that case, I will go to another laboratory. This is public demand. Have we ever created public demand to make patients safe with reference to laboratory? There is a third driver, very interesting driver. Here, 1, 2, 3, 4 laboratories are there. 3 laboratories are accredited for all the methods. This laboratory is not accredited. What will happen to that laboratory? She has to shut down. Why? People think going to that laboratory is not safe. Therefore, people judge about the safety from laboratory. These are the 3 drivers. Therefore, we know who is the patient. Coming to safety is ensuring quality care. Laboratory safety is one side of the coin. Clinicians, other side of the coin is ensuring quality care. Now, protecting patients from harm. That's we all know. We are not intentionally causing any harm. In fact, there are a number of, even Socrates has said earlier, what is patient safety? Avoiding prevention. Avoidance, prevention, amelioration, adverse outcome, injury stemming from medical care. Why? Though WHO said, where is the laboratory here? Is there any mention about laboratory? I'll show you a few slides. Tell me where laboratory has some responsibility in assuring patient care or patient safety. Okay, here, how many laboratories are there in India? I tell you, 3,75,000 medical diagnostic laboratories are there only at the government sector. I'm not talking about private. I'm not taking Apollo or other laboratories. Only at the government level. 3,75,000 laboratories. In primary health center, they are doing urine protein in a pregnant lady. They are doing malarial parasite. They are looking at the hemoglobin. Is it not a laboratory? Are they providing dependable, reliable, accurate, sensitive, reproducible result? Are they causing harm to the clinician depending on the data? It is harm is not to the patient, its harm is to the clinician. The patient can go to the court tomorrow. How many clinicians had to, come out of their profession in US? You know that? How many laboratories were shut down in Australia and in USA? Because of some error. This error, unless we take care of that error, we cannot think of patient safety, clinician safety, medical. Today people are, why they are attacking the hospitals? I don't know whether they are attacking the laboratories also. Every day we read in the newspaper. Why is that? Why we have become victims of that? Okay, the absence of preventable harm to a patient, reduction of risk of unnecessary harm associated with healthcare to an accountability to a minimum. Friends, a common source of patient harm must discuss medication error. Can laboratory detect it with therapeutic drug monitoring? Therapeutic drug monitoring, how many laboratories can provide that? Who will pay for that? There are chromatographic system wherein you can detect more than 90% of the drugs sold in the pharmacy, and most of the patients have directly procure these drugs from the pharmacy. Or go to anybody's house. We did a very small study. Go to anybody's house, including your house. You have some medicines which are date expired. You have not thrown it. Can it cause some harm? Is there a possible? Of course, 300 million surgical procedures performed annually, accounting 10% preventable patient harm. When you come to diagnostic error, 5 to 20%. This has been published in Lancet. Okay. Now, to look at evidence-based medicine, laboratory. Why patient safety matters with particular reference to your area. I'm not talking about the clinicians, your area. It's because, you see, the most dangerous place to live or work on this earth is laboratory. I worked in a laboratory at St. John's Medical College. We had 200 beds. Most of the beds were occupied. Sometimes all the 100% occupancy. Each bed had 2 or 3 different diseases. Same patient having more than 3. All their samples used to come to laboratory where it was air conditioned without any air exchange facilities. Same one split air cooler, and I don't know how many of us were exposed to that harmful air. We don't know. Still we are alive, thank God. Now, patient safety is one, worker safety is one, and also safety of all those who are involved in the sickness caring center. I don't want to call it as health caring center. We don't care for the health. They don't come to you. Only sick people come to you. We care for the sick. Every hospital, go to any bed, there is no healthy person. There is only sick person. Therefore, they are all sickness caring centers. But you may not like to put a board as sickness caring center. It's a healthcare center, but healthcare center, real healthcare center, where laboratory had not played any role, that is municipality. If they have not kept your drain clean, mosquitoes away, then we fall sick. They are the real healthcare organizations. We belong to sickness caring organizations. When they fail in their duty, then we get business. And do we have any laboratory support to bring these two together, to take care of the health of patients, safety of patients? Okay. Now, patients coming to laboratory, or hospital, they demand only 3 things. If you are a patient, you will demand your safety. If you are a patient, you will demand your comfort. If you are a patient, you will demand your rights. What are those rights? What is the cost of this examination? What is the turnaround time of this examination? These are the simple things. Every one of us, we have the right. These are all our rights. Now, patient safety, if all the rights are taken care by the diagnostic division, patient is safe, clinician is safe, everybody is safe. Okay. There is a system approach. What is the role of laboratory? To address these issues, a system approach to patient safety is very, very crucial. I'll come down and this is too close to me, big, big letters. Okay. I am also looking at my safety to my eyes. Now, when you look at this, we have 8 resources in any organization, including your bathroom or a kitchen. We have 8 resources, laboratory also, or a clinic also. One is the manpower, competent manpower. Number 2, material, quality material, fitness for purpose, doing right thing at right time for right purpose. Or number 3, management, committed management, passionate management. If management and is not committed and passionate, Apollo would not have grown to this level. Then we have methodology which has to be validated, verified. If not, there is an error. The error can occur, there could be harm. And then, of course, mechanism. You are all sitting here, you have not shut down your laboratory or your clinic. Something is, you have made some alternative arrangement. There is some, what is called mechanism. Apart from that, the equipment. The equipment is another resource. If equipment is not properly calibrated and properly maintained, can cause harm, can cause error. Error can cause harm. Today I saw incidents and accidents. Even I wanted to use the washroom when I entered there, it was just then washed. I was about to slip. That is, I saw the wet floor. It's an incident. If I had slipped and broken my hip, I would have come to your hospital. That is an accident. Now, you see, and also environment. Environment has to be controlled, regulated and monitored. Are we doing it? A safe working environment. In fact, my previous speaker talked about ergonomics in the laboratory. Very well, narrated, beautifully narrated. Then I changed my position on the chair, how to sit and what to do so that I will not get back. Now, competency development. Patient engagement, engage patients and family in a policy development. Are we involving them so that if you call your patient, like you treat that patient like a younger brother or an elder brother, he will never go to court even if you make a mistake, even if laboratory makes a mistake. Are we doing it? And incident reporting. Now, we don't report incident because of fear of punitive actions, isn't it? Suppose I go and tell my boss my centrifuge is not working, you only must have spoiled, my salary is cut next month. The punitive action. Therefore, where will safety come when we work under pressure, under stress, under threat? These are some of the most common things which we have to look at. Global action on patient safety, of course, it was launched in 21 up to 2030. Now, next 5 years from now, WHO said only 2 things you have to do. Only 2 things to achieve total patient safety. You know what they said? One is hand hygiene. Another is infection control. If you would take care of these 2, everything will be taken care. If in the laboratory or many hospitals, I don't know in your hospital, when I walk in, they say hand sanitization. Near every ward, when I walk in, hand sanitization. I do that. Then, when I walk out, nobody is asking me to hand sanitize my hand. That is the time when I have to sanitize. Otherwise I'll go and play with my grandchild with some infection from the hospital, which I might have carried in my hand. I would have touched railing before I leave. I would have touched some door handle before leaving. Have we made anything like this mandatory to provide safety to patients, safety to family members? No, we have to think it over. Therefore, this is what World Health Organization has stressed upon. I am not reading the slides. National patient safety goals are identify patients correctly, laboratory level action. I tell you, Joseph came for prosthetic specific antigen. And our technologists did it. They did not get, they said some enlarged prostate and passing urine is difficult. These people got confused. Then they somehow made some PSA, total PSA, free PSA ratio to agree to that condition. It was Mrs. Thomas urine. Something can happen, Are we truthful to ourselves? Then only that safety can be assured. Of course, improve medication safety, reduce healthcare associated infections. The laboratory has a very big role to play. And prevent patient falls. What laboratory has to do? Tell me. Think it over. In the ward, patient falls. one sentinel event. Has laboratory, do they have any role to play? We say, no, laboratory has nothing to do with. I tell you, laboratory data on some electrolytes, some hormones will give a reflection of instability of the patient. Such a patient should be protected. Laboratory data should be used. Half the time laboratory data goes to the file, patient is already discharged. Do we do that audit? What is called laboratory outcome? Patient benefit audit? We don't do. Because lack of communication. One of them is, some of them we keep talking, promoting health, providing health, protecting health, powering health, performing for health. In all this, laboratory medicine has a very big role to play. Our clinician, if I ask any one of you to name some super specialties in a hospital where you are working, tell me, madam, one super specialty in the hospital? Cardiac, very good. Tell me one super specialty. Psychiatry. You have put me to shame, I tell you. Our clinicians are waiting for your advice. Am I right? From the laboratory? Laboratory data, laboratory interpretation, so that you can treat the patient. If they are super specialists, you are super specialists. Pathologists, microbiologists, do you agree with me? If I say they are the super specialists, please hold your head high and walk around with a board saying I am the super specialist. Then you get that responsibility. And I tell you, that leads to better patient care, better patient safety. Anyway, common patient safety risk when you talk about in the standard, latest standard, international standard, 15189, 15190, 15194, these three standards. 15 is for medical, 1 is for in vitro diagnostics, last 2 digit 89, 90, 94, they are all guidelines provided. They are all applicable to diagnostic processes and highlights errors. And 85 times in the standard we talk about risk. It has not yet happened, it is yet to happen. Therefore, laboratory has a role to play to prevent risk, manage risk, mitigate risk. But still, they may mitigate, there is a residual risk. Every risk you may completely mitigate, completely cover, but still there is a residual risk. One example I will tell you, I am a vegetarian. When I went to a restaurant, I wanted dosa. That was a non-vegetarian hotel also. I asked, do you make vegetarian? Yes sir, we have a separate section. I said, okay, I want vegetarian dosa. I don't like the egg or the fish. He said, okay, I will make. The dosa came. Then I took one piece of dosa. It had the smell of a fish. I said, what is this, man? You told me that it will be vegetarian. I told you I don't like fish. Sir, we washed that tawa with vim, gin, rin and all kinds of things. What to do, sir? Still there is some fish smell left. Are we communicating this to our clinicians? Residual risk? As long as we do not communicate residual risk to the treating clinician, patient is at risk. Where is the patient safety now? Therefore, these are all some of the simple, common things. We don't need big textbooks and big laboratories to understand, realize. It comes with this experience in life. I tell you, wrong medication can be laboratory can detect. Wrong dose laboratory can detect. About 30 years ago, one professor, he was called Professor of Urine. His name was Dr. Yagna Narayana Iyer. He was a fantastic speaker on urine. And we used to call him Professor Urine. He had told long ago, 35 years ago, 1 drop of urine you give me, I'll take it to the lab. I'll tell you whether this urine is from humans or animals. If it is from human, whether male or a female. If it is male or a female, old or young or child, I will tell you. And whether anything wrong with that, what is the disease behind that. So see the power of knowledge from the laboratory, which gives us powerful tool to take care of the safety of patients. Because there is no wrong treatment, wrong medication, wrong approach. Okay? And wrong patient, allergic reactions, our laboratory can easily detect. And drug interactions, I told you, we have to have holistic approach towards drug. Let us not look at only allopathic drug, because today the world is, you get nutraceuticals, you have Ayurvedic, homeopathic, and all kinds of drugs, drug-drug interaction. Do we have a separate section to deal with that? And medication duplication, we can always check in the laboratory through therapeutic drug monitoring. Okay? And medication monitoring errors, and these errors can occur at any stage of the medication. A laboratory can come into picture to detect. We are like investigators. We are like Sherlock Holmes. We can probe into that and find out which gene is defective, where exactly, which level of the family they have acquired this disease. Of course, root cause of patient safety issues, and communication breaks down between laboratory and clinician, or the human error, lack of training. Madam has mentioned about training. Inadequate staffing because of point of care testing. They said maybe they don't belong to us. They are nurses, we don't train them. We train them today evening, they are there, tomorrow morning they may not be there. We have every justification to protect ourselves, and ineffective policies and procedures. And how do we improve? Implementing evidence-based practices, laboratory plays a big role. Conduct regular risk assessment, laboratory plays a very big role. Foster culture of safety, laboratory plays an important role. And encourage patient engagement even in the diagnostics. And of course, technology to improve safety. We have gone into non-invasive procedures. Okay, we don't have paracentesis, thoracentesis. Today capsules can be sent inside the body to do what endoscopy was doing. There are technologies improving. AI is coming to the picture. Of course, risk assessment, identifying, assessing, prioritizing, implementing, monitoring and reviewing at laboratory level helps the entire healthcare organization. And of course, this you must have already covered. I will not go into this part. I will straight away go to, because time is also one of the crucial factor. I will skip this risk because there is some session on risk. And diagnostic safety for the patient safety is the key factor in any healthcare organization. And of course, I will skip this. I will straight away go to conclusion. Patient safety is a critical aspect of healthcare. A relevant image such as healthcare professional with a patient should be displayed at places. And patient has a role in patient safety. That's what we are talking about. Ask questions, understand treatment, patient, as a patient, because I said my dear patients, therefore we also have to follow all this. Thank you very much for this.
Thank you so much, sir. Your talk today has been a cornerstone of this program, inspiring us to pursue excellence and work collectively towards the culture of zero harm in healthcare. I kindly request Dr. Anjali Arun, consultant pathologist, Apollo Hospital, Mysore, to do the honor of presenting memento to Dr. Venkatesh Thupil as a token of our gratitude and appreciation.
Similar, that ISO 15190, 90 is the guide, 1 is in vitro diagnostics, 15 is the for medical. Yes, ma'am.
Thank you so much, sir. There is a gentle reminder, doctors are requested to share their KMC registration number to our registration desk to avail the KMC credit point. And also we are having a poster presentation session after the panel discussion, so please be with us.
Now, after such an inspiring session, it's time for us to reflect on ourselves. Our next session is about us, the healthcare professionals. We dedicate ourselves to the well-being of others, often at the cost of our own mental, emotional, and physical health. The demands and stresses that comes along with caring for patients can take a significant toll on the caregivers themselves. This brings us to an important session today titled Who Heals the Healer? We are honored to have with us Dr. Arun Kandaswamy, Professor and Head of Addiction Medicine at NIMHANS, Bangalore, as a speaker for this crucial discussion. He is an expert in the field of addiction medicine and mental health. Please join me in welcoming Dr. Arun Kandaswamy to lead us through this enlightening and necessary discussion on the importance of healing the healer.
Adauchar, I would like to thank the organizers for inviting me to this program. I'm an odd man out over here, I suppose, because this is about lab safety. But lab safety or any safety, if it doesn't include our own mental health, it doesn't make any sense. Unless we are safe and we are healthy, we may not be able to produce quality results per se. So in that way, I would agree this invitation. I bring greetings from my alma mater. This is our 70th year of existence and Platinum Jubilee celebration. Let me start with this quote from Isaac Asimov. Your assumptions are your windows on the world. Scrub them off every once in a while or the light won't come in. This is extremely important because we all go with a prefix notion that things have to be in a particular way. Unless we keep ourselves open, if our cup is not empty, then we may not be able to learn or provide too. I have certain conflict of interest, although I am not a lab professional. My conflict of interest is that I'm married to a pathologist, so I do have a conflict there. I've used some of the photographs and some information from the World Wide Web, so it's only for academic purpose. I have taken the help of AA. I use AA, right? So I would like to make it in 3 parts. One is to give an introduction to mental health itself, because you're an audience who are not used to this, I assume, and then move on to the silent struggles of the healers. I include lab professionals as the healers. I did had a discussion to start with whether it will only fit in clinicians or it will also include diagnosticians. I believe that the diagnosticians are also healers because they assist in healing process per se. And obviously I had a discussion with my wife. She strongly believes that she's a part of the healing group. And also the part 3 is about nurturing the nurturer, give some ideas and tips into our own mental health for healing. Introduction into the mental health. See, Dr. Venkatesh has already alluded into this slide. Any illness in the current existence has contribution from all these 3 spheres: biological, psychological, and social. Now, biology comes from what I am born with, whom I am born to, what kind of risks which has been added to me through that, and my psychological aspects do contribute towards various behavior of me, from acquiring an infectious disease to acquiring a non-communicable disease. And my environment, I don't need to explain more. Sir had given a very nice way of looking at how environmental toxins add to anybody's ill health. It's not only the environmental toxins which are direct influences, there are environmental aspects of parenting, what happens in school, what happens in the academic settings, and various other areas. Like my personal work field is addiction, how access to some of the substance could contribute towards one's own mental health. Now, each of us are very, very unique in a way, and that's the beauty of nature. None of us are alike. We have been born with certain traits which are again unique. When those traits meet with our own environment, right, and that becomes a different level of permutation and combination. So, when we have to understand a person, it has to be individualistic, it has to be personalized. And when we are looking at some kind of management with that, it also has to be personalized. So, the best person to manage ourselves is us, right? Because I know how filthy I am, I know how good I am. Who else could be the better healer than myself? Yes, there are illness where we need to take care of that through professionals, but there are other aspects where I need to focus on myself. Now, this is where the mental health continuum. This is not a black and white kind of situation. It moves from being healthy to being ill. And this is a spectrum, and nobody falls in this extremely healthy part of it. In fact, even the extremely healthy part also includes things like I become emotional about certain things which happens in my environment, right? It could be simply that a woman going through her own premenstrual phase. This is healthy part of it because that is also a part and parcel of the nature itself. And then there are some things where we are slightly easily inflammable with things which happens in our environment, or what happens at home, or what happened within ourselves. So that is another group. And then some people are more than what these kind of normal variant, but still they are not very ill because they are able to perform whatever they are supposed to do, but they are not personally satisfied, or people around them are extremely satisfied with them. And people who are ill, where significant amount of dysfunction has happened in various dimensions of their life. So mental health is not a black and white. It passes through a continuum, and it changes across person, and within a person across timeline it is different. So how mental health issues develop? I have a simple way of putting it here. See, this is a gun. Will it fire with the current status? No, it will not fire. The chambers are loaded now. Will it fire? No, it will not fire. Somebody has to pull the trigger, right? And I assume that the cartridge which is getting filled are the biological vulnerabilities, what we are born with. And the trigger is from the environmental vulnerabilities. So when this biological vulnerability is there with a person, and then they meet the environmental vulnerability, that's when the expression of phenotype happens. The whole mental illness or substance use related issues can happen. And it is the same for non-communicable diseases too. Even in now communicable disease also has been shown to be having hereditary risks. So are the medical professionals or paramedical professionals, health professionals vulnerable? If we create an MCQ, this will be the answer. Right? We need to select from one of this. And why so? That's where the silent struggles of the healers come in. I look at our vulnerability as a health professional in 4 concentric circles, right? The first one and the core of it is that it is very similar to all the general population, not anything specific to health professional. It could be their personality, it could be what is happening in the environment, right? Anybody could be affected by it, and we are not immune to it. We are also going to be affected by it. And that's the first level of vulnerability. The second level of vulnerability is that specific developmental vulnerabilities, what one go through while they were growing up, which is very specific to each person, right? Some people are subjected to poverty, some people are subjected to living in an environment where gun violence is very common, right? People coming from Northeast or Kashmir are very different from people coming from Bangalore and Tamil Nadu, because here the life is very different. There it's a very different life. So the developmental vulnerabilities also contribute towards one's own mental health, how they look at the life, how they perceive things around them. Third is core professional vulnerability. When we enter into this profession, what kind of vulnerability we accrue? When we are entering into vulnerability, most often things are the same as the general population, but once we start entering into it, our things change. From some kind of idealistic tendencies come to us because we assume that we are immune, because we are reading about it, so we are immune to things, and we are the best patients because of that. Right? We tend to treat ourselves most often. We don't approach for help. Often that happens to us. And it's also about how we enter into it. Once we enter into it, we'll stop all the things which were buffers to us. For example, the friendship changes. Your own identity change, right? From whoever you were, this person, you start going up, especially with doctors. We start putting a DR, and then our whole attitude and aptitude towards life change, right? And that a lot of idealistic thing comes in. And in fact, one of the third line in the today's this conference brochure is that get it right and make it safe. That becomes a mantra to us. Not anything is more stressful, according to me, than that, right? Get it right, right? Make it right and make it safe. I understand it's for the patients, but then the person who is sitting on this side of the table also is going through the same. Right? And then specific professional vulnerabilities. It varies from everybody. It varies across men and women. It varies across people who are in different stages of their career, what an intern is going through, what a retiring physician is going to go through. It varies across things. Specialities are very different, right? What a clinician goes through is very different from what a microbiologist, biochemist or pathologist is going to go through, right? What an emergency medicine physician is going through is very different from what a surgeon or a psychiatrist is going to go through. Nothing is insignificant. Everybody is having their own way of approaching life, right? Approaching their work, and the stress is very different for each of them, but nothing is inferior. So I try to look at some of this speciality of laboratory professional and their related issues. Like I try to put it in this 5 different headings. Obviously, I'm sorry if some of these things are known to you, or some of these things might be not acceptable to you, but this is what I have read, I have listened, and I have observed from my own group of people. First is the occupational stress. High workload and burnout. Right. Quite a few labs, including the lab which I am a budget controller, is having understaffed. Right. They talk about being understaffed, and it's not only in this country, all over the world people do talk about the same thing, and that leads to excessive workload. Right. The whole aspect of TAT, right? How much pressure it puts on a person, because for example in our setting we have 100% nursing staff. All the time 20% would be on one or other form of leave, right? So where 100% staff had to be working, only 80% is working, right? And then that puts up a lot of stress on them. And this is the same thing with places like lab, where if one person is off, then the other person has to take care of. While doing that, they have to look for the TAT also, how to perform that within that limits, right? Shift work and irregular hours, this is something which is problematic to everybody, and if some people who are having mental health issues, it's going to be even more difficult, because the circadian rhythm getting disturbed will definitely affect mood, right? That's something which has been well known, and now even though we are starting to abuse our sleep left, right and center, watching mobiles and laptops, right? We have to understand the fact that we have been created to sleep in the night and be awake in the day. Work-life imbalance, I don't need to talk about it. Dealing with diagnostic uncertainty, and this is something which all of you, I am sure, are undergoing because of various reasons. It could be a reagents reason, it could be a machines reason, it may not be the personal reason, maybe. It can happen various level, and this uncertainty leads on to various fear and anxiety from moral distress, professional guilt, and a fear of legal repercussions. And obviously there is an isolation and lack of recognition, because isolation, I'd seen most of the labs are very in a very secluded place or in the basement and AC rooms. It is an isolation basically, and obviously there it is improving, but then there is a lack of recognition in terms of what the lab professionals contribute towards a clinical care. Biological and chemical exposure, quite often it happens, and in I think in microbiology this is a very common entity. And injury and ergonomic risks, Madam has spoken very well. The ethical dilemmas in testing and reporting, decisions on retesting, borderline results, laboratory errors, these are not known to clinicians like us, but then what a lab professional go through is quite significant. This is in a toxic workplace and workplace bullying. This is common across all settings, but these are secluded setting where it is more intense, and job insecurity and contractual employment does result in difficulties. Administrative challenges, this moves from resource allocation, right? It has to be, decisions have to be made which may not be acceptable to people. There is inequitable distribution of resources, supply chain disruptions like reagents doesn't come, or sometimes we order machine because of Ukraine war, it doesn't land up because chips are not available. This happened with us when we ordered certain equipments. Leadership and governance issues. One aspect is about, I hope all of you heard about Simon Sinek. Simon Sinek is one of the leadership gurus who talks a lot about leadership and how it has to be like. So when he was asked in a chiropractic conference that about what advice would he give for the upper management in terms of the patient care and how things had to be. What he has to say, and I quote, he says that the role of the upper management is to take care of their people. When their people are being taken care of, they in turn will take care of the people under them or the end users as such. Because it's very difficult for the upper management to directly manage the patient care and other aspects of care as such. This is something which helped me also in some ways. Policy disconnect, policies don't get passed on to different levels of employees. Workforce challenges, recruiting and retaining people because of varying salaries at different places. People would keep moving around. You train somebody, they don't stay back and they move around. It causes like training gaps and role definition being unclear. And there are quite a few standards are there. Quite a few records need to be filled up, right? This is something which we commonly come across when NABH accreditation or NABL accreditation, our people would come and say that like, we end up in doing this more. And because organizations like us doesn't have HR with us, so nobody will be able to do it. It's only the already employed people had to keep doing it. It becomes too difficult. And there are lack of unified guidelines also. And there is a fear of technology taking over, AI taking over as such. Like how to use it is something which we are still looking at. Specific gender related issues which I had looked at in one of my own colleagues, and I found it very disturbing because there is, because of the course of life itself, there is possibility of break-in services at certain point of time, but they have to be judged at the same level as the other gender also. It's very difficult for them to survive. Pay disparity and implicit societal and cultural biases are noted. This is something which is very peculiar. It often happens in a health professional that both mental health and substance use, if it is there also, their work will not be the first one to get affected. Their personal life, their family life are the first thing to get affected. They will maintain their professional life better till the last extent. And if their professional life is affected, means they are ill. That's very clear. Right? This is something which has been commonly observed across the world. So in fact, it's not absenteeism, it's presenteeism which presents first. where people are not able to perform qualitative work. So move on to briefly the nurturing the nurturer, what can be done as such. There is no single easy technique to change everything, right? There could be personal intervention, there could be workplace interventions per se. In the personal intervention, obviously prevention is better than cure. When you are not well, please ask for help. There is no other rule. If we are not well, we have to ask for help. This is a model which I often use. It's like if somebody wants to learn ballet, they first need to have the wanting to learn ballet. Then they need to have the infrastructure, the flooring and the attire. Then somebody had to coach them and they have to practice. This is the same thing with mental health related issues also, right? I would equate the motivation as the motivation one would want to change, and infrastructure as if there is a need for medications that needs to be taken. Coaching is where you go to a counselor, you work out on some of the difficulties which you have, and then whatever has been taught them us, we have to keep practicing it. The same thing. This is how I view as how our intervention had to be there. Again, this is a concentric circle. The core of our life is our personal space, our personal life. We need to fill that with personal buffers, right? It could be anything. It could be something which we are interested in, we are good at, but they are not profession. We need to have that in our life so that we use that personal buffers when things goes wrong on other things, because these are our own buffers. Next comes the family, right? The family should come before profession. Again, although it is a professional conference, I am saying this because if this goes wrong, then that cannot be good. These two are essential to keep the other one better, right? And learning to keep profession as profession, this is something the health professionals always had struggled with. But more and more what we are facing in both legal realms and other realms, and how we are being socially respected and all, we need to understand this is a job. Other aspect is called as informal mental health care. Not all the time formal mental health care needed. It is only when the person is ill or nearing to ill, then there is a need for referring to a psychiatrist or psychologist as such. But there are informal mental health care available, which unfortunately is deteriorating over a period of time, which includes get enough sleep, take time to relax, eat healthy foods, exercise regularly, spend time outdoors, connect with others. This is something which is not happening because of our mobiles. Say no when needed, create a routine, focus on positives and take up a hobby. This is something which I sincerely believe we all need to have these 5 aspects to keep our personal growth intact or a spiritual growth intact, right? It starts from connectedness, being connected to people outside and people inside. We often not are willing to connect to both outside and inside, and we use mobiles and whatever, YouTube shorts to keep running away from ourselves. Connectedness is the biohack for the future. If we do not attempt at it, we are going to find it's very difficult. Hope and optimism in every step, it's very important. Our own identity is something which we need to be worked on. Meaning and purpose, always people say meaning and purpose. The problem is we create meaning and purpose for our ideal self, which doesn't exist. When you start creating, this is my meaning and purpose, I don't create it for myself at this point. I create it for somebody who I aspire to be, right? So because I create a meaning and purpose for somebody I aspire to be, I am not able to achieve it. Right? So I need to take the yin and yang, the both negatives and positives of me, and create my own meaning and purpose. And empowerment in various aspects is very important for us to survive. And it's not that we can fill everything. These are 5 different sacks. We need to keep putting coins over here. We will never be able to fill it. But together, they would help us to move towards a personal growth. Workplace intervention, this is something I sincerely believe in health profession. The modeling from seniors is very, very important. So this is something which needs to be done on a regular basis. Workload management, I'm sure all of you would be doing this, and sir also had talked about it. Implementing reasonable work hours, working on staff to patient ratio, task sharing, and realistic patient quotas per se. Promoting psychological safety, supervision, mentoring, peer support groups, and open door policies for people to discuss their difficulties. And mental health support, I'm not sure employee assistance programs is there everywhere, but we do have a mechanism now that the telemanus is available. People could make calls to this number and get at least a minimal mental health care, which is there. Like Nimans is the one which is spearheading this work, and it will be matched with the language and region-wise inputs also. And recognizing and rewarding efforts, I've been seeing this quite often happens whenever I visit a hospital. I see that there's a model employee or somebody who has done good. This is happening. So this kind of rewards would also help people. Financial incentives and career advancement opportunities needs to be put in. Ethical and safe work conditions also is important. Workplace wellness program wherever it is possible. This one we started with our nursing staff. We found that there are a lot of frictions between the senior nursing staff and the junior nursing staff where they stop talking to each other. Like, so there's a kind of workshops where a lot of activities together being done. It has helped in breaking the ice with most of them. On-site childcare support, if it is available, is very useful. This is one thing which I am putting it because the World Medical Association's the physician pledge include this. I will attend to my own health, well-being and abilities in order to provide care of the highest standard. And I think this is something is very important for every one of us. So to summarize, too much delay in recognition treatment is not good. So looking at these issues at the earliest, this system should be able to be geared up to address the deficit. Tailor-made intervention or personalized intervention is important. Clear approach to real-time monitoring during aftercare management. This is something which not very relevant to this presentation. Jack Dorsey has said this: the greatest lesson that I learned in all of this is that you have to start now, start here, start small or start simple. Keep it simple. This is something, there's no alternative to it. Always listen first. I have two people to thank. One is my wife, Dr. Shanti, and then the drug toxicology services of Center for Addiction Medicine in Mahans also, because I don't work there, but I do the budget controlling aspect over there. Thank you. Any questions? I'm happy to discuss.
Thank you so much, sir, for addressing such a profoundly relevant topic in today's demanding healthcare environment. As a token of our gratitude and appreciation, we kindly request Dr. Manjula, HOD Department of Hematology, Apollo Hospitals, BG Road, to do the honor of presenting memento to Dr. Arun Kandaswamy. Now, before moving forward, we are delighted to share some exciting news. The 12th International Patient Safety Conference will be held in New Delhi on 21st and 22nd February, and all the participants attending the CME are eligible for an exclusive 50% discount on registration fee for that conference. Thank you.
Finally, we approach the final session of the day. We are excited to present a panel discussion on a topic that is becoming increasingly central to the future of healthcare, the clinical laboratory, a decision-maker hub. In today's healthcare environment, clinical laboratories are no longer just places for testing. They have evolved into vital decision-making hubs that play an integral role in shaping patient care outcomes. We are honored to welcome the following panelists: Dr. Vijay Agarwal, Lead Medical Oncologist at Apollo Hospitals, BG Road; Dr. Ashish Shah, Director of GI Surgery at Apollo Specialty Hospital, Jayanagar; Dr. Rajiv Mogar, Senior Consultant in Internal Medicine at Apollo Hospitals, BG Road; Dr. Himal Dev, Chief Consultant in Critical Care Medicine at Apollo Hospital, Seshadripuram. And we are fortunate to have Dr. Nivedita, Professor and HOD of the Department of Pathology at KIMS Bangalore, as the moderator for this session. She did MD Pathology from Lady Hardinge Medical College, New Delhi. She is a passionate undergraduate and postgraduate teacher for past 25 years and believes in creating ethical, committed pathologists. She is active in research with 50 publications in national and international journals. She is committed to ethical and professional pathology services to aid patient care. With her vast experience in pathology and healthcare, Dr. Nivedita will facilitate an engaging and insightful discussion. We look forward to a thought-provoking session that highlights how clinical laboratories are evolving into indispensable decision-making hubs in the medical field. Now over to Dr. Nivedita, ma'am.
Panel discussion was to meet my senior, Dr. Ashish. I'm your junior from Bangalore Medical College. Yeah. So that was, and also I know many of the panelists because they are more like family. Dr. Arun Naik was working here for some time, so many of them I know personally. I have a PPT presentation. So before this, I think we have all veterans who spoke extensively about lab safety. And this, I have tried to make it a fun session because as Dr. Tupil said, this is a postprandial session when it's difficult for the listeners also and difficult for the speakers also. So I have tried to make it as fun as possible. I hope you'll enjoy this session with the esteemed panelists on the dais. I think all lab professionals now, we have moved from earlier we used to be telling them what has already happened to now for some years we moved into diagnostic hubs. And for some time we are talking about prognosis, and now we are having an say even in the treatment aspect. I think we decide some of the things in the lab. So I'm very happy to agree with Dr. Tupil, as we are super specialists where we are guiding the clinicians, and the National Association of Pathologists also now recognizes pathology as a clinical branch. So the labs are back. So I think this is this inquisitive nature that we have, all lab professionals, that has led to this promotion from being only diagnosticians to becoming people who have say in the treatment of the patient. And no wonder this lady is quite unhappy with the detailed description of her way in her safari. And also I think now that precision medicine has become an important aspect of patient care, I think all of us have to be very precise. I think a lot of talking has happened since morning about lab safety, and I think this session will more so focus on the patient safety, because we have to give an appropriate and accurate report which indirectly tells us about the patient safety. So if you look at this picture here, lots of things are here. Diagnostics are tailored diagnostics, precision medicine, personalized medicine, all this, and lab professionals have a very big role to play in this.
I think this is the bridge we are all trying to cross. The clinicians are on that part and we are on this part. We are trying to climb this bridge to come to you so that we all give, all our aim at the end of everything is to give patient care. And I hope whenever we fall down in this pond, clinicians will provide a boat and a navigator and pull us up by giving appropriate information. Yes, sir. Okay, so we have a set of, most of the presentation is through a set of cartoons. I hope we will be able to break the ice. I think patient safety, as I said, we are talking about safe reports for the patients. The first aspect which I would want to focus is reliability and accuracy of the reports. So, anybody? So Dr. Vijay Agarwal can take this question, sir. What is a clinician's role in helping us to give an appropriate or an accurate report?
Yeah, I think providing clinical information on the patient is probably the most important job for any clinician. And I think I have to accept that most of the time we don't do it very well. And I think filling the pathology form to its full brim and literally asking that this patient had breast cancer before, is this a recurrence or not? I think that kind of information needs to go through. A lot of time we just ask the radiologist to do the biopsy and the material comes to you with no idea as to what's really happened. And a lot of time you're calling on clinicians and you may not get access to the clinician. And I think having a more detailed form where the clinician actually fills in the form and says these are the bits that are there. I know nowadays we have EMR and easy access to some of the clinical information, but a lot of the patients come from outside with information not really in the system. So I believe that clinical information is probably the most important information you can get.
Thank you so much, sir. I think Apollo pathologists and Apollo lab professionals are very lucky to have clinicians like you who take so much of interest in filling up the forms. Thank you for that. And do you have any idea about what are pre-analytical errors? Dr. Rajiv can take this question. Pre-analytical errors. Do you think for an accurate lab report, suppose we don't, you don't expect an accurate lab report that you expected, there is a role for pre-analytical errors?
Yes, the clinical history is very, very important because when we anticipate, to give you an example, if the patient is healthy, if you do a CBC, if the counts are less, we take it as a bone marrow failure or aplastic anemia or a deficiency disorder. Similarly, if the patient comes with a history of fever, myalgia, the clinical syndrome is suggestive of a viral infection. If the counts are less, we go in favor of a viral infection, temporary cytopenia rather than a bone marrow problem or a deficiency disorder. So there is some pre-test probability is also important. That is where the history is most important. If the test, when you are asking for a test, if you are strongly suspecting, then you are thinking of ruling in the possibility. And sometimes we do ask for some tests when we are not really strongly suspecting, but to rule out a possibility. In these situations, the report, the clinical history is very, very important, and the pre-test probability is also very, very important.
Do you think there may be a problem, Dr. Vijay, would you agree that if there could be any other problem other than the history in sample collection?
I was expecting to answer this question. So I'm a critical care physician.
Yes, sir.
I'm Dr. Himal.
Oh, I'm sorry.
So what happens is my role would be, the first thing is to send the sample accurately.
Mm-hmm.
To give you a fair bit of example, while sending a blood culture, if a nurse is not well trained and she pricks in a wrong area and sends a contaminated sample, and the lab cannot do anything about it and they report it, and finally we end up treating them inadvertently. It's not required. So the best thing is to, from clinician's perspective, is to train the nurse.
Yes.
And send the right sample. Not only that, if suppose a sample comes and gets repeatedly hemolyzed, I think the clinician has to decide. I think nowadays we go with a lot of numbers. I think you should stop doing the number game and look at the clinical perspective and balance it out. and probably talk to the pathologist and say why this patient is probably getting hemolyzed, is it the right sample? Another one is getting the wrong values, accurate values. The INR comes 3, patient is absolutely stable. I saw the patient is impossible to get an INR 3, I want to do a procedure on him. Send a repeat sample, talk to them, have I sent a wrong sample? I think that's where the bridge is very, very important in this aspect.
It's not only the wrong sample, it could also be the way the sample is collected even for coagulation profile. Yes, I think those are, I agree with Dr. Himal when he says that we have to train because we cannot oversee every single sample. I think repeated training, I think the other speakers also emphasized on this, repeated training of our paramedical staff is very important, because once the sample comes to the lab doesn't have any way to understand how the sample has come to the lab. Yeah, I'm glad that you brought out that point, that we should have adequate, probably repeated training, and whenever there is an issue, it is always better to find out. I think this happens even with platelet counts. Because samples, when they are not mixed as soon as they are collected, or if there is some issue with the collection, because many labs are not still following the Vacutainer system. So many times we do have this problem when we were not having the Vacutainer system, that if the nurse has not been trained to mix the sample properly, we could get pseudothrombocytopenia, especially in the cool tub. So the lab also will have a protocol whenever there is a cutoff of less than 1 lakh. We do a manual peripheral smear to cross-check it. But at the same time, the clinician also should be aware that these are the pre-analytical errors for which you can at least call us back and confirm so that the patient has safety is maintained. So I think Dr. Himal will be the one who will be always looking at this TAT time. So I think this TAT time, what is your input on this?
I think this forms the foundation of personalized patient care. Though we might be very pushy to get the reports, I think there is certain TAT time where you can't extend certain.
Yes.
But before I send any investigations, I think the first thing is I need to know and to tell the patients and patient relatives that this is the time I expect the report and my treatment starts from there. And not only that, even the cost also part is very, very important, because unless I know the cost and I order it, and the patient has to suffer. So there are those two things. And TAT time is very, very important. To give an example, these are routine problems which we face. That's what I'm bringing it to you. There is no conflict of interest here. Our pathologists are extremely good. Our lab is one of the best.
No, sir, we all love our clinicians.
Yeah. So what happens is some tests which goes outside the hospital, there has been a lack of communication awareness when you are going to get it. Probably the main pathologist or the lab person may not know when it is happening, or the assistant. The clinician may not know, and ultimately in the end, the nurses also do not coordinate properly. So there is a lack of communication from the top end to the bottom end. And we keep on delaying it. Finally, sometimes we don't check it also. So I think that communication part is very, very important to trace the reports and follow it up. But some tests are really, we need to have the faster TAT time so that we tailor our medicines also, especially the drug levels and the microbiological reports, especially the blood cultures, blood PCRs. So we do have something called as a blood PCR technique, which has become workflow in the hospital. Suppose a patient we get a blood culture sample, you don't have to ask any physician as a microbiologist. It runs as a workflow. It flashes positive, they run it through the PCR, because the management has been kind enough to agree to do that test for almost all the patients. So we get the test result by 12th hour, and there is a WhatsApp program, and immediately it flashes. Even at 9 o'clock in the night, if blood culture is positive, the resident can change the antibiotic or de-escalate the antibiotics. So that TAT time is very, very important. Reduces the cost of the stay, reduces the length of hospital stay, reduces the length of ICU stay as well. So but we are a bit pushy, but I think there are some drawbacks about the TAT time. I think Dr. Vijay will be aware of those pathology reports, which takes a lot of time,
So we would like to have your inputs, Dr. Vijay.
I have to say in Apollo we're very, very fortunate, because our path team is excellent. And we don't really struggle with TAT for the in-house testing. And all we have to do is just call. And if they know, they may look at it, or they'll just say that I'll call you back in so and so time. And they're usually very, very proactive. The issues come around outsourced tests. There are certain tests that are outsourced which are very, very difficult. Everybody has to follow organizational policies. To give you a simple example we use a lot of high-dose methotrexate for patients with osteosarcomas and lymphomas, and we need to send a sample in the morning and get the report in the afternoon and modify the folinic acid by evening. And I think there are only 1 or 2 labs in the city who does that, which will give you a TAT of a few hours, and most of the others will give you after 3 days.
Okay.
Now, if your organization does not have an MOU with those labs, you're kind of stuck. And a lot of these patients have insurance, so they end up paying direct money to those labs because the MOU does not exist. So those operational issues are there. That
One answer, so simple, it anti-chromic deficiency. It's quite common. This should replace the vegetable plasma and then the so that is what is important. So you learn from others, you learn from them, you don't know everything. That's where the communication and asking for help is very, very important. So clinician doesn't know everything. There are specialists who know in their specialty what is best, take the help and treat them well. And regarding the accreditation, the internal accreditation is also very, very important. I think probably you need to have the protocols, the in charge of the lab and the regular recalibrations of the machines, whether the machine is working or not. Those things are pretty much important. So to get the accurate reports.
I think even without, accreditation is very important. As I think Dr. Anand also brought out that point, that modeling experience is also very important aspect. I think that is internal accreditation. So every person who is there in the lab profession or whether, I think we have to show that we can communicate with you, or we should not let our ego get under us with our juniors. So they also learn this and not be like, we cannot be two different compartments and think that pathology is super specialty and emergency medicine is super specialty. We have to come in between, and the bridge was the ideal thing that I think both have to come halfway to meet them so that the patient is safe and we can safe.
Another important thing is to maybe involve yourself in the audits.
Yes.
The physicians go to the laboratory audits and see what are the problems and how they troubleshoot, how we do it. Then only we get to know what is happening.
Yes.
Otherwise, it's out of the lab, you not know what is happening inside. So better to converge and then discuss, in single parts.
Dr. Rajiv. This is an AI-based smart report. I think every patient would love to have a report. Do you think it is okay to have a report like this?
AI-based smart reports is it's like started as a marketing gimmick. That's what I used to feel when I used to see those reports in the beginning, because I am more used to this PDF format,
Traditional
format, patient doctor format. When the patient come to me with some 30 pages of report with all the interpretations, the suggestions, and other things, I used to go where is the PDF format. Because I was more familiar with that. We generally don't go out of our familiar area. We feel more comfortable with what we have been doing. Anything new, brain tries to resist that. So now I'm slowly getting adjusted to the new report. In fact, it is quite good. It gives a pattern also. If they have the data of the previous reports, they analyze that and they give us a trend. And they also give us some suggestions, and sometimes it may make your work a little lesser. If someone has high uric acid, there will be a list of things they should do to reduce uric acid. Now I am slowly changing my perception that this report is needed, it is very useful. Because the AI is touching our lives in many ways. I have one friend who is working for Caterpillar's USA-based company which deals with heavy machineries and all. Sitting in Bangalore, he assesses the health of the machine that is working somewhere in some mines based on its temperature, fuel consumption, noise, vibration. He can predict whether that machine is healthy or it is going to break down, and if it is going to break down, in how many weeks it is going to break down, which part he needs to replace it. So he knows all those information sitting in Bangalore because of the AI and the millions of inputs he gets. So probably we will also get similar inputs on our health related data.
Scaring people?
It has to go pros and cons.
Be careful.
Yes. It is both ways. If it scares the patient may take better precaution, and sometimes it may be unnecessary scare. Like Dr. Kapil was saying, in future days, there will be a chip inside you, and the AFS report will be generated without undergoing any actual blood test.
Maybe all of us will be out of jobs.
All of us will be out of job, maybe or may not be. If you don't use
AI in your practice, definitely you are going to be out of job.
Yeah.
Whether AI replaces you or not, I don't know, but if you don't use AI, you are going to be out of job.
You have to inculcate.
You have to. There is no other second thoughts about it. Maybe in the future, if I give a CBC, you will get to know whether this patient is going to develop leukemia or not if they have the data to compile.
I mean, just a small disclaimer here. I like winter, that's one. Second, I'm going back to the parathyroid gland, but for the audience, I do know organs other than the parathyroid. But it fits in perfectly here or when we're doing a cancer resection. And you've seen the hair, so obviously I come from an era when frozen section was not so easily available across town. And sometimes when you send for a frozen, you freeze in the OT with those temperatures and it's about 2 hours before something came back and you didn't know what came back. So thankfully now it's no longer the way. The only urgency in the calls are is a petrol in the bike, is a guy on the bike and the sample reached him. And let's look at the parathyroid. As pathologists or histopathologists in the audience, I mean, the three things that we can't as surgeons differentiate typically is the parathyroid gland, a bit of fat, and a lymph node. And when you guys look at it under the microscope, you must be saying this guy's cuckooing is very, you can't differentiate between the three. But I mean, that's where this comes in handy. In half an hour or 20 minutes, you know what you've removed. And there was a time when you would close up the patient, wait for the formal report, then tell the patient, I'm sorry, we need to reopen. So, I mean, this is a godsend.
So, do you think frozen section is overutilized? Say, I mean, like especially we get these difficult situations sometimes because I find it very difficult to digest. Sometimes, especially in breast carcinomas, etc., when they ask for frozen, it's very difficult proposition for a woman to not know about having a mastectomy versus a lumpectomy prior to the surgery. That is, some cases I feel it is little overutilized. What is your thought on that?
So probably there, the issue is with the preoperative counseling. If you've had a good discussion with them, then you discuss the pros and cons of all the possibilities, the operative possibilities and the permutations and combinations that arise once the frozen section comes in. Then probably that doesn't come up. But otherwise, not only breast cancer, agreed, it's an ablative surgery at times, but most cancer surgery, where you're asking for a frozen section, then you're in trouble.
What is your input on inconclusive reports? I talk to everybody. Many times I think our professionals are at a situation where I think many of us, I've been in pathology for 26 years now, so I have many times written an inconclusive report. So how do you deal with it and how do you?
You can't know everything, isn't it?
Yes, we can't.
So I think that's when you need to have a clinical acumen better. I think have a good patient history and patient's profile and see whether it matches or not. And if required, probably retest it and see whether it is matching your reports. But don't jump on it. Probably have a multi-discussion, probably discuss with other specialists and find out what exactly is happening. But yeah, so.
I think in this inconclusive report, pre-analytical issues also come up, a proper filling of the form also comes up, proper information also comes up. Many times, lab professionals are conversant with the clinical conditions, but probably because they are not given information, that we are always running behind these forms and asking information, especially in setups where there is no good laboratory information system where you can sit at my desk and access the biochemistry report or your history report. I think a lot of inconclusive reports, in my opinion, would come down if that part is taken care of by the clinician.
Your communication from the clinician.
Yes, yeah, it will help us.
It's not like it's too much of a work to call somebody and give inconclusive.
No, sir, we love calling clinicians. In fact, as you said, whenever, I'm sure all pathologists or all lab professionals will agree, when lab professionals walk to the, when clinicians walk to the lab, there is a glee in lab professional, whichever lab person, we usually say, surgeon has come down, it's the red cup. So that's how it is. We like to have you in the lab talking to us, going for coffee. That would be wonderful to have a good team understanding.
Red carpet is only for surgeons, not for oncologists. So we do ask for the help in case suppose there's a difficult case situation or scenario. We do talk to the other, I'm sure you also do the same with other specialists.
And I think every lab professional, especially in pathology, before we give an inconclusive report, I think if there is a group of pathologists, we all look at it before, because nobody wants to give, it is like, viewers don't like to give something inconclusive. So it would have gone through the process. So I think communication would be of very good help.
In oncology, I think with inconclusive report, I think the first thing is not to panic, even for the clinicians.
Yes.
Because there's a reason it's inconclusive. And I think there are certain results that are meant to be inconclusive. For example, if you're doing HER2 tests, equivocal test is not an inconclusive. It's a positive report to say it is equivocal. Please look for the
Please go for the test.
Or there's certain genomic testing that we do, and we end up getting a rare mutation, for example, a red mutation. And then we have to confirm it twice. So it's not an inconclusive test, but it is perceived as inconclusive. And I think we need confirmatory tests to do that. The second reason why the test can come inconclusive is because there's not enough tissue. You've not got enough tissue for confirmation. You're not able to do IHC to confirm it, so you can report it inconclusive. Sometimes the controls don't work, and those times the reports are inconclusive. And of course, a lot of times we've not provided the information. The report comes as could be hepatobiliary upper malignancy. This is breast cancer. How about telling me that first before you set the sample? So yes, so those are issues. But of course, we do get inconclusive reports, which are true, inconclusive in the sense that I don't know what is happening with you. And I think that is the time the MDT is very, very important, where we all get together and try to connect our heads to find out what is happening. A lot of times, radiology gives us the answer, the pathology may not be able to give. Occasionally, second opinions help. If a good pathologist cannot identify it, it's unlikely that someone else will be able to identify it. But it gives the patient the confidence that it is truly inconclusive. Multiple people have seen it and said exactly the same thing. So it helps them cope with it better. So there's no easy way to deal with inconclusive reports. I think we just need to find why it was inconclusive and just give the report to the patient as best as we can, and let them decide what they want to do with it.
I'll go back to one statement you made saying that if the surgeon goes to the lab, then, the red carpet. When I go to our lab, it's like Piyakudri. I mean,
You should arrange for the red carpet.
But, these guys are both Himal and Vijay have spoken about the scientific aspect of the inconclusive report. But something that, when you pick up the phone and say, look, we're not sure, that's a lot of confidence. And it is better than giving something because something has to be given. And I think that's important. And there really can't be a hierarchy in clinical care or, in healthcare, in this way, in patient care. So I don't think just because somebody is in the lab, they should feel that in the hierarchy they're lower, or vice versa for us. I mean, at the end of the day, we can't do much without the lab.
Thank you so much.
So molecular genetics as cancer screening.
Do you think, this is quite do you face patients asking you for the different genetics when you advocate?
So when we talk about genetics, of course, there are two aspects. One is germline, profiling the one just mutation.
Yeah.
I think germline is quite ingredient in the system. I think a lot of people do it. We have clusters of cancer families, we speak to genetic counselors, one, and genetic counselors through pre-testing screening and breast ovarian syndromes, those already pre-established genetic testing, and I think there's a SOP for that, and I think everyone's aware of how to do it, and that kind of goes, and that I promote, and I strongly encourage patients and their family members to undergo it with the standard criteria. The other ones that are currently, some of them commercially being promoted are liquid biopsies, cancer screening, to look at somatic mutations to see if we can identify cancer earlier than it actually presents. I think as a concept it's fantastic. I think it would be great if you could do something like that. But the clinical validation is currently lacking. So it is not something that I am currently promoting. I might change my views in the future because I think the concept sounds nice. The challenges that we will currently face by promoting something like this is that if the report is negative, are we absolutely certain that how long is it going to be valid for? So are we doing it monthly, quarterly, yearly, 5-yearly? I mean, we don't know that. Second thing is if it is positive, does it really translate into the cancer? And even if it does, when? The thing about cancer screening is that the reason why you don't screen all the cancers, there is still only a few cancers, is that you can intervene to alter the outcome. Yes. For example, if you've got breast cancer, you undergo mammography every 3 years, you catch it early, you can intervene and improve survival. And you don't know that same thing will exist. Or something like evaluating a somatic mutation in the biopsy. So if you can't alter the outcome, I think currently as it stands, it could cause a lot of stress for the patient and the family. So it's not something that I'm currently doing. But I understand the concept, and I think if things change in the future,
This great genetic part. So that's actually a double-edged sword. And at least in our ICU setup, we do the PCR test. It comes with its own cost, but it's very, very helpful. You get the reports immediately. The only thing is, it's not always something is positive, it doesn't reflect the clinical situation. It can be genetic, but not clinically manifested one. So that is one aspect of genetic testing. So coming to this, lab reports in confirming diagnosis were it helps in both. Definitely confirms the diagnosis, reassures us that it is a possible diagnosis, and also definitely this diagnosis requires this treatment. I think that's quite clear, isn't it? There is no question about it.
I think this is a question to all of you can give an opinion. What advances are you expecting us to speed up the diagnosis, treatment planning, and faster recovery for the patients? I think Dr. Raji would agree with the smart reports, the role of AI. Still, the AI takes over, sir. Any suggestions for lab professionals to make?
Yeah, one is like molecular analysis, PCR can test. See, as a physician, particularly when we are doing these infectious diseases, most of the tests are antibody-based tests. We all know that the possibility of getting a positive antibody-based test in the first week of the illness is very less. And if the test comes negative, we can't really take it as negative because the person may not have mounted an antibody response to the given infection. So the micro-based tests like the PCR test, if it is easily available and affordable, yes, that will be more
less costlier.
Yes, more useful actually. We need tests definitely for diagnosis and confirming our clinical suspicion, and sometimes we strongly suspect something and the test comes negative, that makes us think what else it could be. So to get us some leads also early and less turnover and more accurate test reports are very, very essential.
The important thing is, I think, if you need extra machines and extra equipments, I think discuss with the clinicians and talk to the management and get, for example, PCR cells, it's very expensive, but I think you can work around things and you can, if you do a large number of patients, you can actually cover
cost comes down.
For example, one PCR test is around 15,000. You can work around make it around 8,000 for all patients.
Like how it happened during COVID. Initially, it was so expensive. When it came down, when massive tests were going on, it came down to quite 1,000.
Another thing is be persistent, like pathologists, for example, I've heard, I think when you do a biopsy of the lymph node, I think if you want to do an RT-cell, TBG next to it, you need to preserve it in the, not to preserve, preserve in the
Cell, right, you have to put it in the cell.
It keeps on happening probably because of the awareness of the juniors who does it. Multiple times it has gone with a non-informant. I think you need to talk to them repeatedly and tell them this is problem. That's why you need to be persistent. Be gritty and be persistent.
Yeah, I wish I didn't have to outsource the tests because our lab functions at a very high level. It's not expected the same high level of efficiency from the tests that we've outsourced. So I think doing more tests in house will certainly help our patients, both in terms of prostate and recovery. The other thing is for education, it's constant communication, and I think are we having EMR where the clinician, the pathologist can access data, even if we are not providing it. EMR would really help for not just for our organization, but across the board to everybody. So that would make seamless communications slightly better as well.
Thank you for taking the last. So in a multiple choice, A, B, C, and D is all of the but I'll just add one point, which goes on the lines of what people said. Communication without hierarchy. And that's what solves most of the problems.
What I agree is that it's very simple. The advances for expecting faster results is not very. It's very simple solution which lies within us, and I think we all should work together as all of you have said without hierarchy. Probably we should not be working like this. Each one looking at something in a different way so that we get a different output. So all of us. So all of us should be working together. Only then we'll discover the elephant in the room. Otherwise, we'll be making our own assumptions. So I'm so thankful that it was such a wonderful discussion. I hope I try to figure out whatever questions there from a lab professional point of view, and I hope I didn't offend you in any way.
You said that's fantastic.
Thank
The slide was so well done.
Thank you so much.
A big round of applause to Madam. And thank you, you made this across the servers of all the specialties and to discuss it. It was a really enjoyable.
Thank you.
Wonderful.
Thank you.
How did you mind these slides? How did you mind these slides? I said, hey, it's very nice. Very nice, very appropriate.
Thank you. I think, communication without hierarchy is teamwork. Teamwork makes dreams work. Thank you all so much. That's my talk's nothing.
Thank you.
I thank Dr. Swarna for giving this opportunity. She literally pushed me into doing this. I kept on telling I have something else. She said, I am not holding the panel discussion, you have to moderate, and just switch off the phone. So I'm thankful for this opportunity because I got to speak to a lot of esteemed panelists and esteemed audience. Thank you so much.
Thank you so much to our panelists and moderator. On behalf of the organizing committee, I would like to extend our heartfelt gratitude to all the distinguished panelists and the moderator for their valuable contribution during today's session. As a token of our gratitude and appreciation, we kindly request Dr. Swarna Sivakumar, Lab Director and HOD of Histopathology Apollo Hospital, BG to do the honor of presenting mementos to our panelists and moderators. And second case goes to sample tracking to improve patient safety, presented by Dr. Kritika. Dr. Karthika. Dr. Karthika and Dr. Saishta Jahan. I think unfortunately they are not present here to receive the memento. We will make sure the memento is delivered to them on time. The first place goes to the poster titled Risk Management at Sri Shankara Cancer Hospital and Research Center Lab Services by Mr. Lakshmikant S. Reddy. I think unfortunately he is also not available at the moment to receive the memento. We make sure we will send the memento to him as early as possible. Thank you, ma'am. Now, as we come to the end of the program, I would like to call upon Ms. Pragati, Senior Executive from Quality Department, Apollo Hospitals, to deliver her vote of thanks. Good evening, all. It's both honor and a privilege to deliver the vote of thanks on behalf of the organizing team of Apollo family. I would like to extend my heartfelt gratitude to each and everyone present in this hall and to make our 12th International Patient Safety Workshop a grand success. It was on laboratory safety or resounding success. This event would not be possible without the dedication, expertise, and the contributions of many individuals and organizations. Our sincere thanks to all the speakers, moderators, my special thanks to my all quality team, my lab heads of Karnataka region. We also extend our thanks to our Apollo Hospital senior leadership, Dr. Manish Madan, CEO, Apollo Hospital, Karnataka and the Central Region, Dr. Rohini Sridhar, Chief of Medical Services, Apollo Hospitals, along with our IT team, marketing team, housekeeping team, all the members of our Dream Park who was with us, and last but not least, all the sponsors and delegates who participated in this event. Once again, thank you for being a part of this event, and we look forward to seeing you at our future program as a collective journey in our 12th IPSC conference that is on 21st and 22nd of February 2025 in Pragati Maidan, New Delhi. Please register yourself for the conference with a 50% discount, which was for today, that is 2,500, and hope to meet you all once again. Thank you again for your invaluable contribution. Please patiently collect your certificate, which is arranged in alphabetical order.
Feedback.
This is the scanner for our feedback. Please give your feedback for today's workshop.